court fees.
Your voice is not audible, madam.
Yes, sir. Madam is on call with me. Yeah.
Achyut? Shyam, can you hear?
Yes, ma'am. Loud and clear, ma'am.
The faculty group. People are joined. Let them ask them to think. For one be on mobile, join on.
నెట్ ఇక్కడ చూడు ఏది కనెక్ట్ అయిందో
Thank you.
Good morning, Maithili ma'am.
Yeah, good morning.
Yes, ma'am. We are
Am I
expecting.
visible?
No, no, ma'am. You have to turn on your camera.
I did. Wait 1 minute.
It's dark as well.
How come? Now?
No, ma'am. It's still pitch black.
Okay, I'll change the laptop.
Sure, ma'am.
Yeah, am I visible?
Yes, yes, ma'am. You're audible, ma'am. Good morning, ma'am. We are
Is
expecting
it
more
too bright
people.
or okay?
No, no, it's wonderful, ma'am. It's wonderful.
Yeah.
Yeah. So we'll wait for other panelists to join, ma'am, and then we can proceed with the day one. Yes.
Hello, madam.
Hi, Ramani. Good morning.
Madam, welcome to this IMA AMS conference, madam. It's an online conference where 1,880 people have registered. And I think Dr. Ravindranath sir, are you there? Dr. Ravindranath sir?
Yeah, I'm there, madam.
Achyut? Achyut? Can you call Achyut Ravindranath once?
Yes,
I have
ma'am.
asked.
Ma'am, we're calling
Shyam?
them. Yes, ma'am.
Please, sir.
We're calling
So
Archit.
now shall we start the conference? Ravinder, as a moderator is there, I just want to invoke a prayer. I'm not a singer, but I just want to little bear with me. I want to sing a song on Ganapati for 1 minute, and then we'll start with your session, madam. Okay.
Sure.
महागणपतिं मनसा स्मरामि महागणपतिं मनसामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं स्मारकोटिप्रतिष्ठं शान्तं महाकाव्यनाटकादिप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं मूषिकवाहनमोदकप्रियं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि. Madam, this is now the stage is for you. I welcome all the delegates, the panelists, the moderators and the speakers of this IMA AMS AP State online conference, the sixth one from from the inception of this team of IMA AMS. We have a 17 board team. So we've been conducting monthly seminars and all. So this meeting is particularly a free online meeting where 6 credit points are given, and there was a tremendous response. As you all can see, more than 1800 have joined on this. I welcome the first speaker, Dr. Maithili P. Maithili Madam, who is a retired professor of Andhra Medical College of Endocrinology Department. She's a very good friend of mine, more than an elder sister for me. She is a good academician, and we are very much pleased to have you, madam. And I now request the moderator, Dr. Ravindranath, who is young, energetic, dynamic finance secretary of IMA AP State, to moderate the session. Thank you, ma'am. You can share your screen and start. I also welcome Dr. Achut, who is the observer from the MCA, AP MCA of this online conference. Welcome, Dr. Achut. Ma'am, you can start, ma'am.
Hello, everyone. Is my screen visible?
Yes, ma'am. It is visible. You keep in slide share mode, ma'am.
Okay. So, a very good morning to all of you. I'm indeed honored to address the members of the Indian Medical Association and thank Dr. Ramani for the kind invitation. So Dr. Ramani asked me to speak on current practices in the management of type 2 diabetes. So this is a very apt topic chosen by her. The reasons being, we have a better understanding of the pathophysiology of type 2 diabetes. We have now numerous treatment options. We have advances in technology, which are all helping for better management of type 2 diabetes. However, our challenges remain. The biggest challenge for us in India is the huge burden of people with diabetes. So as we are number one in the world's population, shortly we are going to be number one in the number of people with type 2 diabetes. And if you look at the global contribution by India, India carries nearly 17% of the global burden of diabetes. And we have a good number of people with pre-diabetes also. Now, looking at the bar diagram, you can see that the trends in the diabetes prevalence over the last decade has been increasing. And this increasing trend is again a cause of concern because we will have huge numbers shortly. To add to all these challenges, in India, our biggest challenge is young onset of diabetes. As young as 20s now, we have type 2 diabetes, both men and women, lean and obese. We have a good number of people with undiagnosed diabetes. We have a high incidence of pre-diabetes, and the concern about pre-diabetes is the high cardiovascular risk. So these people have the same cardiovascular risk as those with diabetes. We have the epidemic of obesity and the higher rate of diabetes-related complications in India. Now, further on, the challenges in the management of type 2 diabetes are depicted in this slide. As you can see, there are three important parameters that are measured. One is the glycemic control. 77% of patients with type 2 diabetes across India have an A1C of more than 7%. So that is to say that majority have uncontrolled diabetes. The burden of overweight and obesity, 88% of people are overweight or obese at the time of diagnosis. And the high cardiovascular burden, today Southeast Asia is a tsunami for cardiovascular disease, and India contributes to the major burden. More than 70% of people with type 2 diabetes die of cardiovascular causes. Now, having mentioned these challenges, now I move on to the current topic of practices in the management of type 2 diabetes. What I wish to do in my presentation is to give a bird's eye view of the current pharmacological management and the management of diabetes complications and comorbidities. So I will first discuss the pharmacological management of type 2 diabetes and then move on to management of diabetes complications and comorbidities, including cardiovascular risk factors, hypertension and dyslipidemia, cardiorenal protection. Today, when we talk of diabetes, we say cardiorenal protection, protect the heart and the kidney, prevent cardiovascular disease and chronic kidney disease, and management of obesity and NAFLD. Now, before moving on to pharmacotherapy, most important is lifestyle therapy. This is the cornerstone of management of type 2 diabetes. And unfortunately, this is really not practiced by people in India. As far as nutrition is concerned, physical activity, sleep hygiene, behavioral support like alcohol in moderation and smoking cessation. It is important for us to emphasize on a healthy lifestyle, a proper nutrition, avoiding trans fat acids, limiting saturated fats, reducing carbs, and most important is at least 150 minutes of moderate intensity physical activity, including 2 hours of strength training per week. A sleep hygiene of at least 6 to 8 hours per week, and alcohol in moderation and avoiding tobacco. These are the lifestyle measures which need to be practiced for prevention and treatment of type 2 diabetes. Now, the pharmacological approaches to glycemic treatment include many now. We have around 11 to 12 molecules in the management, and this is really confusing. And the basis for the number of molecules is the better understanding of the pathophysiology of the disorder. Now, when you see this diagram, you have hyperglycemia in the center. And what is contributing to hyperglycemia? Previously, we were only discussing about the insulin secretion, which is less by the beta cells. But then today, you see, we have so many different organs. There is an alpha cell defect. So in the pancreas, in the islets, you find that the alpha cells produce glucagon. There is not only a decreased insulin by the beta cell, but there is an increased secretion of glucagon by the alpha cell, which contributes to hyperglycemia. The next important organ is the liver, where the liver produces more glucose, contributing to high blood levels. A neurotransmitter dysfunction at the level of the brain is responsible for hyperglycemia, decreased glucose uptake by the muscle, and increased glucose reabsorption at the level of the kidney. And the insulin resistance in type 2 diabetes is contributed by increased lipolysis by the adipose tissue. And finally, we have the gut in the intestines where the incretin hormones are defective and they lead to decrease in the glucose secretion. So the message of this slide is you have multiple drugs acting at each of these organs. You can see that, for example, if you look at the liver, you can see that these are the drugs that the pioglitazone, metformin, and the GLP-1 receptor agonists act here. And at the level of the brain, we have other molecules. At the level of the kidney, we have the SGLT2 inhibitors. So the number of molecules are many. And, we can combine molecules. We can address different pathophysiological defects so that you have an optimal A1C achievement. Another important change in the management of type 2 diabetes is the early combination therapy. Now, previously, we were only talking about, start with diet. You can see this diagram where diet was started, and after a few months, metformin was added, and after a few months, you add one more drug, so on and so forth. Today, we do not use this approach. Our approach is an early combination therapy. We want a legacy effect. We want the metabolic memory. Achieve A1C faster, and then you have a good legacy effect. So early aggressive intervention provides more rapid glycemic control and prevents complications. Well, this is a very busy slide. I will try to simplify. Now, how do you choose an anti-diabetic drug in the management of type 2 diabetes? So we all know number one is lifestyle therapy, and the simplest drug that is chosen by any doctor, any clinician is metformin. We do continue with this option, but then what is the next drug after metformin? It all depends on what the patient's problem is. If you look at if the problem is the cardiovascular disease, heart failure, or chronic kidney disease, if this is the major problem in the patient, you add drugs like the GLP-1 receptor agonists, the SGLT2 inhibitors, which reduce cardiovascular events, which reduce the progression of chronic kidney disease, which reduce heart failure hospitalizations. So this is how you choose the second drug. Suppose patient doesn't have cardiovascular disease, no heart failure, no chronic kidneys. How do you choose the drug? Now you see, if the patient has a compelling need to minimize hypoglycemia, today a busy doctor, a busy politician, anybody for that matter, nobody with a busy lifestyle, nobody wants to have hypoglycemia. So this is the major choice of the anti-hyperglycemic agent. And for this reason, sulfonylureas have taken a backseat. And then the next option is the patient obese? Do we have the need to minimize weight gain? So, or, promote weight loss? Choose anti-diabetic drugs which reduce weight, like the GLP-1 receptor agonists and the SGLT2 inhibitors. And finally, if the patient is a poor patient where cost is an issue, we use sulfonylureas. Sulfonylureas are very potent anti-hyperglycemic agents. The only thing is that they produce hyperglycemia and weight gain. So this is in a nutshell. Due to time limitation, I have just put one slide, and that is how you proceed with choosing an anti-diabetic drug. Any anti-diabetic drug should be efficacious, should not produce side effects, and should have a good cardiovascular safety. Now, about the glucose monitoring, glycemic monitoring in the management of type 2 diabetes, we have 3 core glucose technologies today. We are all aware of the finger stick testing. We all do the SMBG at home. Then we have the A1C. And today, what is the sea change in glycemic monitoring is the continuous glucose monitoring. So a mix of all the 3 components really helps in good glycemic monitoring. Now, today we don't talk about just A1C alone. We talk of glycemic pattern. We want fasting glucose to be controlled. We want a postprandial glucose to be controlled. We want A1C to be normalized. We do not want hypoglycemias, and we do not want glycemia. An ideal drug should address all these 5 important parameters. And limitations of A1C is that it produces only the average glucose. We only have the average glucose value over the last 3 months. And however, the confounding variables are many depending on hemoglobinopathies. But then it doesn't tell us anything about glycemic variability. It doesn't diagnose hyperglycemia. So the CGM is one which has now taken, this is the era of the continuous glucose monitoring. And this is again a diagram showing the glucose monitoring over a day. So this particular patient, this is the target glucose. And when you ask the patient to do a blood glucose monitoring, he does for 4 times in a day with a finger stick pricking. You find that all are in the normal range. So the patient and the doctor feel, oh, my glucose levels are normal. But when you do a CGM, this is the real picture, what is happening. So a continuous glucose monitoring is like a CC camera. You have a continuous record of glucose. Though these 4 values are normal by the finger stick, when you do a CGM, you see so many ups and so many downs have been visualized. So the continuous glucose monitoring today is an important change in the management of type 2 diabetes. Now, moving on to cardiovascular risk management. So very important is the blood pressure management along with glycemic control. The definition of hypertension again has been reduced further as a systolic of more than 130 and a diastolic of more than 80 on at least 2 different occasions and an average of 2 measurements. So any blood pressure goal consistently, more than 130/80 is the people with diabetes and hypertension, they qualify for antihypertensive drug therapy. lipid management. Dyslipidemia in diabetes starts early. It is the major trigger for cardiovascular diseases. So, very important is that what you do in lipid management is look whether the patient has cardiovascular disease or no cardiovascular disease. Without cardiovascular disease, without any ACVD risk factors, without target organ damage, the goal of LDL is less than 70 milligrams per deciliter. We were talked of less than 130, less than 100, and today the goals have been much lower. And in the presence of a target organ damage like a nephropathy or presence of hypertension, dyslipidemia, our LDL is further lowered. And more so in those who have cardiovascular disease, you find that the goals are still lower. So the primary goal of treating lipids is to lower LDL to as low as possible to minimize cardiovascular disease. Drugs that are used for LDL lowering, the cornerstone still remains statins. If we do not reach the goals with statins, we add ezetimibe, PCSK9 inhibitors, and bempedoic acid. After an LDL lowering is achieved, an increase in triglyceride poses additional cardiovascular risk. So there is a residual risk of cardiovascular disease with high triglycerides, and we use drugs that lower triglycerides. As I said, cardiorenal protection is what we need in the management of type 2 diabetes. So most important is in people who have chronic kidney disease, established heart failure, with or without a reduction in the ejection fraction. We use drugs like SGLT2 inhibitors, which have a proven benefit. They reduce they improve the cardiac function. They reduce the EGFR decline, and this is a recommendation to reduce the CKD progression and the cardiovascular events. Further on for CKD, a very good drug is the addition of finerenone, which is a mineralocorticoid receptor antagonist to further improve cardiovascular outcomes and reduce the risk of chronic kidney disease progression. So this is just about cardiorenal protection in type 2 diabetes. Very important in the management of type 2 diabetes is obesity and weight management for prevention and treatment of type 2 diabetes. Today, people ask us, can we reverse our diabetes? Yes, of course, you can reverse if provided you lose around 10 to 15 kgs of your weight. So this is the answer. So weight management prevents diabetes, reduces the number of drugs that should be used in the treatment of type 2 diabetes. So the benefit of weight is so much that you have to emphasize on weight reduction. Relatively small weight loss, say 3 to 7% of the baseline weight, improves glycemia and other intermediate cardiovascular risk factors. And now longer sustained weight losses confer greater benefits, including remission of type 2 diabetes and improves long-term cardiovascular outcomes and mortality. Finally, a word about NAFLD. We have a new term. We do not use the term NAFLD. There is a new terminology coming up, which is called metabolic dysfunction associated steatotic liver disease. The importance of changing the name is to highlight the metabolic disorders that are associated with steatotic liver disease. So it is called MASLD. It is important that all patients with type 2 diabetes need to be looked for liver fibrosis by using the fibrosis 4 index. And the management of people with type 2 diabetes and NAFLD is same like lifestyle changes that promote weight loss. And drugs like pioglitazone, saroglitazar, GLP-1 receptor agonists, we do have drugs that are effective to treat steatohepatitis, and they slow the progression of fibrosis and decrease cardiovascular disease in people with type 2 diabetes and NAFLD. Now, finally, this is my last slide. So the current practices in the management of type 2 diabetes is, number one is that glycemic control matters in the management of type 2 diabetes. We need to focus on this because a majority of our patients do not achieve glycemic goals. We have numerous treatment modalities. We have newer technologies that aid in the management of type 2 diabetes. A comprehensive medical evaluation and assessment of comorbidities is essential. We cannot be glucocentric alone. We have to have a holistic approach, a focus on cardiorenal protection and optimal weight management. So these are the key take-home messages of my presentation. So thank you IMA for the kind invitation.
Thank you very much, madam. That's a wonderful bird's eye view of the hypertension and diabetes and all. There is one question from Dr. Sharma asking about the continuous glucose monitoring. As you all know, continuous glucose monitoring has been there in the world for a long time, but people started practicing in India very recently. He just wanted to know how to do it and all.
So the continuous glucose monitoring we have today in the market is, we have the Freestyle Libre by Abbott. So the people are, they're buying their own readers, and then they have the sensors. It is applied at the level of the arm, the upper arm, the sensor is applied, and it is used for 14 days. So over 14 days, every 5 minutes, you have a capture of the glucose values. And this gives the A1C, this gives an idea of glycemic variability, where the patient is getting high glucose and low glucose. We are using it regularly on people in type 1 diabetes. We are using it regularly because they are all on insulin. And in type 2 diabetes, whoever is on insulin, whoever is prone for hypoglycemic events, we are using it. Of course, the cost is a little high today. Maybe the future, with more number of companies and coming into the market, the prices will decline. So the sensor cost will be around 4,000. You can use it for 14 days. And then the reader is permanent. You can have your own reader. And the importance of CGM is that people who can afford are all buying it. They're putting their sensors, and then they flash the reader in front of the sensor. How much is the value before lunch? How much is the value after lunch? So that they get an idea. Suppose they want to eat a sweet, an ice cream. So they look at their values. They get motivated either to eat or not to eat, depending on the values. So the advantages are many, but however, still there are issues in standardization of the meters.
Thank you, madam. Thank you very much. That was a wonderful presentation and very informative to all the members of the Indian Medical Association. Thank you, madam. And coming to the next topic, the recent advances in management of uncontrolled hypertension. Dr. A. Surya Lakshmi, madam, former professor of medicine, Sri Venkateswara Medical College, Tirupati. I request Dr. Surya Lakshmi, madam, to present give the lecture, please. Over to Dr. Surya Lakshmi, madam.
Am I audible?
Yes, madam, you are pretty much audible. I think you need to little adjust your camera.
Okay. So my screen is being shared?
Not yet, madam. You need to share it.
Okay.
The green button is there, no, ma'am.
Green
Press
in the
the
center.
share screen.
Yeah,
Center.
that's what I pressed it. Not able to share it.
You just have to click it,
Yeah,
ma'am.
yes.
Click that.
Yes, now?
That's perfect.
Yes, ma'am. Yes.
Right.
Yes.
You can
Put it
make
in.
it a slideshow, ma'am. Yeah.
Yeah, yeah.
Slideshow mode.
Yes, yes, yes. 1 second.
Madam, bottom corner, you'll find there is 65%. Beside that, there is a button. Left side, ma'am. Left side, more left. Yes, ma'am. Click on that. Thank you, ma'am.
Okay.
Have a good day, ma'am. Yes.
A very good morning to all of you. I thank in the first place Dr. Ramni for inviting me for this particular session. I've retired from government service from SM Medical College, and right now I'm with Gayatri Vidya Parishad. So my topic given for discussion is uncontrolled hypertension or resistant hypertension. Well, there's a very slight difference between the two. Uncontrolled hypertension includes both pseudo-resistance as well as resistant hypertension. So before going for the treatment of uncontrolled hypertension or resistant hypertension, we have to make sure that it is resistant or pseudo-resistance. So I'll be dealing with these topics under the following headings. First is introduction, definition, epidemiology, and so on. And ultimately, we'll have the management part of it. So coming to introduction, it is not uncommon for us to see a number of patients who are on dual drug therapy or triple drug therapy, antihypertensives, but still their BP is not reaching the goal. So it is not uncommon for us to see these things in a clinical practice. So first and foremost, when we see these people, we think in terms of secondary hypertension, and then we try to analyze for the causes of secondary hypertension. So by definition, resistant hypertension or uncontrolled hypertension is defined as a hypertension which has not reached its goal in spite of using 3 antihypertensive medications. So out of these 3 antihypertensive medications, one should be preferably a long-acting calcium channel blocker, an angiotensin converting inhibitor or an ARB, and a diuretic. So all these 3 drugs should be started, and then still if the BP is not under control, only then we label it as resistant hypertension or uncontrolled hypertension. So for the criteria that have to be met is, as I told you, first criteria is it should meet the target goal. The blood pressure should meet the target goal. So as we all know, the clinical goal for the normal BP is changing. So initially it was 140 by 90, then 130 by 80, and now again 140 by 90 without target organ damage and 130 by 80 with target organ damage. So whatever guidelines or goals we keep, so based on that, we should be able to achieve that goal with 3 antihypertensive medications to the maximum dose or maximum tolerated dose. That is the first criteria. Then the patient, we should exclude the white coat effect on the patient. That is, we have to measure out of office blood pressure for the patient, and still if it continues to be high, only then we can label it as resistant hypertension. The third most important thing is we should be sure that the patient is adhering to the medication. So non-adherence or missing of the dose does not include the person in resistant hypertension. So the term apparent treatment resistant hypertension has come into use, where all the patients who are non-adherent, who are not taking the right dose, and who have got the white coat effect, so they are known as apparent treatment resistant hypertension or pseudo resistant. So before we conclude that the patient has got resistant hypertension, we have to exclude pseudo resistance. So why is it important that we should diagnose resistant hypertension? Most importantly, just like any other hypertension, resistant hypertension also increases the risk of heart attack, stroke, and renal failure. And the incidence is more when compared to normal controlled hypertension. So coming to the epidemiology, 20% of the patients who have been diagnosed to be hypertensive are also resistant, though also have resistant hypertension. So as I have already told you, first thing is, before we conclude that the patient has got resistant hypertension, we have to exclude pseudo-resistant hypertension and adjust the dose to the maximum tolerable doses. So how do you proceed when you get a patient with resistant hypertension, or when you suspect a patient to be having resistant hypertension? First is take a full history and do a full physical examination. So this full history is to exclude the habits of the patient, like smoking, alcoholism, using of herbal medication, using of recreational drugs, over-the-counter medication, and use of NSAIDs for some other purpose. So all this history should be taken in a very detailed manner. And true measurement, that is the exact measurement of the blood pressure, as you all know, the guidelines or the specifications when you have to test for the blood pressure. How do you monitor the blood pressure? With the equipment, the calibration of the equipment, all these things have to be taken care of. Once you think the patient is coming into resistant hypertension, then a home blood pressure monitor has to be attached. That is, ambulatory blood pressure monitoring should be done, so that out of the office BP is also noted to be high or it is normal. So once all these things have been fulfilled, then test for secondary hypertension. So all the panel of investigations, we'll go through that in the next few slides. So eliminate all the secondary causes of hypertension by the blood analysis as well as by doing other investigations like radiological investigations, imaging, other imaging techniques. So factors that may influence the prevalence of resistant hypertension in daily clinical practices, they are patient related as well as measurement related. Patient related are the age and sex of the patient. First is more the age of the patient, greater the chances of him becoming resistant, and males are more commonly having resistant hypertension when compared to females. Ethnicity of the patient, that is the genetic makeup of the individual as well as the body mass index. So all these things, they play an important role in resistant hypertension, in assessing the resistant hypertension. And also, as I've already told you, the way you measure the blood pressure, the time of the day, and the place where the blood pressure has been measured, all these play a very important role in diagnosis of resistant hypertension. So the Spanish registry has shown that a number of patients who have been found to have resistant hypertension after performing the ABPM, that is ambulatory blood pressure monitoring, almost 65%, 62.5% of them were found to be really resistant to hypertensive drugs, while the remaining 37.5% of patients had pseudo resistance, or more often it was white coat resistance. So coming to the various causes of pseudo resistance, most important is under treatment. So under treatment, that is the clinician's resistance or inertia of the clinician to increase the dosage to the maximum tolerable dose. So under treatment of the patient is one of the common causes for resistant hypertension. The next common cause is medication non-adherence. That is patient missing the medication to take on time or daily monitoring of the intake of the pills. Then white coat effect also is one of the most important causes, and inaccurate BP measurement. So we leave to the non-medical personnel to note the blood pressure who may not be aware of all the precautions that have to be taken. So that again comes as a cause for pseudo-resistant hypertension. So these factors should be excluded before we label the patient to be resistant hypertensive. So the pathogenesis is multifactorial. There are several factors, as I've already told you, the age and sex of the individuals, then the systemic vascular resistance, and also minor elevation of circulating aldosterone level and suppression of the plasma renin levels. They play a very important role in the pathogenesis of resistant hypertension. So coming to the diagnosis, yes, again and again we stress, first exclude pseudo resistance, that is white coat hypertension, medication non-adherence, and then only conclude that the patient has got a resistant hypertension. So when the patient, you suspect the patient to be having resistant hypertension, first thing that we have to see is whether the patient is taking any other medication for any other purposes. Most important, commonly grouped drugs are the NSAIDs. So excessive intake of NSAIDs, probably because of osteoarthritis or some other reason, could be the cause for hypertension not getting under control. Or if it is a young female, usage of oral contraceptives or hormonal therapy postmenopausal or hormonal therapy for dysfunctional uterine bleeding or whatever it is. Then usage of sympathomimetic drugs or usage of cyclosporin, tacrolimus. If it is the say patients using erythropoietin, then vascular endothelial growth factors, alcohol abuse, cocaine intake, amphetamines, antidepressants, glucocorticoids, and mineralocorticoids. So all these drugs play a very important role in the etiology of uncontrolled hypertension. So we have to take a detailed history whether the patient is using any of these drugs. Next most important is exclude secondary hypertension causes. First most important are the chronic kidney diseases and the renovascular diseases, obstructive sleep apnea, coarctation of the aorta, pheochromocytoma, primary hyperaldosteronism, Cushing's syndrome, thyroid disease, and any intracranial masses. All these are common causes of secondary hypertension. Now, how do you evaluate for these diseases? So if you're suspecting primary hyperaldosteronism, plasma aldosterone-renin ratio has to be measured. If you're suspecting a thyroid disease, thyroid function tests have to be done. If you think the patient could be having a pheochromocytoma, 24-hour urinary catecholamine levels and plasma metanephrine levels have to be measured. If you think patient could be having Cushing syndrome by a physical appearance or either a drug-induced or inherent tumor, then urinary cortisol has to be done. Obstructive sleep apnea again forms a very important cause of resistant hypertension. So these people have to be investigated with polysomnography. Then renal vascular diseases, that is renal artery stenosis, renal artery duplex scan has to be done. Any renal parenchymal diseases, ultrasound of the renal system has to be done. Coarctation of the aorta, again, cardiac scanning has to be done. So all these preliminary investigations have to be done in order to exclude the secondary causes of hypertension before we come to a conclusion that basically the patient has got a resistant hypertension. So the commonest cause, almost 25 to 50% of the secondary hypertension are because of obstructive sleep apnea. So when you suspect obstructive sleep apnea being the cause of resistant hypertension is patient has obesity, he has a history of snoring, breathlessness and in breathing pauses during sleep and daytime sleepiness. So when all these symptoms are there, go for polysomnography. And when you suspect the other most common causes of primary hyperaldosteronism. So when on routine blood examination, you measure for the serum electrolytes, patient may complain of muscle cramps and there may be a family history, and usually the onset is in a young individual. So then drug induced, already I have told you the list of drugs which you have to check whether the patient is taking. So those drugs could be one of the causes, but out of all these, the commonest is obstructive sleep apnea syndrome. Now, once we conclude that the patient is having a resistant hypertension, the next aim or the next procedure that has to be done is check whether there's a secondary organ damage, that is the target damage has already occurred or not. So this is done by basic investigations like the ECG and echo, which will show whether there's any left ventricular hypertrophy or enlargement. And then microangiopathy has to be tested by a fundus examination, and nephropathy has to be tested by taking a urinary sample for proteinuria, that is microproteinuria, and chest X-ray. So these are the basic investigations we have to do whether there is any target organ damage or not. So coming to the algorithm, how we are going to proceed about this, first is confirm that the patient has got a treatment resistant hypertension. It is definitely a resistant hypertension and not a pseudo resistant hypertension, where I've already told you where the target blood pressure of less than 130 by 80 is not reached in spite of taking 3 or more antihypertensive agents, one of them being a long acting calcium channel blocker, an AC inhibitor or an ARB, and a diuretic at maximal or maximally tolerated doses. That is the first step to diagnose resistant hypertension. Then exclude pseudo-resistance by confirming that the patient is adherent to his therapy and by doing a 24-hour ambulatory BP monitoring, and exclude the white coat effect. Then assess for secondary hypertension. All the causes that have been enumerated earlier have to be excluded. Then assess the target organ damage, that is ocular, then cardiac, renal, as well as peripheral arterial disease. They have to be looked after. So now, how do we treat a patient with resistant hypertension? First is addressing any condition that may have caused the hypertension. That is, if the patient has got a secondary hypertension, that has to be first looked for, and then it has to be treated accordingly. Then making lifestyle changes and adjusting the medication to find the optimal dose, that is the maximum tolerable doses have to be given to the patient. So lifestyle changes, most important part of this lifestyle changes are limiting the intake of salt and alcohol. So the DASH diet, wherein the diet which is aimed at reducing the hypertension, that is to be followed, where there is a less than 2.3 grams of sodium per 24 hours. Intake of potassium is increased, intake of grains are increased, fiber content in the diet has to be increased, and then decrease the alcohol content of the diet. Limiting the use of NSAIDs to as small as possible. That is, restricting yourself to take only acetaminophen when the need arises. Regular use of NSAIDs will result in resistant hypertension. Then doing at least 30 minutes daily aerobic activity as far as possible all days of the week. And then treating sleep apnea with continuous positive airway pressure. So these are the basic lifestyle modifications which have to be introduced in patients who are having resistant hypertension. Then the goal of the blood pressure is less than, in uncomplicated, that is without any target organ damage, maybe less than 140/90. Sometimes some textbooks say that it can be relaxed up to 150/90 in more than 60-year-old patients, but that is not universally accepted by the JNC7. And more appropriate treatment target is patients with end organ damage. The target goal is 130/80. So treatment resistant hypertension. So the first thing is maximize the diuretic therapy. If the patient is on hydrochlorothiazide, then substitute hydrochlorothiazide with chlorthalidone. Then introduce the fourth drug as a antihypertensive, the drug of choice being aldosterone mineralocorticoid receptor antagonist like spironolactone from 12.5 to 25 milligrams daily. It can be titrated up to 100 mg. Eplerenone 50 mg once daily, or amiloride 5 to 10 mg daily. The other drugs that can be used are alpha blockers such as prazosin, centrally acting sympatholytics like clonidine and methyl-dopa, or direct vasodilators like minoxidil and hydralazine. So these have to be introduced if it is not getting controlled by the earlier drugs which have been told. So here, this is the algorithm that has to be followed. So patient with true resistant hypertension, then dosage has been optimized, that is the maximum tolerable dosage is given, and then hydrochlorothiazide has been switched to chlorthalidone. Then still it is not under control, add spironolactone. Achieve the target blood pressure? Yes, then continue with these drugs. Not yet achieve the target blood pressure? Then beta blockers, alpha blockers, centrally acting sympatholytic drugs or direct vasodilators have to be started. So then we have the interventional treatment, that is the renal denervation and the carotid artery stimulation. Renal denervation, so this is a procedure wherein a percutaneous procedure where an electrode is placed in the renal arteries and then we ablate the sympathetic nerves. Normally we know sympathetic innervation stimulates the release of renin from the juxtaglomerular apparatus and then causes afferent vasoconstriction, which in turn results in increased sodium reabsorption and elevated blood pressure. So this denervation can be done in patients who are not responding to medical therapy. Then the other procedure is the carotid sinus stimulation, where the electrode is placed in the carotid baroreceptors by an implantable device. So this decreases the sympathetic output. So this is the second interventional method which can be followed in resistant hypertension after all the medications have been tried. So here, this is the algorithm. First, ensure that the patient is decreasing the salt intake, has at least 6 hours of adequate sleep, weight loss, exercise has been done, and then 3-drug regimen has been started, and other causes, secondary causes of hypertension have been excluded. Then substitute chlorthalidone or indapamide with hydrochlorothiazide. Still BP not on target, then add spironolactone or eplerenone. Then if all these are not still bringing the blood pressure under control, then a beta blocker, if the can be added if the heart rate is more than 70 and still BP is not under target, add hydralazine. Still not under target, then substitute with minoxidil or minoxidil. So this is the algorithm which has to be followed in the management of resistant hypertension. So summarizing, treatment of resistant hypertension is challenging, but it is not uncommon for us to come across. First, exclude secondary hypertension and then only consider about resistant hypertension. Thank you.
Thank you very much, madam. That was a nice and very crisp presentation. Thank you very much. And as we are short of time, there are questions in the chat box. If it is possible for you to answer them in the chat box, that will be better, madam. We'll be going for the next topic.
Okay.
Thank you very much, madam. Thank you for your excellent presentation. And coming to the third topic of the day, is the current guidelines for the pulmonary tuberculosis treatment. As you all know, going from diabetes and hypertension, the tuberculosis, the approach and management of tuberculosis have seen a significant change over the last couple of years. And to present this, we have Dr. Alladi Mohan, Professor and HOD, Department of Medicine, SWIMS, Tirupati, and a renowned speaker, and who doesn't need any introduction, who has a lot of awards, and he was one of the best outgoing students, and first among first ranking students. That's what we all know about sir, and 25 gold medals, and best teacher award in the year 2011, and a lot of publications, 355 publications, and he has done extensive work as far as tuberculosis is concerned, and he's also a past chairman of the Andhra Pradesh chapter of Association of Physicians of India. Over to you, Sir Alladi Mohan. Thank you.
Thank you, sir. I hope I'm loud and clear. I'll be sharing.
Still, I think volume still could be increased, I believe, sir.
So, okay, sir. I'll share my presentation.
Please, please.
Maybe I could put off the fan that is making some sound. Yeah, I think this will be better. The background noise of the fan is something. Okay, let me share my screen. Yes. Are my slides visible, sir?
Yes, sir.
Yeah. Okay. I at the outset like to thank the IMA and Ramani madam for giving me this opportunity to be with you here today. When the topic was conveyed to me, it seemed a very simple, straightforward one. But then, having reviewed what has happened in the last couple of years, there are lots of new things that need to be understood in the management of pulmonary tuberculosis. I would like to state that I have not received any funding for this presentation, and I have no conflicts of interest to declare. I will also say that I am an adults physician, so I will be focusing on treatment of pulmonary TB in adults. The treatment of pulmonary TB in pediatric age group is similar, but with subtle variations. So I will be focusing on treatment of pulmonary TB in adults. Over the next 12 to 13 minutes, I will try to summarize what the current guidelines say. So let's understand from the basics. What is the scientific basis of treatment of TB? Obviously, Mycobacterium tuberculosis is a mycobacterium. A bacteria needs to be treated with the appropriate antimycobacterial antibiotics. It is important to remember that it is a slow-growing aerobic organism with a doubling time of about 18 hours. It also has the habit of remaining dormant for a long period. Therefore, a prolonged treatment is required to ensure a relapse-free cure. Big deal about treating pulmonary TB, everyone does that. Why have a talk on that? I will entertain you regarding why have a talk on treating pulmonary TB. If you see the populations of Mycobacterium tuberculosis that are multiplying in a cavity, you find predominantly 4 groups. Group A, which is the most abundant, are the organisms that are rapidly multiplying, and from among the first-line anti-TB drugs, isoniazid acts on this group of organisms most effectively. Then you have a group B, which is constituted by slowly multiplying organisms, and this is lesser in proportion compared with the rapidly multiplying organisms. Pyrazinamide has maximum action on the slowly multiplying organisms compared with the other anti-TB drugs. The sporadically multiplying organisms constitute group C. These are organisms with bursts of activity. Once in a way, there is a burst of activity and a sporadic surge in the multiplication. Rifampicin is crucial for eliminating these organisms. But then there is another dormant, non-replicating group of organisms that lay low and resurge often when there is a reason for immunosuppression, but more often, even for no reason, these organisms resurge and constitute the important cause of reactivation TB relapse. For the benefit of the practitioners and postgraduates, if there are any, in an endemic area like India, which is one of the high TB burden countries, 85% of post-primary TB is by reactivation and 15% is by reinfection. So if you look at the treatment of pulmonary TB, or for that matter, any extrapulmonary TB as well, there are two phases of treatment. The initial phase is called the intensive phase. This is required to kill the actively growing and semi-dormant bacilli. And then you have the continuation phase, which is needed to eliminate the most residual bacilli, and it reduces treatment failures and relapse. If you look at the history of treatment of TB in the world and in India, 1946, we actually dared to think we can treat and cure TB. It progressed reasonably well till about 1962 when we had the National TB program, and various regimens were in use at that point in time. Only in 1980, this 6-month fully intermittent effective short course chemotherapy for TB evolved. Till rifampicin was introduced, treatment of TB was more than 9 months. Senior practitioners would remember that. Once pyrazinamide re-entered, was brought back at a lower dosage, the treatment became 6 months. So 6 months treatment of pulmonary TB became possible from 1980 onwards. Thereafter, the revised National TB Control Program came up when the thrice weekly intermittent treatment was in vogue for a long time. When all of us were busy worrying about COVID-19, silently the government of India introduced the National Tuberculosis Elimination Program with the aim to eliminate TB by 2025. When the rest of the world wants to do it in 2035, the government of India wants to do it in the year 2025, which is not very far away. Of course, COVID had other plans, and will we reach the target by 2025? Time will decide. Now, in the year of grace 2021, the government of India came out with the guidelines for the programmatic management of drug-resistant TB. And in that, there is this algorithm, which is called the Universal Drug Susceptibility Testing Algorithm. So, with this algorithm, which is in vogue, Ase to Himachalam, from Kashmir to Kanyakumari, from Bombay to Bengal, at a PHC level. It is available at a PHC level free of cost. The upfront diagnostic test today is Gene Expert. It is a nucleic acid amplification test, and with a turnaround time of 90 minutes from submission of the sample, we know whether M. tuberculosis is detected, and if detected, whether rifampicin resistance is detected. Two things as a matter of learning. This tells you drug resistance testing, not drug susceptibility testing. Susceptibility is a term when you use culture. This is drug resistance testing. 2, it does not tell you whether it is rifampicin sensitive. The terminology used is R resistance is detected, not detected. So when there is no R resistance, drug sensitive TB regimens are enforced. So what is this regimen? So for all the TB patients, whether in public or in private corporate sector, the standards for TB care in India guidelines must be followed. There is a provision to administer the first line anti-TB drugs as appropriate for the weight bands under direct observation. This provision is there in the program. And for patients being treated in the private sector, corporate sector, the FDCs may be provided by the NTEP free of cost whenever requested. So the current regimen which is being used is has been a change from thrice weekly intermittent to a continuous treatment. Late 2017, early 2018 itself, the change occurred from thrice weekly intermittent. We have an intensive phase of 2 months, 60 days, 8 weeks of 4 drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol. And in the program, 56 doses are given. And the continuation phase is for 4 months. We administer isoniazid, rifampicin, and ethambutol. Earlier, ethambutol was not used in continuous phase. With the introduction of this daily regimen, ethambutol is now used throughout. Why we have ethambutol throughout along with isoniazid and rifampicin? The scientific reason is the isoniazid monoresistance is wide variable across the country. In Tirupati, in one study we did, isoniazid monoresistance was 0. But in another study which we did in the adjoining Srikalahasti, the isoniazid monoresistance was 15%. It is not practical to test for isoniazid monoresistance because the upfront diagnostic test Gene Expert picks up R resistance. Later versions of Gene Expert can do both, but that will take some time for implementation. So instead of looking at the INH monoresistance and worrying about it, the ethambutol has been put through in the program mode throughout the treatment of pulmonary TB. The dosages for the first line anti-TB drugs that are used in the programmatic treatment are like that: isoniazid, rifampicin, pyrazinamide, ethambutol. Streptomycin is used only when there is a concomitant TB meningitis. You may ask me, why talk of streptomycin in a talk on pulmonary TB? If the person has pulmonary TB and TB meningitis, then the may I know why? Hello. When pulmonary and extrapulmonary TB are coexisting, whenever there is pulmonary, we call it pulmonary. So pulmonary TB with TB meningitis is also in the program reporting terminology called pulmonary. Otherwise, RHZD are used, and it is advised that pyridoxine is also given at a dosage of 10 mg per day. And as per the weight band listed here, the number of FDCs are given. We teach the people who are working at field level to remember the number of tablets to be given: 2, 3, 4, 5, 6. Now, one should remember that 4 FDC is given in the intensive phase and 3 FDC is given in continuation phase. And if the patient's weight will increase by more than 5 kgs during the treatment and crosses into the next weight band, then the patient should be given the next higher weight band fixed drug combination. Side effects of anti-TB drugs are very many: isoniazid, peripheral neuropathy, hepatotoxicity; rifampicin, hepatotoxicity; pyrazinamide, hepatotoxicity. These are the big players. Streptomycin is ototoxicity, nephrotoxicity. But I want you to pay attention to ethambutol. Ethambutol is now used continuously throughout the treatment. So please pay attention to the retrobulbar neuritis caused by ethambutol. Question the patient on follow-up regarding visual symptoms, and if required, check the visual fields. What is not widely known is, in addition to INH, ethambutol also causes peripheral neuropathy. Ethambutol also causes peripheral neuropathy. So we have 3 drugs with hepatotoxicity, 2 drugs with peripheral neuropathy in the first line anti-TB drugs. So please watch for these symptoms. So on follow-up, if the person is a non-responder, or when the initial sample as per the program is subjected to first line LPA, INH resistance is detected, a different regimen is used to treat drug-resistant TB. It can be a monopoly resistant regimen, but since it is not the topic for today, I will not be dealing with the details of this. So to summarize quickly, what is the fundamental new development in the management of pulmonary TB in India? In the programmatic management, we have universal drug susceptibility testing as an upfront diagnostic test. In 90 minutes of sample submission, we can know whether the isolate is M. tuberculosis, whether there is rifampicin resistance. 2, treatment is given, continuous daily treatment. In the program, there is a provision for supervision. 3, ethambutol is continued throughout the treatment along with isoniazid and rifampicin. Pyrazinamide is stopped at the end of the intensive phase. So it is now possible to rationally, meaningfully, and scientifically manage pulmonary TB, and one should monitor the patient for nutritional status. The Nikshay Poshak program is there for improving nutrition, and when managed with commitment and care, TB is curable, and as the Government of India visualizes, we can eliminate TB in the near future. I thank you for your patient hearing and for the opportunity to share a few of my thoughts. Thank you and namaste.
Thank you very much, sir. That was a wonderful lecture, and very crispy and very informative, and taking us back from history of 1960s and 1940s to the present day, what's happening. Thank you very much, sir. I think in chat box, just check that there are no questions. If there is anything in the chat box, probably we'll answer them in the chat box, sir. Thank you very much, sir.
Don't see any questions, sir. So I would conclude, and
thank you very much, sir. Nice to see you on a Zoom platform after a long time. And that's the end of the first session. And I request the board to take on to the next session, please. Thank you very much.
Thank you very much, Dr. Ravindranath, for efficiently conducting and opening the conference of IMA AMS. Thank you. And I request you to join the inaugural function at 10 o'clock. Thank you, sir. Moderator.
Now, for the second session, we have Dr. Srinivas MD, Dr. Karthik, Dr. Kishore, and Dr. Bhargava. Online, we have Dr. Karthik and Dr. Kishore. So, can you please join? Sir, can you hear me? Dr. Karthik as well as Dr. Kishore, sir.
Join. Dr. Karthik, are you there connected? Next speaker. Okay, next speaker. You announce the speakers, they will start.
So for the second session, we have a speaker, Dr. K. Chandrakala, MD Pharmacology. She is the professor and HOD of Department of Pharmacology, Government Medical College, Ongole. Ma'am, are you there? Kindly join, ma'am, please. Dr. K. Chandrakala, ma'am, are you there?
Hello, Chandrakala ma'am. You have to click on John as panelist, ma'am, to be able to share the screen. Yes. Hello, Chandrakala ma'am.
We have our next speaker as Dr. Sanesh, who is a consultant nephrologist. Do we have him online, sir?
Yes. Yes, I'm there. Hello.
Yes, sir. We are able to hear you, sir.
Yeah, okay. Can I share the screen?
Dr. Sanesh, I can see you. You present your session.
Sure, madam. Yes. So can I start the session?
Dr. Sanesh is a practicing nephrologist from Apollo Hospitals, Nellore. Sir, kindly start your sessions.
Good morning, one and all. Thank you, madam. Thank you for the IMA for giving me the opportunity to speak on behalf of chronic kidney disease. As everybody knows, this chronic kidney disease is an overwhelming and big problem nowadays in the world. So I'm going to tell a few words regarding the chronic kidney disease, how to prevent the progression of the chronic kidney disease so that the patient can prevent from going to hemodialysis. So as everyone knows, chronic kidney disease is defined as structure and function abnormality of the kidney for a period of more than 3 months. Along with that, the patient will be having the glomerular filtration rate less than 60 ml per minute. Along with that, markers of kidney damage. One of the markers of kidney damage is albuminuria. This is how the chronic kidney disease is defined. There is both the structural abnormality and the functional abnormality for the period of more than 3 months. Along with the glomerular filtration rate, it will be less than 60 ml per minute. Along with that, markers of the kidney damage is one of them is albuminuria. So as everyone knows, this is the classification of the chronic kidney disease. This is the KDIGO guidelines which has classified the chronic kidney disease in 2012. Based upon the glomerular filtration rate, that the function of the kidney, the CKD has been classified into 5 stages. So the 5 stages are G1, G2, G3A, G3B, G4, and G5. So based upon the glomerular filtration rate, the glomerular filtration rate of the kidney is calculated by serum creatinine, and CKD EPI is the formula which is used to calculate the glomerular filtration rate. This has been recommended by the KDIGO. Based upon the glomerular filtration rate, it has been classified when the glomerular filtration is greater than 90, or when it is equal to 90, the chronic kidney disease is stage 1. When the GFR is around 60 to 89, it is CKD stage 2, that is G2. When the GFR is around 45 to 59, it is CKD stage 3A, that is G3A. And if it is less than 30 to 44, it is G3B. And CKD stage 4, that is G4, is when the GFR is around 15 to 29 ml per minute. When it is less than 50, it is chronic kidney disease stage 5. Along with the glomerular filtration rate, based on albuminuria also, the CKD has been classified. That is normal to mildly increased albuminuria, moderately increased albuminuria, severely increased albuminuria. So what are the important causes of chronic kidney disease? As the worldwide, the most important causes of chronic kidney disease is diabetes. Around 30 to 45% of the patients with chronic kidney disease, the most common etiology of them is diabetes. Followed by diabetes, the hypertension, then there are the glomerular disorders, which causes the chronic kidney disease. There is polycystic kidney disease. The other causes which are attributed to chronic kidney disease of aging of the kidney. As everyone knows, the GFR comes down after 30 years of age. After 30 years of age, for every 1 year, the glomerular filtration rate of the kidney comes down. So when the person is aging, in such conditions, when the person is dehydrated, vomiting, loose stools, in such conditions, the creatinine will go up. Along with that, renal artery stenosis is also important cause of chronic kidney disease. And old age patients more than 50 to 60 years of age, you have prostatomegaly. Prostatomegaly leads to recurrent infections. Recurrent infections ultimately leading to damage of the kidney itself is all attributed to chronic kidney disease. Drug-induced and toxin-induced. In India, it is a major problem. You have over-the-counter medications such as NSAIDs, proton pump inhibitors that have been regularly used by most of our people in general population. All these drug-induced causes also leads to chronic kidney disease. And in children, you have peripheral posterior urethral valves, vesicourethral reflex, ultimately leading to reflex nephropathy and leading to chronic kidney disease. So most important causes, diabetes followed by hypertension, then you have the glomerular disorders. These are the other causes of chronic kidney disease. So what is the framework of the CKD screening, how we can do it. So determine the individual or population level risk. For example, in Andhra Pradesh, you have Yuddhanam nephropathy. So there are some hotspots of chronic kidney disease worldwide along in India and also in Andhra Pradesh. So in that hotspots, you screen the population. You screen the population to find out if the person is having any symptoms of chronic kidney disease. So you find out the hotspots of the chronic kidney disease where there are increased incidence of CKD. You do a CKD screening. If the CKD is diagnosed, is confirmed, risk stratification and staging and prognosis followed by treatment can be done. So if the CKD has not been diagnosed, so individual screening can be done. So who are the most important etiological factors for CKD? As I told you, persons with hypertension, diabetes, and cardiovascular disease should be screened for chronic kidney disease. So diabetes is the most common cause of chronic kidney disease, followed by hypertension. Then you have the cardiovascular disease. In cardiovascular disease, what will happen is the person will be having, person will land up in congestive cardiac failure, followed by low ejection fraction, ultimately leading to decreased renal perfusion and renal injury. That is the cardiorenal syndrome. Cardiorenal syndrome, one of the most common cause of renal dysfunction in patients with coronary artery disease. Then also in coronary artery disease, you have persons who will be going from angiogram and angioplasty where contrast has been used in volumes. This contrast nephropathy is also a very big problem for patients ending up in chronic kidney. So diabetes, cardiovascular disease, in all patients with cardiovascular disease, you should screen for chronic kidney disease. So this is the same thing that the person should be screened for hypertension patients, diabetes patients, and cardiovascular patients. All these patients should be screened for chronic kidney disease. So what other population persons who have increased risk for chronic kidney disease? CKD screening, as I told you, is most common in diabetic patients, hypertensive patients, cardiovascular patients. The other populations which need to be screened are older age patients. As I told you, as the GFR decreases when the age goes up, so these people are more prone for CKD, so kidney damage. So all these people, due to dehydrations, vomitings, loose stools, they'll have pre-renal element, ultimately recurrent acute kidney injury will finally land up in chronic kidney disease. And race and ethnicity, as I told you, race and ethnicity is a very big problem, which most of the people land up in chronic kidney disease, such as Black African people who are mostly affected by focal segmental glomerulosclerosis, that is FSGS, and SLE. Most of the SLE patients will be having lupus nephritis. If lupus nephritis is not treated well, they will end up in chronic kidney disease. HIV is also Ivan. It is HIV associated nephropathy is a major big problem in patients who they land up in chronic kidneys. Then have the genetic factors such as autosomal dominant polycystic kidney disease, which also run in families. They will be having, they land up in CKD. There are family histories, low socioeconomic people more prone for infections into CKD. Environmental factors such as exposure to silicosis, asbestosis. These are all the people who need to be screened for chronic kidney disease as a prior history of acute kidney injuries, preeclampsia, nephrotoxins, obesity. All these populations should be screened for persons if they are having chronic kidney disease or not. So how do you screen for population? So identify the risk population. As I told you, what are the risk population are diabetic patients, hypertension patients, families of CKD, recurrent UTI, the recurrent infections, recurrent acute kidneys. These are all the risk populations for chronic kidney disease. These persons should be screened for chronic kidney. There's a simple test which you can that is simple urine examination enough. In urine examination, we can see if the presence of proteinuria is there or not. Finally, you need to quantify that proteinuria. You can do an urine protein creatinine ratio and urine albumin creatinine ratio. And you can do a simple blood test as serum creatinine. By serum creatinine, you can do an estimated glomerular filtration rate to know what is the status of the CKD and do a simple ultrasound examination. By doing an ultrasound examination, we can know the size of the kidney, structure of the kidney. So these are the simple investigations which can be done to rule out CKD or not. We can do this population-based screening to identify the CKD persons. So when you identify the CKD patients, we can do some measurable factors so that they prevent the progression of CKD. As I told you, the high-risk population, we do a simple screening test such as urine test, serum creatinine test. Finally, if it turns out to be positive, if it turns out the person's GFR is less than 60 ml per minute, if the person albumin creatinine ratio, that person is leaking proteins, it is more than 30 milligrams per gram, these are markers of kidney damage, then you classify it as chronic kidney disease. After classifying it as chronic kidney disease, we will divide the person into which stage that the chronic kidney disease comes based upon the glomerular filtration rate. So based upon the glomerular filtration rate and classifying the stages of CKD, we can do some preventive measures to prevent the progression. So when should a patient with chronic kidney disease consult a doctor? Patients with CKD should consult the doctor immediately. The patient explained If the patient gains rapid unexplained weight gain, that is due to volume overload, volume overload is due to fluid retention that is due to secondary to oliguria. If the patient develops rapid volume overload, then immediately you should consult a nephrologist. Marked reduction urinary volume, the person develops chest pain, fever, severe diarrhea, recent worsening of uncontrolled hypertension. If normally the blood pressure will be controlled with single medication, suddenly the blood pressure will shoot up and the persons will land up in pulmonary edema. That could be secondary to renal artery stenosis. Such person should be immediately consult a doctor. If the person is having hematuria, these are all the factors when immediately a person with CKD should consult a doctor. So what are the goals of medical management in chronic kidney disease? So initially, after identification of the chronic kidney disease, our goal of management as a doctor or as a nephrologist is to slow down the progression of the disease. So by slowing down the progression of the disease, we can prevent the person from going to the stage 5, that is the renal replacement therapy. Treat the underlying causes and contributory factors. Followed by chronic kidney disease, there are some underlying factors and contributory factors which lead to rapid progression. For example, the persons with chronic kidney disease will be dehydrated, that is secondary to vomitings or loose stools or due to environmental exposure, and over-the-counter medication, they'll be taking NSAIDs and proton pump inhibitors. In such condition, there will be rapid deterioration of the chronic kidney disease. We need to identify these underlying causes and the contributing factors. Relieve the symptoms and relieve the complications of the disease. Complications of disease, as I told you, secondary to volume overload, severe uncontrolled hypertension. These are the complications which need to be identified and controlled well. But reduce the risk of cardiovascular burden. As I told you, chronic kidney disease also land up in cardiovascular, increased risk of cardiovascular burden. So it needs to be reduced. Delay the need for dialysis or transplantation. So what are the treatment strategies, different stages of chronic kidney disease? So in case of all stages, regular follow-up and monitoring of the patient is very essential and very important. Lifestyle changes and general measures are also very important. Diagnose what is the cause of chronic kidney disease. Treat to slow down the progression of the chronic kidney disease. Educate the patient. You need to educate the patients about the disease management. We need to educate the patient regarding the intake of fluid, how much fluid is need to be taken, dietary, what are the dietary measurements that needs to be taken to find out if avoid NSAIDs, painkillers, proton pump inhibitors. We need to educate the patients. Treat comorbid conditions such as diabetes, hypertension. If any obese, we need to ask the patient to do physical activity and reduce the weight. Estimate the progression, treat the comorbid conditions, evaluate and treat the complications, educated patients regarding the kidney replacement options, and also kidney replacement by dialysis and transplant that is usually done in the 5th stage. So what are the 9-step actions of planning medical management chronic kidney disease? What need to do? Management of the primary etiology. So first of all, you need to identify the cause of chronic kidney disease. What is the cause? Is diabetes or hypertension, even glomerular disorders? What is the cause of person that has landed in chronic kidney disease? Secondly, these strategies are done to prevent the slow down the progression of the CKD. Your doctor must describe important effective methods such as blood pressure control. The most effective blood pressure control antihypertensive medications in persons with chronic kidney disease are ACE and ARBs. And also protein restriction. Protein restriction is also one important method to prevent the progression of the chronic kidney disease, because increased protein intake will land up the person in uremia, and also increased animal protein intake will also land up the person in acidosis. We need to cut down the protein intake in patients with chronic kidney disease. How much protein is acceptable? The protein intake is usually 0.6 to 0.8 grams per kg body weight. That is the amount of protein that is acceptable. And also lipid lowering strategies. Lipid lowering strategies can be done by using statins. Statins when given to prevent the cardiovascular risk in patients with chronic kidney disease. Correction of anemia. As I told you, most of the patients with CKD, erythropoietin deficiency will be there. This because of lack of erythropoietin deficiency, most of the patients will be anemia. We need to check the iron levels also for these patients, not only by giving erythropoietin. Correct the iron first and give the erythropoietin. It's also very important. By taking all these measures, we can slow down the progression of the chronic kidney disease. What are the support and symptomatic patients? When the patients land up in chronic kidney disease stage 4, as I told you, they will be having anemia. We need to do iron replacement and erythropoietin therapy. CKD, MBD, mineral bone disease will be much of the factor. The calcium levels will be low. The phosphorus levels will be elevated. Parathyroid hormone levels will be altered. So we need to correct the calcium and the phosphate levels in all these patients. And management of reversible factors. Management of reversible factors, as I told you, is if the person is coming up, initially the patient will be around CKD stage 4 to gradually it could progress to CKD stage 4. That gradual sudden progression of CKD stage 4 will be due to some intake of any over-the-counter medications, or it might be due to secondary infections. We need to identify these infections, correct the infections so that we can halt the progression of the CKD. Identify and treat the complications. Identify the complications such as volume overload, if the person is having hyperkalemia or not. Identify these complications, treat the complications. Lifestyle modification. Lifestyle modification is also a very, very important thing to prevent the progression. So physical activity is very important for all of them. At least doing half an hour of physical activity for at least 5 days a week. Salt intake, reduce salt intake. The salt intake should be around less than 5 grams per day. That is equal to 1 teaspoon of salt. Limited protein restricted protein intake, that is 0.6 to 0.8 grams per kg body weight. These are all the lifestyle modification, dietary restrictions that need to be done. And preparation for the kidney replacement therapy. When the person comes to the final stage, that is CKD stage 4, you need to prepare the patient for kidney replacement therapy. That need to be done. We need to counsel the patient that it be a dialysis or a transplant. If you want to give an option of dialysis, you need to tell them regarding hemodialysis as well as peritoneal dialysis. The person is willing for hemodialysis, we need to construct an AV fistula at around the CKD stage 4 when GFR is around less than 30 ml per minute. As told you, lifestyle, this is a study which shows that lifestyle improvements may help reduce the progression of all stages of the chronic kidney disease, such as increased vegetable intake and potassium intake, physical activity, limited alcohol consumption, smoking cessation, salt intake, reduced salt intake, that is around less than 3 grams of salt. All these factors have been reduced. All these lifestyle modifications have prevent the progression of the chronic kidney disease. As we told you, AC inhibitors and angiotensin receptor blockers are the cornerstone for the treatment and prevent the progression of chronic kidney disease. They reduce the risk of CKD progression as well as kidney failure. There are many meta-analysis studies which show that ACRBs prevent the progression of chronic kidney disease. Benefits of intense blood pressure. Intense blood pressure control has been shown to lower the progression of CKD. Previously, the guidelines what used to say in patients with diabetic and chronic kidney disease, the blood pressure should be around less than 130/80. The newer guidelines with the KDIGO guidelines, hypertensive guidelines, which are recently reduced, they have so told that the systolic blood pressure should be around less than 120 mm of mercury. So this is a trial, sprint trial, which ensured that intense blood pressure control, the standard blood pressure control, for the persons with intense blood pressure control has very least increase, least incidence of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from cardiovascular causes, or death from any other cause. Similarly, as the cardiovascular benefit, renal benefits have been shown with intense blood pressure control. So mortality benefits of intense blood pressure control in chronic, there are many severe meta-analysis studies which have shown that intense blood pressure control prevent the progression of CKD. And statins also decrease the incidence of cardiovascular disease in patients with chronic kidney disease. So in patients with more than 50 years of age, it is a chronic kidney disease, you can start him on statins so that it can prevent the cardiovascular disease progression. Intense glucose control. So intense glucose control also prevent the progression of chronic kidney disease. So intense blood pressure control, glucose control, dietary modification, lifestyle modification, these are a very important part in prevent progression of the chronic kidney disease. These are newer therapies. Previously there was only fewer ACE used to prevent the progression of the chronic kidney disease. Now the SGLT2 inhibitors are coming to market. They have been very useful and they have been very helpful in prevention of progression of chronic kidney disease. Usually what is to happen is the proximal tubule of the kidney, you can see that the sodium and glucose will be reabsorbed to the SGLT2. So by inhibiting the SGLT2, the glucose and sodium is not reabsorbed in the proximal tubule. Through the distal tubule, macula densa will be stimulated and it releases adenosine and causes afferent arterial vasoconstriction. That is how that the mild GFR reduction will be there and proteinuria will be controlled. That is how the SGLT2 inhibitors are. SGLT2 inhibitors have been a cornerstone and very important in the management of prevention of chronic kidney disease. The drugs have come into market recently and they have been very useful. So these are the effect of SGLT2 inhibitors, major kidney outcome. There are trials, there are cardiovascular trials and renal trials which have been studied on SGLT2 inhibitors. The major renal trials on SGLT2 inhibitors are Credence trial for canagliflozin and DAPA-CKD trial for dapagliflozin and for EMPA kidney trial for empagliflozin. So along with the cardiovascular and renal trials, they have shown that SGLT2 inhibitors have more of favor, more of the side effects have been favored with SGLT2 inhibitors. So the risk of dialysis, transplantation, death, and stage renal disease have been low and in patients with the SGLT2 inhibitors when compared to placebo. So these are the different trials in different stages of CKD, both the cardiovascular trials such as CANVAS trial, DECLARE-TMAC trial, EMPA-REC trial, as well as the renal outcome trials such as Credence trial, DAPA-CKD trial, EMPA kidney trial. They showed the benefits of usage of SGLT2 inhibitors prevention the progression of CKD. So this is the same, the different study modalities which have been used to prevent the progression of CKD. So coming to the staging of CKD, this is the credence style. As I told, the credence style. The credence style is mostly studied in diabetic chronic kidney disease population. Diabetic chronic kidney disease population, the GFR is around 30 to 90 ml per minute, along with patients having proteinuria around 300 milligrams per kilogram. So in this population, by usage of canagliflozin, the rate of progression of diabetic kidney disease to dialysis have been decreased when compared to the placebo group. After the canagliflozin credence trial, the dapagliflozin trial come, that is the dapagliflozin trial. Whereas credence trial, it has been studied only in the diabetic population, where the dapagliflozin trial has been studied in both diabetic and non-diabetic population. And also in the dapagliflozin trial, the GFR is around 25 ml per minute. Next comes the EMPA kidney trial. In case of EMPA kidney trial also, the GFR has been studied to around 20 to 45 ml per minute. So SGLT2 inhibitors can be given to patient not only for diabetic chronic kidney disease patients and non-diabetic chronic kidney disease patients also. These SGLT2 inhibitors can be given up to the GFR at 20 to prevent the progression of CKD. So this is a credence trial that the canagliflozin renal outcomes in patients with diabetic diabetes and nephropathy. This credence trial has only been studied in diabetic chronic kidney disease population. 4,400 people have been participated in study. We have urine albumin excretion ratio of more than 300 milligrams per gram. The average age of the individuals in study is 62 years, and the EGFR is around 57. So most of the patients who have been included in the study are CKD stage 3, diabetic CKD stage 3, with urine albumin excretion rate of 900 milligrams. All the patients are on tolerable levels of AC and ARB. So for any diabetic chronic kidney disease patient, initially you need to start an AC or ARB inhibitor. Directly you should not go for SGLT2 inhibitors. Start with an AC or ARB inhibitor up to the tolerable maximum limit. Followed by that, you start an SGLT2 inhibitor. The primary outcomes such as doubling of serum creatinine, end-stage renal disease, death to cardiovascular events are very low in patients who have been started on canagliflozin when compared to the placebo group. Similarly, the DAPA-CKD, as I told you, the difference between the credence trial and DAPA-CKD trial, whereas credence has been studied only in the diabetic chronic kidney disease population. In case of DAPA-CKD trial, it has been studied both in diabetic and non-diabetic population. There are 21 countries have been participated at 286 centers. You can see the most of the person here, around 2,000 people have been studied. And you can see when compared to the placebo group and dapagliflozin, the instance of reduction in creatinine levels and stage renal disease, death to cardiovascular disease are low in the person who have been taking dapagliflozin when compared to the placebo group. So accurate diagnosis, staging of CKD are necessary to utilize the treatment effectively. You need to identify the cause of chronic kidney disease and do the staging of the CKD, which stage the patient comes. The stage 1, treat the underlying condition, comorbidity conditions. With the stage 2, estimation of the rate of progression is very important. In case of stage 3, evaluate and treat the complications. The most of the complications such as anemia, mineral bone disease, all these complications will be seen in stage 3 of CKD. In case of stage 4, prepare the patient for renal replacement therapy. Prepare the patient means you need to give the options of patient for the dialysis and the transplantation. If the dialysis also, you need to give the option for hemodialysis or peritoneal dialysis. If the person is willing for hemodialysis, an AV fistula creation should be done when the GFR is less than 30 ml per minute, that is CKD stage 4. And CKD stage 5 is dialysis or transplantation if the patient is symptomatic or uremia is present. So finally, this is the treatment part. So all the patients with the estimated GFR less than 60, we need to do dose modifications should be done based upon the estimated glomerular filtration rate. So some of the drugs should be avoided and dose modification of certain drugs should be done to prevent the damage to the kidney, more damage to the kidney. Reduce the risk of acute kidney injury from volume depletion. So volume, the intake of fluid should be different for each and every individual. All individuals should not have one prescription. It depends upon the dry weight of the patient. If the patient is much more dehydrated, he can have some increase the amount of fluid intake that can. So intake so that we can prevent the acute kidney injury, that is pre-renal element in patients with chronic kidney disease. So adopt sick day rules as needed. So with the person, as I told you, most of the persons AC and ARBs are the cornerstone in prevent the progression of the kidneys. But if the person is dehydrated, if the person is having any fever or any infection conditions, in such conditions, we need to educate the patient that we need to avoid AC inhibitors and ARBs as well as SGLT2 inhibitors so that they deteriorate the progression. So we need to educate the patient when to start the drug, when to use the drug, and when to stop the drug. And also contrast associated acute kidney injury. As I told you, contrast associated acute kidney injury is the most common in patients with cardiovascular disease. to use the lowest possible radio contrast dose. As the contrast material also varies from high osmolar, low osmolar, and isoosmolar. It is better if you use a low osmolar or isoosmolar contrast for patients, and also minimal dose based upon the glomerular filtration rate. To withhold ACE inhibitors, ARBs, diuretics, other nephrotoxic tests, if you want going for a procedure and the person is planned for an angiogram or angioplasty, it's better to hold ACE inhibitors, ARBs, as well as diuretics. So if the person GFR around 45 to 59 mmol/100, prevent use of prolonged NSAIDs. The GFR 30 to 44 also usage of NSAIDs should be started. Metformin also should be, dose also should be reduced. If GFR is less than 30, so you should need to make the patient ready for AV fistula creation. So slowing the CKD progression. How slowing the CKD progression is treating the blood pressure. ACE inhibitors should be used so that they reduce the proteinuria and prevent the progression. Target blood pressure, target diabetes levels also should be around less than 6.5. For all the patients with chronic kidney type 2 diabetes, if the GFR is greater than 30, you can go with SGLT2 inhibitor and metformin. Still, if you want to control the sugars, you can add up GLP-1 receptor antagonists. CKD complication, as we told you, CKD stage 3, CKD complications, you can see if the person is having anemia. First of all, see the iron levels. See the iron levels. The iron levels are good. First, correct the iron levels, followed by that erythropoietin supplementation is very important. Acidosis. Acidosis will be seen in all the patients with chronic kidney disease. Such kind of bicarbonate supplementation should be done. And in case CKD, MBD, give calcium supplementation, phosphate supplementation. See, check for phosphate levels, alter the phosphate levels. Vitamin D supplementation should all be given. Influenza vaccination should be done. Pneumococcal hepatitis vaccination should all be done. And hepatitis C screening should be done. Reduction of cardiovascular complications is also very important. How to reduce the cardiovascular complication is reduce the blood pressure. To decrease the blood pressure around to less than 120 millimeters of mercury. Start the statins therapy for patients with on to observe that the cardiovascular resistance has been reduced. Aspirin can be used to prevent secondary prevention. When to refer for a nephrologist? If the person is having AKA or abrupt sustained fall in GFR. So when the person usually is on CKD stage 4, it gives up around 70. So if the person GFR falls less suddenly to less than 30, so then it should be referred to a nephrologist. Then also that progression of chronic kidney disease when it is rapid, if the person is having hematuria more than 20 RBC per IFL feet, the patient is having uncontrolled hypertension and hereditary kidney disease, extensive recurrent renal calculi formation, persistent hyperkalemia, all these conditions you need to refer to a nephrologist. Thank you.
So, thank you, doctor, and you extensively covered entire the CKD in a given time, but it is a little late. But anyway, congratulate for your good presentation.
Thank you, sir.
The coming to the question and answers, you can answer them through charts. Okay. Thank you very much. I'm Dr. Kishore. Okay.
Okay, sir. Thank you, sir. Thank you.
Nice. Yeah, next speaker.
The next speaker we have with us Dr. K. Chandrakala, MD Pharmacology, Professor and HOD, Department of Pharmacology, Government Medical College, Ongole. Ma'am, you can start with your presentation now.
Yeah, thank you.
Welcome, madam.
Audio, video, and screen share ready? Visible?
Yes, ma'am. We are able to see your screen. Ma'am, can you change the screen mode to slideshow mode? Yes. Thank you.
Hi. Thank you. Thank you. First of all, I would like to thank Dr. Ramani, madam, for asking me to present and be a part of this. Thank you, madam. And I also thank all the organizing team. Because of the technical issue, I could not log in previously. Thank you for resolving the issue. So I'm Dr. Chandrakala, worked as professor and HOD pharmacology, working as in Ongole, GMC Ongole. Very recently, I have been transferred. I worked as AMC coordinator at GMC Guntur also. So in this session, I would like to give a gist on ADR's identification and their reporting as a part of Pharmacovigilance Program of India. So before we have a briefing on how this reporting started. So we all know about the Phocomelia incidents. So in late 1950s, there was a catastrophic effect on deformations of the babies, where there were limb abnormalities. So then it was not known which drug was the culprit for this. Later on, they have identified, some practitioners, they have identified and published in Lancet that it might be due to thalidomide. which was used as an antiemetic or as a sedative in pregnant women. So in New York Times, after this tragedy, the manufacturer, he apologized the victims of thalidomide in 2012. This was after 50 years. So this was quite late. So to prevent such ADRs, we need to report ADRs. So before going how to report ADRs, let us know, we all know about the definition of ADR. So by definition, any drug, any response to a drug which is noxious and unintended, which occurs at doses normally used for prophylaxis, diagnosis, and therapy of the disease, or for the modification of physiological function. So, are these ADRs preventable? That is the question now. Yes, they are preventable, but when? So, when the phocomelia was reported, then we came to know that it was due to thalidomide. So, reporting is very much essential to know that ADR is due to that particular drug. So, ADRs are preventable, and how to report and where to report. So, as I was telling, I am working as ADR Monitoring Center Coordinator at Ongole. So, this is the area or the place where all the ADRs have to be reported. Why only ADR monitoring centers? Because not all the ADRs can be reported in a journal. Nobody has that much time to report in a journal, to prepare an article and then publish. So all the ADRs in simple mechanism can be reported to AMCs or ADR monitoring centers, because here only the signal can be generated. Signal is the one where more than one report is needed to generate a signal that the particular drug is causing such ADR, which was unknown previously. And we don't have adequate Indian data on ADRs because we are very much under-reporting the ADRs. So if we inculcate the habit of reporting ADRs, we can have an adequate data, and all the prescribers can be aware about these ADRs. And this will automatically reduce the social and economic burden on treating the ADRs. So the learning point here is all the ADRs are reportable to AMC and all reports are analyzed for signal detection. So here I can say that reporting ADR to AMC is a professional obligation. But because we are in a democratic country, I would say rather it is a professional responsibility rather than obligation. So how to identify ADRs? This everybody knows. All the prescribers are well versed that after the drug is initiated for therapy, some changes may be seen, either clinical or hematological or biochemical lab results, abnormality. So whichever area you see an abnormality, you should first think of the culprit drug. Which drug is causing the ADR? So once you have identified, it need to be reported, and this is what the pharmacovigilance program of India is concerned about. Now, what is pharmacovigilance? So by WHO definition, the science and activities related to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problems. So this applies throughout the life cycle of a medicine, equally to the pre-approval stage as to the post-approval stage. That is, before the drug is into the market, that is the clinical trials, and as well after it is released into the market, that is post-approval stage. So why do we need this pharmacovigilance at all? So all the data which we have from the pharmaceutical company, from the animal experiments or clinical trials, are they relevant or complete? We have to think about it. And once it is released into the market, post-marketing issues have to be taken care of. Unexpected adverse reactions which were not enlisted in the writings which were given from the pharmaceutical companies, drug interactions. So most of the patients will be on polypharmacy. So those drug interactions may not be studied in the preclinical studies or clinical trials. So risk factors and quality of life, how it is affected with the drug, and long-term efficacy, is it dealt properly or not? So all these issues can be taken up only when the drug is released into the market and used in the patients. And not only the drug issues, it is an NABH obligation also. So if you take the MOM 8 regulation of NABH, it says that patients are monitored after medical administration. So the core topic here, if you can see, the organization captures near miss, medication error, and adverse drug reaction, and it has to be reported. So it is an obligation or it is a regulation in NABH also. And those who have applied for NABH, they might well known that about ADR reporting. So now what happens if we report the ADRs? So all the healthcare professionals or consumers themselves, that is the patients themselves, can report ADRs to ADR monitoring centers. As well, the pharmaceutical industry is also taking the responsibility of reporting ADRs in clinical trials. And national health programs and all other institutions, government and private institutions, they have the obligation of reporting ADRs to ADR monitoring centers or directly to NCC or PVPI. The National Coordination Center for PVPI in our country is IPC, that is Indian Pharmacopoeia Commission, which is located in Ghaziabad. And finally, all these data of ADRs which are received in NCC or IPC will be processed to CDSCO. So all the ADRs will be reviewed and sent to CDSCO, which is the National Drug Regulating Authority of our country. So here on the picture, you can see Uppsala Monitoring Center. So this is the International ADR Monitoring Center, which will monitor all the drug-related ADRs. So this is not just a national program, this is an international program. So Uppsala Monitoring Center, again, it collaborates with WHO headquarters. So finally, all the national centers will collaborate with Uppsala Monitoring Center and WHO headquarters in Geneva. So I have taken the picture of 2015 reporting of ADRs. So if you can see, India stands at 2%. And later I have taken the picture from Uppsala Monitoring Center website. So in 2019, it has come to 3%. So by this, we can see how much we are at under-reporting, where other countries are doing better. Now, because of under-reporting, even our country has initiated this pharmacovigilance program of India, and this was established in 2010. And we have established AMC Center under this PVPI in 2014. And in Ongole, very recently, we have established AMC. So all the government colleges now are up to establishing AMCs, and the role of those AMCs is to collect the ADRs and report it to the PVPI. Now at present, we have 606 ADR monitoring centers in the country and 23 in AP. And many of the hospitals and institutions are applying for this ADR monitoring center because now it is mandatory. Now, what to report? What are all the ADRs which we can report? So mostly we'll be thinking that only the serious adverse events are to be reported, but no, all the adverse events suspected to have been caused by new drugs, as well as the established and well-known drugs, and also the drugs of current issues, and all the suspected drug interactions or food interactions, whatever it is. And we all know about the serious adverse events, SAEs. So drugs which cause death, life-threatening risk, prolonged hospitalization, disability, congenital anomaly, required intervention to prevent it, and permanent impairment or damage. And also ADRs due to withdrawals or any other traditional medicines or nutraceuticals, whatever it is. Any ADR to any substance which is being used for therapy, we have to report. So all these have to be reported. Now, who can report this? So all the professional healthcare professionals like clinicians, nurses, pharmaceutical industries, pharmacists, and the patient himself also can report. For this reason, we have incorporated the AMC center number and a toll-free number in the OP slips of Guntur and Ongole hospitals. And patient himself can report with this numbers incorporated in the OP slips. Now, where to report? Now, we are prescribers, and so how do we report and in which form we have to report? So usually PVPI has has released a suspected adverse drug reaction reporting form, which has to be completely filled. And all these are available in all the AMCs and also in the websites of IPC and CDSCO. We can have these reporting forms in this and can download. And once we fill these forms, you can submit to mail pvpi.ipcindia@gmail.com. So either it is easy to report to the near AMC or on mail to NCC. And also we have a toll-free number 1800-180-3024. So even we can just call this number and give the brief details of this ADR. And we have a mobile app. Now this is the smart era. So all the patients themselves, they have smartphones. So they can just log into, they can just download ADR PVPI app from the Play Store. It is available both in Android and iOS phones. And once this app is opened, there will be a free flow of how the inputs have to be done. It is user friendly. Anybody can do. All the healthcare professionals and even patient himself can upload the details. Now, if toll-free number is used or the app is used, the PVPI will directly get the details, but it will get back to the nearby AMCs of that ADR or that patient, and they will ask to detail the ADR. So they will again go back to the patient with all the details received, and they get all the detailed information like what drug, what is the batch number, what is the expiry date, all these, what type of reaction they have seen, did they treat that reaction, and did they stop the drug. All these details will be taken up by the AMCs, and they will again upload in the software which is prescribed by the PVPI. So this is a software which is given by PVPI to all the AMCs, which is called as VigiFlow. So in this software only the ADRs have to be uploaded. So I'm just sharing few of the cases which were reported to GMC. This is toxic epidermal necrolysis induced by carbamazepine. So she came and admitted, and later on she was discharged after it is being cured. And she was illiterate, so we had to give a drug alert card because she is not able to spell the drug carbamazepine. And so she has, and we insisted to carry the drug alert card wherever she sees the physicians anywhere else. So this is another case of fixed drug eruption with amoxiclav. Later it was cured. Blisters with diclofenac, which is widely commonly used drug. Amoxicillin and clavulanate showed intense blisters throughout the body. Hyperpigmentation with norfloxacin. Stevens-Johnson syndrome with paracetamol and aceclonate, which is widely used. Not all the patients will show such reactions. Some are idiosyncratic reactions, but it may be severe. So all these have to be reported. Diclofenac induced fixed drug eruption bullous lesions. Toxic epidermal necrolysis induced by carbamazepine. Fixed drug eruptions induced by norflox and tinidazole combination. Erythematous rash with methotrexate. Diclofenac fixed drug eruption. So all these are some of the ADRs which were reported to our AMC, and we have processed all these details to PVPI through the VigiFlow software. So what happens? So if we report such ADRs, these are processed in National Coordinating Center, IPC, and they will generate a signal. If such reports are received from various AMCs or various centers, so they process these ADRs and go for a causality assessment, and then they give drug safety alerts. So I'm just sharing some of the monthly drug safety alerts which were published by PVPI. So here if you see ceftriaxone, so QT prolongation was seen in many areas. So they have given an alert, and they said they say that all the physicians must watch for this adverse drug reaction to ceftriaxone. The other drug is levosulpiride, which is showing ADR as restless leg syndrome. And another drug safety alert, which was published in June very recently, teneligliptin, an anti-diabetic drug, shows bullous pemphigoid. So all the physicians have to be watchful for such ADRs, which were not given previously in the literature. So in brief, we can say that dying from a disease is sometimes unavoidable, but dying from a medicine is never acceptable. So here safety comes first of the patient. So that is a reason why pharmacovigilance is essential. Thank you.
Thank you, madam. It was very nice.
Yeah. Go ahead. Go ahead.
Yeah, it was very nice listening to you, and hope we'll all report a lot of reactions that we see day in and day out. And there is always a feeling for physicians that we keep reporting more, and people may be a little hesitant of taking our allopathy as well.
Yes.
Thank you for your good presentation. And next we'll move on to the next speaker.
Morning.
Morning, sir.
So for the next speaker, we have Dr. Nishant, MDD in Cardiology. He will be presenting his topic, the golden hour in myocardial infarction identification and management.
Good morning, everybody. Thanks, IMA APS, for giving me this opportunity. Can I share my screen now?
Yes, sir. You can share your screen, sir, please.
Just a second. Okay, can I start my presentation, please?
Yes, sir. Please, sir. Please go ahead. Please change that screen mode to slideshow, sir. Bottom right side. Yeah. Yes.
Yeah, that's it, right?
Yes. Yes.
Okay.
Please
So,
go ahead.
good morning, everybody. I'm Dr. Nishant, interventional cardiologist in Trust Hospital, Kakinada. So, the topic that was given to me today was golden hour in acute myocardial infarction, management and identification. Now, the first thing everybody has to understand and realize is that the golden hour in myocardial infarction management is not just drugs or angioplasty, but it is more about education and coordination. So we'll just go ahead and see what it is. Acute myocardial infarction has a very high mortality rate out of hospital. Data indicate that at least 1/3 of patients die before coming to the hospital, and another 40 to 50% people are dead on arrival. And 5 to 10% of the patients will die within the first 12 months after their MI. And readmissions are also very common, that to the rate of 50% in the first 12 months after initial MI. And the problem is the most of these deaths do happen only in the first 1 hour of the myocardial infarction. The myocardial cells are irreversibly injured within 20 minutes of the coronary occlusion, and myocardial cells will be completely necrotic by around 6 hours. If you see this slide, here you just see the importance of the most important factor in the management of myocardial infarction is time. If you see, for the similar time of initiation of a CPR in a patient with a defib, the delay in defibrillation, the delay in time to defibrillation affects the mortality. Now, early defib, if the CPR is initiated within 2 minutes and the patient is defibrillated by 4 minutes, 30% survival rate is reported. But as the time to defibrillation extends, the survival rate is very low. This is a very important point we have to keep in mind. So, the golden hour has become a widely recognizable term in the field of cardiology, and communities and states are encouraged to develop and implement regional and statewide plans to ensure that MI patients receive appropriate care within 1 hour of the injury. So, what are the various aspects where we have to look into to ensure this golden hour is properly utilized? Now, in myocardial infarction, the most important determinant of the outcome is time. We all know the famous adage, time is muscle. Now, there are certain time frames which everybody has to understand and remember. We all know about door to balloon time. Most of the hospitals, they talk about door to balloon time and door to needle time. But from the patient perspective, the door to balloon time, that is the patient having an angioplasty, say within 90 minutes of coming to the hospital, is more of an indicator of the hospital's efficiency in conducting the treatment rather than for the patient. As it is not a community indicator, it is a hospital indicator. But as a community indicator, the most important time we have to look at in treatment of MI patients is total ischemic time. This total ischemic time is the time from the starting of the symptoms of the patient to the balloon time. And this time, if a community is running a program effectively to utilize the golden hour, this time should be less than 120 minutes. Please remember this. So this time has two components: symptom to door time, that is the time from the patient having symptoms to reaching a hospital, and door to balloon time. So these two put together is around 120 minutes, should be less than 120 minutes. And if the patient goes to a center where reperfusion strategies are not available, that is primary angioplasty or thrombolysis is not available, the door in and door out time should be less than 10 minutes. So these are quality indicators which we should remember and try to achieve. In 1980, ACC-AHA called the community as the ultimate coronary care unit. Please remember this. The most important component of maintaining golden hour in myocardial infarction is the community itself. So when you are having a plan to get the golden hour in place or to utilize the golden hour to the best, the goals of a community plan in patients with acute coronary syndrome is, if a patient is eligible for reperfusion by thrombolysis, angioplasty, or CABG, they should achieve the reperfusion, at least thrombolysis or angioplasty within 120 minutes and CABG if required. And even with bystander delays or patient delays, 3 to 4 hours should be the maximum time before the patient gets his treatment. Now, the golden hour is actually a takeoff from the trauma care. Trauma care, where the golden hour is quite straightforward, usually 911 access or para 708 access, and there is a trauma center and the intervention happens. But when the same thing was applied to cardiology, 3 levels of coordination were required. First is at the patient level. Second is at the level of the emergency medical response. Now, this emergency medical response could be in terms of ambulances or in terms of primary healthcare centers or community health centers where the patient actually approaches first. Then third is the hospital response. Now, you see this. The problem here is, first we take the patient. The patient experiences symptoms of heart attack. He has a chest pain or sweating or breathlessness. Now, here the first and foremost, what people have to be educated. If you really want to utilize the golden hour and make sure the patient gets the treatment in the correct period of time, patient should be educated about the symptoms of a heart attack, especially about the atypical symptoms, especially in patients' diabetes. We see many times patient coming to us saying that they were having abdominal bloating and upper epigastric pain, which they mistook for gastritis. They approach some local physician or a quack, and they are given some APD medicines and they're sent home, only to find 6 to 8 hours later they come with a full-fledged all blown out myocardial infarction. So the symptoms of heart attack or the atypical, especially the atypical presentations, especially in patients with diabetes, should be taught to the patients. And once the patient knows his symptoms are cardiac, the patient should be educated to directly report to the healthcare services. Now here in US, and where there is an emergency service number like 911, where they can call and kind of reach out, a similar kind of initiative should be taken in our country also, to make sure that the patients have a single contact number which they should call when they can get a symptoms of a heart attack. Now, what usually happens is either they ignore the symptoms or they drive themselves to the hospital, which is very dangerous, or they self-medicate. And if they do not understand the symptoms, then they usually go to other people where they don't actually get the correct treatment and the golden hour is wasted. Then the next important system is the EMS system. The EMS system has a number of components like public health, hospitals, academic institutions, work sites, voluntary public facilities, and clinical outpatient settings. So here, one important thing we should understand are, one is the work sites, two is the public facilities, these and public health departments. Now, these are the places, academic institutions. Now, these are the places where the presence of a defibrillator would be of great help in preventing acute heart attacks. Always remember that for a witnessed cardiac arrest, if CPR is initiated early enough, patient survives and gets to the hospital. Now, these public places are places where we should have a defibrillator available, and at least one person in the family should be trained in basic CPR. Then only we can actually take care of the golden hour. Now, once the patient has a contact, if the ambulance comes or he comes to a hospital, now the time frames that should be followed are within less than 10 minutes of the patient getting into the ambulance or reaching a primary hospital, a STEMI diagnosis should be made. If it's STEMI, a diagnosis should be made. And once the diagnosis is made, if there is a center capable of doing primary PCI, which the patient can reach within less than 120 minutes, the patient should be shifted there immediately. And in that center, within less than 90 minutes, the patient should have reperfusion. If the patient is not we cannot transfer a patient within 2 hours to a center for a primary PCI, then we should do fibrinolysis. And fibrinolysis should be started less than 10 minutes after the patient has been diagnosed with MI. If the patient has a capacity, here again the education comes into the play. If the patient knows that there is a hospital where primary PCI is being offered, we should encourage the patient to go there directly, or the ambulance should take the patient there directly within 10 minutes. The diagnosis should be made in 10 minutes and primary PCI should be taken up within 60 minutes. This is how you minimize this total ischemic time. And by minimizing this total ischemic time, you are able to take advantage of the golden hour. Now, if you look at the summary of the important time targets when you are maintaining the golden hour, the first medical contact to ECG and diagnosis should be less than 10 minutes. Now, these time frames are quality indicators. If a community is able to actually maintain these time frames over a period of time, we can actually save a lot of lives and also prevent a lot of morbidity. Please understand that it is not just the reperfusion. The myocardium is lost, and even if the patient survives with LV dysfunction, they have more incidence of readmissions. They can have VTAC, sudden death, and they have to go for device therapies. So both the morbidity as well as the patient's lifestyle and his financial aspects all go down, especially in a country like ours, where we are very much dependent on the government schemes. It becomes very difficult to actually get the patients back. So it's very important to maintain these time frames and use them as a quality indicators in the community to make sure that patients get the best treatment. So the maximum time from the first medical contact ECG diagnosis should be less than 10 minutes. And if the patient can go to a primary case, to a center where primary PCI can be done, it should reach that time should be less than 2 hours. If the primary PCI center is there within 2 hours of the hospital, then patient should be shifted there only. There should not be any other thought here. Now, one thing you can actually, if anybody is looking at this image very clearly. Now, please remember, you have a diagnosis of STEMI and you are shifting a patient to a primary PCI center. Now, the important thing here is coordination. Now, this is where networking of hospitals plays a huge role. The EMS people should be able to inform the center where they are going that a primary PCI is on its way. For that, the people in the ambulance should be trained to take an ECG and at least recognize a myocardial infarction. If the patients or the doctors in the primary health center or staff in the primary health center should be able to make a diagnosis of myocardial infarction, that is ST elevation MI, and they should inform the center where they are going that the primary PCI is on this way. Because if you take a patient who comes in at say 2 o'clock in the night directly to the hospital, already reaching 3 to 4 hours after the onset of STEMI, sometimes getting the whole system together and performing a PCI within 90 minutes may not be that easy. So networking is very, very, very important in this situation. This is where when we are doing a program like this, all the policymakers should understand that the maintenance of this time is very important. So these are the second thing. Now, some simple things here, a couple of simple things which I want to initiate. This is the ECG for a diagnosis of myocardial infarction, where you have more than 2 mm elevation in 2 or more contiguous slits. This should be identified. What is important when you're identifying the ECG is to know the atypical presentations, like bundle branch block and isolated posterior myocardial infarction. If the patient presents with a left bundle branch block, please remember that if the patient is having more than 5 mm elevation in a lead with a negative QRS, or more than 1 mm elevation lead with positive QRS, it is MI. It's MI in LBBB. This is an atypical presentation which people should recognize. And again, patients who are having isolated disc depression B2, which is more than 1 mm, this is an indication of a true posterior myocardial infarction. These two things should be kept in mind. And the most important thing when you're reading an MI ECG, if a patient presents with an ST elevation AVR with significant depression in all other leads, that indicates a left main coronary artery or left main coronary artery equivalent obstruction. And these are the patients that should be rushed to a cardiac center without any waste. And one thing with the troponins. Now, one of the other things, the patient presents with ST depression, you are not sure whether it's a MI or not. Please do a cardiac troponin. Now, the best way to diagnose these patients is 0 and 1 hour troponins. The troponin levels peak if it's a large MI. Within 1 hour of the infarction, they'll peak. Now, the important thing here, which I want to stress again, is a patient coming to you in the night with chest pain, with an atypical ECG, 0 hour troponin is normal. Please don't send the patient home. Do a 1 hour ECG or 1 or 3 hour trop, then only you can send the patient home, because the 0 hour trop may be normal, but at 1 hour it will peak and the patient will land up in STME. This is another thing you have to see. then of course the treatment is the primary PCI or fibrinolysis if you can't do a primary PCI. One thing I want to actually tell people here, the loading doses for in the patients in the golden hour are aspirin, clopidogrel, ticagrelor, prasugrel. But one thing we have observed, which people should be discouraged from doing, is prasugrel should be only loaded if the patient is going for an intervention. Please don't load prasugrels for unstable anginas. If you are sure it's an MI and the patient is going to be taken for intervention, then only load prasugrel. Now, if you are a patient, if you are a physician or somebody who's working in a primary care center, you have to reperfuse. The simple thing is STK, give him 30 to 60 minutes IV for 1.5 million units, or even more easier now is tenecteplase. If you have a ampule of tenecteplase with you, it's a single bolus shot. You just give a single bolus shot of tenecteplase. It is more fibrin specific than STK, but always remember that with reperfusion, you're only going to get around 60% TIMI3 flow. Most of other 40% you are not going to get. So even if you give a thrombolytic, please observe the patient for the next 2-3 hours. If there is not enough resolution of chest pain and his ST resolution is and the ST segment has not come down to 50%, take it as a failed thrombolysis and shift him to a primary PCI center for rescue PCI. So the take-home message is the golden hour is most important because it reduces the mortality. Population level, EMS level, and hospital level interventions are required to ensure that the golden hour is maintained. Now, management of these specific times requires a strong networking and public education, right from the patient side to the interventional side. The networking and education are very important. A single number, emergency number like 911 or an EMS alert will go a long way in achieving these targets. And once you relieve the patient, initiation of antiplatelet therapy followed by primary PCI, if not thrombolysis, should be available in golden hour to all the patients. Thank you very much.
Thank you, Nishant, for a lucid presentation of golden hour and the importance of the public education getting into place where people should realize that they have to get to the hospital or the care facility as early as possible. Thank you. And I think because we are running out of time, we'll not have any questions.
Karthik, can I add one more word?
Sure, sir.
Dr. Nishant, your presentation is excellent and it is useful for all the doctors of the IMA and AMS. And what I want to suggest is that the golden hour is mainly meant for the trauma and stroke cases. This you can add as a golden minute. The word may be changed from a golden hour to golden minute, maybe more appropriate for the cardiac patients.
Yes, sir. 100%.
And that you should think about it, and you can add on some change in the modality of the names. So yes, thank you very much for a good presentation.
Thank you, sir.
And you can answer all the question and answers by chat.
Sure,
thank you.
Thank you.
Yeah. Thank you. Thank you, Ramani.
Thank you, sir. Thank you for actively chairing the session. And immensely thankful to Dr. Kishore, Dr. Karthik. And now we'll go to the next session. That function. IMA AP State Academy of Medical Specialties, AMS. Online CME is being conducted on the 5th and 6th of August 2023. Now we are starting the inaugural function. I request Dr. G. Ravikrishna, President IMA AP State, to kindly join the virtual Zoom platform for the inaugural function. Lighting of the lamp now only. Let the guests come. Sham. Right. I request Dr. Sharad Kumar Agarwal, IMA National President, Honorable IMA National President, to kindly join the virtual platform of this inaugural function, sir. Dr. Sharad Kumar Agarwal. Please on your video, sir, so that the people can see all. I now request Dr. G. Srihari Rao, I'm a National Vice President, to join the virtual platform of Zoom for the inaugural function. I now call upon Dr. Pankaj Mukneja, IMA AMS National Chairman, to kindly join the platform for the inaugural function. I now call upon Dr. R. Ramesh Babu, Dean IMA CGP National Headquarters, to kindly join the virtual platform for the inaugural functions. I now call upon Dr. Abkari, IMA AMS National Secretary, to kindly join the platform for the inaugural function. I call upon Dr. P. Fanidhar, IMA AP State Honorary, to please join the platform for this inaugural function virtually. I now call upon Dr. Achyut, who is the observer from APMSI for this online conference of 2 days, to join the virtual platform for the inaugural function. I now call upon Dr. TV Ramnamurthy sir, Chairman Andhra Hospitals, who is the co-host for this online function, to kindly join the virtual platform for the inaugural function. I now call upon Dr. C. Srinivas Raju, immediate past president of IMA AP State, to join the the inaugural function of this virtual CMA. I now call upon Dr. Jayachandra Naidu, who is the president-elect of IMA AP State for the coming year, to kindly join the virtual platform for the inaugural function. I now call upon Dr. M. Ravindranath,
Madam, you are muted.
I now call upon Dr. M. Ravindranath, Honorary Finance Secretary, IMA AP State, to kindly join the virtual platform for the inaugural function. Now, let us light the lamp.
Sure, ma'am, we're doing that video.
Okay. Done? I request Dr. G. Ravikrishna sir to preside over the function, who is the president of IMA AP State.
Thank you, madam. The National President Sharad Agarwal sir joined the program. Please check. Panithar sir.
Shall I call him? He said he will join after 10 అని నాకు మెసేజ్ పెట్టినారు. Shall I call him now? Somebody.
Sir, it is good to inform him. I think you should do that.
Yeah. Yeah, very good.
Ravi Krishna sir, you can go ahead, sir.
Yes. Sir is on the line. Dr. Sharad Kumar Agarwal, sir.
No, sir, he has not joined.
Another sir is
Yeah, I am trying to call. Document technical team, somebody contacted, he said he will join after 10 o'clock.
Shyam, Dr. Pankaj Mukteja wants some help.
Okay, ma'am.
Can you help him?
Yes, yes.
His number is in the WhatsApp group.
Okay, ma'am.
sir. మీరు కాల్ చేశారు సార్, నేను చేయమంటారు సార్?
నేను చేశాను ఎత్తలేదు, మీరు చేయండి ఒకసారి. సార్ చెప్పండి. పంకజ్ గారు వస్తే స్టార్ట్. పంకజ్ ముత్నేజా గారు జాయిన్ అవుతున్నారు.
Sir, I just spoke to Venkatramana sir. Manani continue చేయమంటున్నారు sir, Ravikrishna sir.
Okay.
I just spoke.
శరద్ అగర్వాల్ సార్.
Yes.
శరద్ అగర్వాల్.
లేదు సార్, వెంకటరమణ సార్.
వెంకటరమణ.
ఆయన ఫోన్ కి ఏదో ఇష్యూ ఉందంట సార్. He said I'll join in 5 minutes. You guys.
Pankaj Mutneja. About whom you are speaking? Pankaj Mutneja జాయిన్ అయ్యారా? హలో,
టెక్నికల్ టీమ్ ఎవరున్నారు ఇక్కడ? హూ ఇస్ టెక్నికల్ పర్సన్ ఇన్ఛార్జ్?
సాత్విక.
సార్ చెప్పండి సార్.
Somebody from the technical team contacted Dr. Sharad Agarwal sir. He said he will join after 10 a.m.
Yes sir. He said he'll join after 10 a.m.
You just once again
Yes.
try to reach him, and
Okay.
you join Dr. Pankaj Mutneja, who is asking for help.
Okay sir. Okay sir. We're calling him. Satvika.
sir joins, we can start the program, and we will ask the national president to address once he joins the program.
Meanwhile, మీరు మొదలుపెట్టి మాట్లాడేద్దాంలేండి మనం మాట్లాడేస్తుంటే.
Dr. Shyam, can you, Mr. Shyam, can you make Achyutrao, Dr. Achyutrao as a panelist?
Yes, ma'am.
He's a observer, MC observer.
I welcome all the delegates, guest speakers, panelists, moderators, and IMA AMS executive committee members, IMA AP State executive team, and Honorary Secretary IMA AMS National, Dr. Sriranga Akkari Garu, for the 6th IMA AP State AMS conference. This is the 6th virtual program we are organizing, and this is a 2 days CMA program with 6 CMA credit hours by AP Medical Council. So I request Dr. Ramani Garu to present the welcome address.
Good IMA leaders of AP State as well as national level. I welcome Dr. Sharad Agarwal, sir, Sharad Kumar Agarwal, who is our chief guest today to this online conference of IMA AMS. And I also welcome our national IMA AMS chairman, Dr. Pankaj Mutneja, sir, and Dr. Akbari, who is the secretary of IMA AMS. I also welcome our president of IMA AP State, Dr. G. Ravikrishna, sir, and other leaders, Dr. P. Fanidhar, sir, and our national vice president, Dr. Srihari Rao, and our Ramesh Rai, Dr. Ramesh Rai, who is the chief, he is the Dean CGP National Headquarters. I also welcome Dr. Achyut Rao, MCI observer for this conference. I welcome all the delegates who have registered in large numbers for this conference. 1,800 delegates have registered. We are privileged to host this conference. I'm profusely thankful to Dr. Ravikrishna sir for always encouraging us to conduct conferences, monthly conferences in a regular basis, and Dr. Fanidhar sir for guiding me, and Dr. Ravindranath sir who is supporting in all manner for conduction of this conference. And my greetings to Dr. Sharad Kumar Agarwal sir, who is always on taking information of all the affairs in the states, being there physically, protesting if needed at the zero station. Thank you, sir. I had the opportunity to meet you on several occasions. I welcome Dr. Pankaj Mutneja, sir. We are carrying all your instructions. We are doing our training of our members continuously by virtual CMEs. We are planning physical conferences, and we are encouraging membership wherever it is possible. We are sending by virtually sending the PDF and asking him. So there is a lot of encouragement for IMA AMS throughout our AP State, sir. Only thing is we have to start the activity of preparing modules. We will take the modules which are available in the national level, and surely we will train our members in that aspect. Thank you, sir, for giving me this opportunity. And I request Dr. Ravikrishna sir to preside the meeting. Thank you, sir.
Thank you, madam. I would like to congratulate Dr. Ramani, Chairperson IMA AP State AMS, for organizing regular CMA programs on behalf of the IMA AP State AMS program. Now, I reserve Honorary Finance Secretary, IMA AP State, and representing on
Sorry, you are muted.
Unmute, sir. Ravi Krishna, sir.
I request Dr. M. Ravindranath, Honorary Finance Secretary of IMA AP State, and also representing Andhra Hospital, who is sponsoring for the program, for providing a Zoom platform to address the delegates on this occasion.
Nada, Ravi.
Dr. Ravindranath.
Nada.
Line lo unnaru, but meeting.
I think he.
I request Dr. P. Panidhar sir, Honorary General Secretary, IMA AP State, who is guiding all the wings and schemes in the state to address the delegates on this occasion.
I think may I request the beloved President to call upon Dr. Sriranga Apkari first, so that he is representing the national team. You let him give these. Otherwise, I will proceed. Thank you, sir, for the opportunity. I think IAMS has lived up to the expectations of the IMA AP State under the leadership of Dr. P.A. Ramani Garu and also Dr. G.T.V. Ramesh. I think Ramani is a seasoned leader for quite a long time. But Ramesh, who recently joined the state team, has shown his abilities. We also congratulate Dr. Ramesh. We also thank the Messrs. Andhra Hospitals for the excellent facilities they are providing, technical facilities mainly for 1,800 odd delegates who have registered. And I also thank Dr. Sriranga Apkari, who has joined on our request, representing the national team. The 2 days hectic program has been designed. I was a little apprehensive how best it will go on, but the first 2 sessions, they went on very well. I think the other part of the program will also go on in the similar manner and will be successful at the end. Thank you, sir. I think President is busy on some other call. May I request now Dr. Sriranga Apkari to give the inaugural message on behalf of the national team. Unmute yourself, sir. Apkari saab, unmute చేసుకోండి సార్.
Good morning, a very good morning to all of you. Dr. Ravi Krishna sir, IMA AP President, Dr. Faninder sir, Dr. Ramani madam, the national dignitaries who will be joining shortly, Sharat Kumar Agarwal sir, Dr. Sri Hari Rao sir, and then Dr. Ramesh Babu, the Dean CGP, and the entire team of AP IMA AMS. I congratulate you for planning a wonderful program. Today, the topics are very well. The speakers are distinguished speakers. I know personally quite a few of them. And already about 627 delegates are watching this program. So a huge congratulations to you. From IMA AMS, we are very happy to note this conference is going on in a very nice way. We would request you to conduct regular CME programs and then also send your monthly report so that the wonderful activity done can be reflected in our newsletter so that people all across India will know the wonderful work being done by the AP team. We would also like to request to start a lot of courses of IMA AMS. There are courses in infertility, laparoscopy, and other new modules also have been created. We'll personally talk and then let you know all the modules available so that these courses, which are primarily for upgrading the knowledge of people, can be started immediately. Also would like to inform that national conference will be held in the next month. Details will follow soon. It will be held in Kerala. And we have also invited applications for fellowships of IMAMS, that is FIAMS fellowship applications. So request all of you to send. The details have already been sent to the respective chairpersons and the state president and secretary. So with this short, I wouldn't be taking much of time. Wish the conference a huge success. And then any support from our side, we are more than happy to extend. And even for the monthly CME programs or webinars, if you require any Zoom link, we are free. We are going to provide them at free of cost with prior intimation. Thank you. Thank you so much for inviting me and having me here. Thank you.
Thank you, Dr. Abkari, Sir Srirang Abkari, for joining the program and giving the message. Dr. Sharad Kumar Agarwal sir called me that he is in another meeting. He will join after 1 hour and address the delegates with the message. So after 1 hour, he will, national president will join. Meanwhile, elect Dr. Srihari, Dr. Rai Pramesh Babu, if they are on the Zoom platform, we will ask them to address the delegates. Otherwise, with my closing remarks, we can start the academic sessions.
Yeah, we'll start. Yes.
The technical team,
Yes,
please
sir.
play the lighting the lamp and
Sure, sir. You want me
to mark the inauguration of the
Yes, sir.
IMA AMS CME program.
Music లేదా
Okay.
Yes, sir.
Once after joining the national president, and myself and national president will speak for a few minutes at that time. Meanwhile, I will we can go ahead with the academic program. I request Dr. Ramani Garu to continue the CME program. After the meeting, he will join the Zoom platform and address the gathering on the Zoom platform. So after 1 hour, we can take a 10 minutes break for national president's message.
Okay, sir. I request Dr. Ramesh Babu Raivarpu, Dean IMA CGP National Headquarters, to address the conference delegates. Dr. Ramesh Babu.
Has he joined?
Is going on, right? Yes, on.
He's not this. He's there. He has joined. Like.
CH Ramesh.
I request Ramesh. Dr. Achyut, MCA observer to this online conference. Please address the conference.
Dr. Ramesh Babu sir is here.
Invite Dr. R. Ramesh Babu, Dean IMA CGP headquarters to address the delegates. Nara line lo.
అవును సార్ జాయిన్ అయ్యారు సార్ ప్యానలిస్ట్ లో ఉన్నారు.
Dr. D. Srihari Rao, sir, National Vice President.
Srihari might not join. He may not join. He may not join, madam.
He is not on the Zoom platform. Dr. Ramesh is there.
No,
CH Ramesh, not yes. The initial integration program is there. We can close it, and after 1 hour, once the national president joins the program,
we can the function, sir?
Yes, we can proceed with the academic session. After 1 hour, once national president joins the Zoom platform, we can ask him to address the delegates and give his message.
Dr. GTV Ramesh to present vote of thanks to.
Or actually, if Ashit Kumar sir, APMC observer is there, we can ask APMC observer to address the delegates.
I'm not saying he's there. Okay. Dr. Achyut, are you there, Dr. Achyut?
He was there a while ago, ma'am, but I don't see him here.
He was there, yes.
Yes. He was part of the panel.
You can proceed with the CMA program. The schedule will be delayed.
Shall we do the vote of thanks, sir?
Yes.
Later.
Yes.
Dr. GTV Ramesh. Dr. GTV Ramesh, please, if you are there, please present the vote of thanks. He's not there.
Sir, Dr. GTV Ramesh sir, present the vote of thanks, and we can close the formal inauguration.
I don't know, he is there.
And continue with the CMA program.
Can you hear me? Am I audible?
Yes, you are audible, sir. Please present.
Yeah. We are already running a bit late. Okay. Anyway, thank you, sir, Dr. G. Ravikrishnan Garu, President IMA AP State, for presiding over this function. And I will be waiting for Dr. Sharat Kumar Agarwal, IMA National President, to join us shortly. Thank you, Dr. Sri Harirao Garu, IMA National Vice President, and IMA AMS National Chairman, Pankaj Mutneja, and Dr. Abkari, our IMA AMS National Secretary, and then Dr. Ramesh Babu, Dean IMA CGP, Dr. Panidhar is our IMA AP State Honorary General Secretary, and Dr. Achyut, our NCI observer for this conference, Dr. TV Ramanamurthy, Chairman of Andhra Hospitals, Dr. Srinivas Raju Garu, immediate past State President of AP, and Dr. J.C. Naidu Garu, President-elect of IMA AP State, Dr. M. Ravindranath, Honorary Finance Secretary, IMA AP State. And thank you, Ramani, for all the efforts you have taken, and you've really brought this forum to a beautiful, lively situation. Thank you, Ramani, for all your efforts once again. And thank the chief guest for lighting the lamp and marking the inauguration. And thanking you all, sir. We'll proceed with the next program. And as and when the national president joins, we'll have a brief pause again for this function. Thank you.
Thank you, Sir. Please continue with the CMA program.
Yeah.
Thank you.
Thanks.
For the next session, now we'll start. We have two moderators with us, Dr. Sunil Kumar, who is an MD, DDCD, Professor and HOD, Superintendent, Chest Diseases Hospital, Visakhapatnam, and Dr. G.L. Sushmita, Pulmonologist, Medicover Hospitals, Nellore. Next, we have our topics and our presenters. Management of Inflammatory Arthritis in Young Adults by Dr. Ramakrishna Naidu. Sir, have you joined? Sir, have you joined? Dr. Ramakrishna Naidu?
Yes, I'm there.
Okay. Okay, so I'll request our moderators to start with this session.
Good morning, all. Am I audible, madam? Madam, am I audible?
Yes, sir.
Yes, sir. Yes, sir, you're audible.
Yeah, thank you. Good morning, one and all. And welcome to this wonderful session in the IMA as well as Andhra Hospital. And today, in this session, we are discussing 4 topics. First of all, I request and I welcome Dr. A. Ramakrishna Naidu Garu, MD/DM, Rheumatology, Associate Professor of Medicine, Government Medical College, Vizianagaram, to give us a lecture about the management of inflammatory arthritis in young adults, which is very important because the early diagnosis of it and treatment can treat it completely, and it also can prevent lifelong arthritis complication in the young adult. I welcome Dr. Ramakrishna Naidu. Over to you, sir.
Thank you, sir. Thank you, everyone. Good morning, all, Ramani Madam and all leaders and elders in the group. So, my job is here today is to give a brief overview about management of arthritis in young adults. As you know, arthritis is inflammation of the joint and sequelae of the symptomatology. And if you see 25% of all the consultations in a primary care practice settings, most of them are musculoskeletal symptoms. The majority are self-limiting with soft tissue rheumatism. Sometimes it may pose a challenge to diagnose, and it may pose a challenge to manage, especially in young adults who want to become parents. So, context is treating. I'm dealing with the management of arthritis in young adults. I'm excluding geriatric population and pediatric population. So, as you know, we can identify arthritis depending on the onset of the arthritis. It can be acute onset or it can be insidious onset. If you see this, my slide, reactive arthritis, viral arthritis, induced arthritis, septic arthritis, such arthritis may present acutely, whereas osteoarthritis, seropositive or seronegative arthritis, and JA, indolent infections, neuropathic arthropathy, they can slowly progress and insidious onset arthritis. And most often, acute self-limiting arthritis, acute or self-limiting. And whereas insidious onset arthritis present as chronic, and they will progress with sequelae, with morbidity and increase in mortality. So, depending on the number of the joints, if more than 4 or 5 joints, so we identify as a polyarthritis. If more than, if less than 4 joints and more than 1 joint, it is osteoarticular arthritis or oligoarticular arthritis. If 1 joint is involved, it is monoarthritis. And any arthritis can be at the presentation as a monoarticular presentation. And so various types of arthritis can present like monoarthritis. If you take examples like distal-induced arthritis, especially gouty arthritis, and CPPD arthritis, septic arthritis, or any other infective arthritis, sometimes trauma, hemarthrosis, or any inflammatory arthritis can start with a single joint involvement. Oligoarticular arthritis, best example is reactive arthritis and post-streptococcal reactive arthritis. Sometimes seronegative arthritis and any other inflammatory arthritis can present with a few joints involvement at the stage of the initial beginning stage. And depending on the pattern, if you take rheumatoid arthritis, so like number of joints keep on adding over a time, that is additive pattern. If you take crystal-induced arthritis or gouty arthritis, usually every attack will be there, and it is punctuated or paused by a period of complete remission or quiescence. So that is type of the arthritis in case of crystal arthritis. And migratory pattern is the best example in pediatric population, that is acute rheumatic fever, where so one joint will resolve and another joint will be like getting involved. That is the type of the arthritis. So like if you take the best example of polyarthritis, rheumatoid arthritis, if you see the right side picture, that is human kilogram. So insidious onset affects both small and small joints of the hands and feet commonly, though it can involve any other synovial joints. So the typical involvement is symmetrical small joint involvement of the hands and feet, and polyarticular in nature and chronic in nature. And this is the this picture shows what are the typical deformities which can appear in advanced stages of rheumatoid arthritis. The botanic deformity, the spinal deformity. Though the hands will be deformed as the disease progresses and as the disease worsens. And here, distal interphalangeal joints never get involved, except few rare occasions in rheumatoid arthritis. So rheumatoid factor positivity does not mean always rheumatoid arthritis. It can present in a normal population up to 5 to 10% of the people, in especially as the age progresses, and other connective tissue diseases, and sometimes infections and bacterial endocarditis. Radiological picture in a rheumatoid arthritis can be showing like as this X-ray film showing periarticular osteoporosis, periarticular erosions, and secondary osteoarthritis in advanced stages with the body ankylosing. So these are the radiological. So rheumatoid arthritis not only involve joints, it can also get involved other than joints, like they can have eye involvement, they can have lung, cardiac, vasculitis, neuropathy, or Feltis syndrome in a hematological manifestation. And coming to the spondyloarthropathy, where the group of arthritis where they can have common features of inflammatory back pain and arthritis and or enthesitis. So this group includes ankylosing spondylitis, reactive arthritis, psoriatic spondyloarthropathy, inflammatory bowel disease associated, that is also known as intrahepatic associated spondyloarthropathy, juvenile spondyloarthropathy, unclassifiable or undifferentiated spondyloarthropathy. So let us see what is inflammatory back pain. So onset of the back pain in a patient who is less than 45 years of age, which is insidious and chronic more than 3 months duration, with early morning stiffness of more than 30 minutes, which can improve with activity, nocturnal awakenings, and HLA-B27 positivity, and enthesitis. The right side of pictures shows the human kilogram, shows they can have dactylitis sometimes. The heel enthesitis can be there. So this is how a spondyloarthritis patient can present like. So X-ray, if you take X-rays of the particular patient, especially ankylosing spondylitis patient, if you see bilateral sacroiliitis, bamboo span-like appearance of the dorsal lumbar spine is commonest presentation in late stages of ankylosing spondylitis. So psoriatic arthritis also mimic rheumatoid arthritis, which can be symmetrical sometimes, also asymmetrical sometimes. High frequency of distal interphalangeal joint involvement is the typical feature of a psoriatic arthritis, although they can have dactylitis and enthesitis apart from arthritis. So like if you see the right side panel, you can see psoriatic nails, psoriatic patches with rheumatoid arthritis like deformities and enthesitis, retrocarpinal enthesitis, secondodactylitis. These are the presentations of psoriatic arthritis. And carbon asymmetrical oligoarthritis is reactive arthritis, especially after urethritis, after sericitis, or post-diarrheal arthritis. They can have arthritis, conjunctivitis, and apart from the recent recovery from urethritis or diarrhea. They also can have mucocutaneous manifestation like balanitis, keratoderma blennerologicum. So the left side panel is showing cutaneous manifestation in a reactive arthritis. The right side panel is showing swollen left knee and dactylitis of the toes. And as I told you, it can also be seen in inflammatory bowel disease, where our gastroenterology patients who comes to a rheumatologist with the presentation of back pain and other peripheral arthritis, sometimes uveitis, sometimes skin manifestation like pyoderma gangrenosum. So we can identify them depending on the history. And this is a typical picture of a gouty arthritis, where you can see a gouty tophi over a right first metatarsophalangeal, that is acute podagra acute gouty arthritis. And the tophi can also be seen in over the ear lobules, and sometimes it can present like rheumatoid arthritis if it is so chronic in nature. Like tophi can be deposited over MCP joints, PIP joints. They can mimic like rheumatoid arthritis, sometimes mimic like psoriatic arthritis. And so osteoarthritis is seen in the elderly most commonly, but in a patient with genetic predisposition, they can have early osteoarthritis also. X-ray findings will tell us like sharpening of the edges, subchondral sclerosis, subchondral cyst, osteophytes, deformities. And so these are the clues to identify osteoarthritis from an inflammatory arthritis. So if you take this, take a careful view at this hemoclogram. So first one is rheumatoid arthritis, where small joints of the hands and feet, excluding DIP joints. Second one is psoriatic arthritis, where DIP joints predominantly get involved. Third one is reactive arthritis, where oligoarticular arthritis. So fourth one is ankylosing spondylitis, which is a typical spondyloarthropathy. Fifth one is osteoarthritis, where DIP joints and the first carpometacarpal joints commonly get involved. So this pattern can, with this pattern, we can identify. And sometimes mucosal involvement along with arthritis, we have to suspect other diseases like SLE, Behçet's, business GP, granulomatous, like and malignancies and other diseases. And arthritis with eye changes also we can suspect arthritis or connective tissue disease sometimes and vasculitis. Okay, and so eye changes, sometimes a patient may directly goes to ophthalmologist. Later on evaluation, they will again going back to rheumatologist for further evaluation. Right. So some local pattern of the disease also can mimic arthritis, especially diabetes with chiroarthropathy, sometimes cancer associated form of fasciitis, and systemic sclerosis and amyloidosis we should not forget. And if you see this algorithm, when a patient comes to you with a joint pain, so we have to decide inflammatory or non-inflammatory. Non-inflammatory, we can rule out with history, degenerative arthritis and other types of like hypermobile joints can also have non-inflammatory features. And inflammatory, we have to see whether autoimmune nature or crystal arthritis or infection. Autoimmune, so more commonly like the rheumatoid arthritis, spondyloarthropathies, and connective tissue disease or vasculitis. That is how we have to differentiate. If a patient comes to you with the acute monoarticular arthritis, history should be perfect and examination thoroughly. Look for any other evidences, mucosal and other evidences. Clinical impression, if it's septic arthritis, or is it a crystal arthritis, or is it a bursitis, cellulitis, we have to evaluate and do arthrocentesis. And if it is suggestive septic arthritis, treat accordingly, or else we have to look for other causes of inflammatory arthritis. It may be early feature of any other polyarticular or any inflammatory oligoarticular arthritis. So like coming to oligoarthritis, it can with systemic illnesses, we can suspect rheumatoid, other infections like HIV, cancers like lymphoma or adult consistent disease. And if no other systemic features, we can suspect osteoarthritis or spondyloarthropathy or cystitis or paraneoplasty. In a patient with back pain, when we are having a patient with back pain, we have to look for other spondyloarthropathy manifestation like enthesitis of the heel, family history in a first degree relatives, uveitis in the family or in the particular patient, asymmetrical arthritis, good response to NSAIDs. All these features are spondyloarthropathy feature. We have to take appropriate X-rays, and if suggestive of spondyloarthropathy, we have to also check for HLA-B27. If it is positive, more likely spondyloarthropathy. If it is negative, still the features are suggestive of spondyloarthropathy. We can take it as spondyloarthropathy. If features and HLA-B27 and imaging are negative, we have to consider other diagnosis. This is how we have to identify spondyloarthropathy. So coming to classification of the rheumatoid arthritis, like this is the latest classification by ACR-ULR. A number of joints involved. We'll be giving scoring and depending on the presence of the antibody positivity for rheumatoid factor and ACPA and duration of the disease and acute phase reactants elevation, whether negative or more than 2 to 3 times elevation. So scoring system is given. Depending if the more than 6 if the patient scores more than 6, we can diagnose. There is a catch in this classification. Even sometimes you can see rheumatoid arthritis patients also can score less than 6. Still, it can be rheumatoid. So this is what I want to stress with this slide. So even in this patient, you can have swollen joints of 1 to 3 joints scores only 3, rheumatoid factor negative, and 2 weeks duration, elevated CRP, and so that scores less than 6. But if you carefully follow this patient, like they may get evolved into rheumatoid arthritis in the later stages. So like classification is classification, not a diagnostic criteria. Similarly, this is a false positive classification where osteoarthritis patient can be scored more than 6, and we can wrongly make a diagnosis of or classify as a osteoarthritis. So PAP joint involvement, all DAP, PAP. So every like where all DAP, PAP, thumb, interphalangeal CMC joints and knee joints involved scores more than 5, and so even rheumatoid factor negativity, long-standing, because of the long-standing disease, they can score 1, so that equals to score more than 6. Acute phase reactant, whether present or absent, so still he can score more than 6. So wrongly we can make a diagnosis of rheumatoid arthritis, but this is a patient of osteoarthritis. So we have to keep those in mind. And coming to the principles of management of rheumatoid arthritis and other arthritis, I am giving we have to make an early diagnosis and treat. Combination of DMARDs wherever necessary, anti-cytokine therapy or biologicals wherever necessary, and treatment outcomes we should be assessing, and treat also comorbid conditions. Like in the earlier days, like gold, salt, and sulfasalazine and hydroxychloroquine, aspirin were the initial drugs to treat rheumatoid, and later on steroid was added. So now we have biologicals and all from 2000 onwards. So we have to find why should we treat a patient with a rheumatoid arthritis very early? Because radiographic progression occurs early and continues over lifetime in a patient with rheumatoid. So 70% of the patients will have radiographic damage within the first 3 years. So it is very important to treat a rheumatoid patient very early, so that prevent progression of the damage and morbidity. So commonly used drugs are methotrexate, hydroxychloroquine, sulfasalazine, leflunomide. Less commonly used drugs are parenteral or oral gold salts. So now we are not using. Cyclosporine was also not used. Levamisole, D-penicillin, minocycline, azathioprine, cyclophosphamide. These are all drugs which have been used very earlier days. Now we are not used. And so the approach is like we start with one disease modifying agent. If no suboptimal response, we add another drug, another DMARD, or we don't get a further response, again we add another DMARD. So until we reach the desired clinical response, tight control of the disease is our target. So that is the approach. But we have to follow the ACR and URAL guidelines. And if I cannot discuss all those things, like we can discuss it in brief later. And so these are the drugs commonly used: hydroxychloroquine, methotrexate, sulfasalazine, leflunomide are the main drugs. Methotrexate is the main DMARD of choice in rheumatoid arthritis. Hydroxychloroquine is added on therapy. Sulfasalazine, leflunomide, other DMARDs which can be added on in a patient with rheumatoid arthritis. Because of the short action, onset of action is very late. Remission sometimes very late. Sometimes we may become refractory. So we can go for anti-cytokine therapy like anti-TNF agents and interleukin neutralization, anti-B-cell therapy like rituximab, and even tocilizumab, that is anti-interleukin 6 also can be tried. So these are the recent drugs which are in the pipeline of treating rheumatoid arthritis: infliximab, etanercept, adalimumab, anakinra, abatacept, and rituximab. These are the drugs commonly we use. And how do we manage a patient with ankylosing spondylitis? So targets are relief of the pain and inflammation, maintenance of the best possible posture, and joint movement preservation. So that we can improve the quality of life of the patient with ankylosing spondylitis. So we consider current diagnosis, current disease manifestation, develop the symptoms and disease activity and prognostic indicators, and age, gender, and comorbidity and psychosocial factors of in a particular individual. So old approach, it was very slow and less aggressive, so that as this diagram is showing, the deforming posture is very rapid. So new approach is to make an early diagnosis, emphasis on limiting the progression. Earlier aggressive therapy may, even with the use of biological agents, may limit the toxicity and may prevent the or slow the progression of the disease also. So ACR ULA recommendation for the management of ankylosing spondylitis, like education, exercise, physical therapy, rehabilitation of the patient, and self-help groups with the help of the self-help groups and associations. Apart from that, pharmacotherapy includes NSAIDs for axial disease, for peripheral disease, sulfasalazine, local steroids, and for both axial disease and peripheral disease, we can go for TNF blockers if there is no adequate response. So NSAIDs provide symptom relief and sometimes may reduce inflammation. Methotrexate, sulfasalazine, methotrexate no evidence of the efficacy. Sulfasalazine limited efficacy. Thalidomide, palmitonide, they have shown some efficacy in clinical risk, but is not regularly used. Etanercept, infliximab, adalimumab are proven efficacy in the ankylosing spondylitis. Leflunomide, there is no evidence of efficacy. But here, I would like to add here, even though there is no efficacy, when patient is unable to buy a particular biological, we still use these anti-DMARDs. So when a patient is actively having ankylosing spondylitis, we should consider TNF blockers. This is the guideline. So no guideline is recommending any DMARDs in ankylosing spondylitis axial disease. Isolated sarcoiditis, we can treat with local steroids. Peripheral arthritis also we can consider local steroids. NSAIDs also we can treat with the local steroids. And physical therapy is very important. Systemic glucocorticoids is not recommended, especially for peripheral, except for peripheral flare and pregnancy and IBD flare. So, this is the guidelines to treat ankylosing spondylitis. In advanced case, hip arthroplasty, depending on the advanced hip arthritis, kyphosis, we have to correct it. Iritis and recurrent iritis should be treated by ophthalmologist, but as such, treating ankylosing spondylitis itself will reduce the flares of the iritis and IBD also sometimes. So, like, what are the concern? A lot of the concerns in a young adults, especially who are planning to become parents. Like, this is the highlighted discussion of today's my topic is like. So, if you take some of the connective diseases and vasculitis, like how they interact with the pregnancy. If you see rheumatoid arthritis, usually up to 50 to 70% of the rheumatoid arthritis patient will improve during pregnancy, whereas maternal complications are very rare, almost not known. Rheumatoid arthritis. Risk of pregnancy complications are moderately increased, but risk for fetus and neonate is almost very rare in case of rheumatoid arthritis. But it is very, but whereas if you take systemic lupus erythematosus and antiphospholipid syndrome, they both flare more than 50% of the cases. Most of the complications are renal complications in case of SLE. Hypertension, preeclampsia, prematurity are the risks for the pregnancy, and fetal loss, IUD and low birth weight, neonatal lupus are the main risk for fetus and neonate. So vasculitis, progression of the renal insufficiency and heart failure and renal and pulmonary diseases are known during unknown during pregnancy. But fetal loss, intrauterine growth restriction, low birth weight is commonly seen with ANCA vasculitis, but not very common with systemic sclerosis. So, so the drugs what we commonly used in inflammatory arthritis. So, at their teratogenicity, what are the what are the precautions we have to take? Methotrexate is the most common drug we use in treating inflammatory arthritis. It is a known teratogen, and they can lead to multiple congenital abnormalities, especially of the nervous system, known as amenorrhea syndrome. And it is labeled as X by FDA. We cannot, it is strictly contraindicated during pregnancy. And if anybody wants to become parented, they should stop at least 3 months before attempting both men and women. And should not be used during lactation because it can be excreted in the breast milk. And in males also, as I told you, like reversible decrease in sperm count is known. And that's why they also advise to stop at least 3 months before attempt conception. Coming to the other drug, leflunomide, it is teratogenic in animals. Therefore, it should not be used in women with the childbearing age. It should be very cautious when we are prescribing leflunomide. And it is contraindicated strictly in pregnancy and breastfeeding. So leflunomide, if anybody, any a young adult wants to become like parent, it should be stopped at least 3 months before planning conception. But thing is like with we have to wash out with cholestyramine for 11 days. Then only we have to plan. In a particular individual can plan conception with the leflunomide. Whereas if cholestyramine washout is not done, usually what we advise for a patient with arthritis who is using leflunomide, they should avoid at least 3 years for conception. So that is the problem with leflunomide. So be cautious while prescribing leflunomide. Cyclophosphamide, they can cause irreversible agiospermia, especially when a total dose of more than 18 grams of cyclophosphamide is used. And even though plasma testosterone levels remains normal, it is still toxic if more than 18 grams of cyclophosphamide is given to a patient, male patient with arthritis. And in a patient with antiphospholipid syndrome, if you where antiphospholipid syndrome is like characterized by recurrent pregnancy loss and arterial venous thrombotic manifestation. In a patient, they usually first time most often we are taking those cases from obstetric and gynec colleagues where they have find out that the particular patient has recurrent pregnancy loss. So this is a precious pregnancy. What to be done for this patient? Such a referral we get very frequently to a rheumatologist from a gynec and obstetrician. And so if a patient with one thrombotic manifestation, lifelong anticonvulsion therapy is the mainstay of treatment, and INR should be maintained between 2 and 3. And if there are recurrent thrombosis, we have to maintain INR 3 to 4 with anticoagulation. So to prevent pregnancy losses in APS, low-dose aspirin should be instituted in the preconception period. Addition of once daily subcutaneous heparin, whether it can be low molecular or unfractionated, on confirmation of the pregnancy throughout the pregnancy is indicated. And if the patient is having the antibody positivity, but no way to predict the any clinical obstetric events and no history of any clinical event or obstetric events. So there is only we recommend only low dose aspirin and hydroxychloroquine before and during the pregnancy also. Most often we get a patient pregnant patients who are pregnant, they are coming with a referral to see whether to stop hydroxychloroquine or not. So here, like you want to mention very clearly, hydroxychloroquine is very good and useful to prevent pregnancy losses in a like asymptomatic patient. So in SLE and pregnancy is the most deadly complication, and best prevention of pregnancy morbidity is to prevent the SLE flares during the pregnancy. So the best way is to delay the conception until the woman has had remission of the SLE, at least for 6 months. At least 6 months, there should not be any flare of the SLE. Then only we advise them to become pregnant. Otherwise, it is very difficult to control during pregnancy. And HCQ can be started before pregnancy, and during pregnancy, it should not be stopped both in APS and SLE, because it can decrease the risk of the SLE flares in pregnant SLE patients. And also, prognosis of the SLE nephrite, progression of the SLE nephrite is also can be slowed down and prevent sometimes death also. That is what literature says. And so mild activity of a SLE disease can be treated with low dose prednisolone that should be less than 20 milligrams only, because twofold increased risk of cleft lip and palate with systemic corticosteroid use. We should be cautious. That's why we try to maintain the dose of steroid at lesser than 20 milligrams per day. NSAIDs, if at all required, in the last trimester only, but not in the first trimester, and sometimes during the second trimester also, if at all required. Thank you.
That's very nice of you, Dr. Ramakrishna again. Thank you very much for the extensive coverage of the topic. I don't expect any doubts across the audience. Okay, if there is no doubt, then we'll move on.
Thank you so much, sir.
Yeah. Madam, tell me.
Okay. So since we are running out of time, we would like to go over to our next speaker, who is Dr. Manoj Kumar, on the topic management of fever in ICU patients.
Okay, thank you, Dr. Naidu. Thank you.
So you can start with your presentation now.
Move on to the next lecture. That is management of fever in ICU, Dr. Naidu.
Hello. Hello.
Yeah, good afternoon.
Sir, you can see the slides, sir.
You can share the slides. Go ahead, doctor.
Yeah. Good morning, everybody. Can you see the slides now, sir?
Yes, we can see.
Yeah. Thank you, AMS, for giving me this opportunity for talking this important topic, fever in ICUs. Actually, what we see regularly in OPDs are different. What we see in a hello.
You are audible. You go ahead, sir. Please go ahead.
So what we see in ICU are different. So basically, first, before going to actual discussion, I just want to show a typical case of what we see in ICUs, the fever. A 70-year male is a known case of diabetes, hypertension, COPD, and atrial fibrillation.
is admitted to ICU at present with a cerebrovascular accident and hypotension. So past there is a history of lymphoma, is also on a chemotherapy. Now because of his sepsis, he was on ventilator. He was also started on inotropes and some antibiotics. He developed a fever in hospital third day, 100 degrees Fahrenheit. So most of the time, either it may be admitted under some physician, or sometimes it may be admitted from the neurologist. As a physician, we get a referral to see these patients. So in this scenario, if you go through the investigations, the total count is 16,000. In urine, there is 8 to 10 pus cells. And chest X-ray showed some bilateral basal haziness, and his CPK is raised because he is also a known case of CAD. His CRP also raised, and the CT scan, there is a IC bleed. So ET culture, there is a, because he is already intubated, it showed Acinetobacter. Basically, he is a previously lymphoma patient. He is also receiving chemotherapy. So he is immunocompromised, and there are multiple comorbidities in this given patient. So the problem is, what may be the cause of fever in this given patient? Is it UTA because there are some pus cells in the urine, or is already known case of COPD and haziness in the X-ray? Is it acute exacerbation of COPD due to lower respiratory tract infection, a new infection, or because of IC bleed also can cause some amount of fever? Is the CVA is the cause of fever? In the acute coronary syndrome, maybe sometimes Dressler syndrome, all these things can have fever. Pericarditis can have fever. Or he is on multiple inotropes and drugs. Some of the drugs also can cause fever. Or is there anything else which is causing fever? So when we encounter a patient like this with multiple comorbidities coming with a fever and having a lot of possibilities, the investigations are sometimes coming to a conclusion is sometimes difficult.
Excuse me, sir.
Yeah.
So sorry to interrupt, but your slides are not going on with your presentation, sir. Can you please put it to slideshow mode?
Slideshow mode. Yeah. 1 minute.
So on the bottom.
At the bottom, sir.
Slideshow mode.
Sir, on the bottom, you see that 86%. There is an icon, sir, that you have to click. Bottom right side on your screen.
Yeah, please click F5 in your keyboard, sir. Press F5.
Okay. No, exit in screen is exit out there.
You can stop the screen share and reshare, sir, if needed.
Yeah, 1 minute.
Yeah.
Show. Oh, share. Reshare. Slide show. ఇప్పుడు మోతుందండి అదే మూవీ ఏంటి Sir, is it moving, sir, now? Hello?
No, sir. It's
Yes,
still.
sir.
Yes, sir. It's visible now.
No, movement, sir. Slide movement.
No slide movement, sir.
Stop sharing in money.
Last.
కనపడలేదు కదా they are moving, sir, now?
లేదు సార్ మీ స్క్రీన్ షేర్ వెళ్ళిపోయింది మళ్ళీ సార్ షేర్ చేయండి సార్ స్క్రీన్ షేర్ ఇప్పుడు వస్తుంది సార్ ఇప్పుడు ఆ బాటమ్ F5 అవుతుంది సార్ మీ సిస్టమ్ లో F5
ఓకే
కీబోర్డ్ F5 నొక్కండి సార్
F5 నొక్కండి
ఓకే సార్ ఈ బాటమ్ రైట్ సైడ్ లో 86% పక్కకి లెఫ్ట్ లా క్లిక్ చేయండి
Yeah, okay. Is it moving, sir?
No.
It's moving from my side.
Fine, sir. You can use up arrow and down arrow to change the slides and continue, sir. Continue the session. Yeah.
No, you can see the slide now?
Yes, sir. We can see the slide. You can continue, sir. Yeah, okay. Use arrows to change the slides
Okay,
as
fine. Fine.
Yeah, it's changing. Yeah.
Yeah. So basically, before going to this topic, I just want to present a case, what we see regularly in the ICUs. 70-year male, known diabetic, known COPD, known hypertension, known atrial fibrillation, admitted with CVA at present admission, also had hypotension, he is in shock. There is a past history of lymphoma, he is also on chemotherapy. So because of the sepsis and shock, he was put on a ventilator, inotropes, and started some antibiotics. So this patient developed fever after third day in the hospital, 100 degrees Fahrenheit, is referred for fever evaluation in this patient. So the slide is moving now, sir. The total count is 16,000 in this patient. The urine, there is 8 to 10 pustules. Chest X-ray, there is a bilateral basal haziness. CPK is raised, CRP raised. CT scan, there is IC bleed. ET culture, there is a endotracheal tube culture. There is a Acinetobacter grown. So basically, patient is immunocompromised because he is also having chemotherapy and lymphoma, and also a diabetic. So multiple comorbidities are there in this patient. So here, what is the cause of fever? So we can think of a lot of possibilities. Because of the pustules, it can be urinary tract infection. Because it's a known case of COPD, and there is a basal haziness in the X-ray. You can think of LRTA with acute exacerbation of COPD. There is a CVA, IC bleed is there. This can also cause fever. And the patient is having coronary artery syndrome. So TRAPT is raised, your CPK is raised. So there may be some amount of ischemia undergoing, which can cause fever, or some of the multiple drugs. He is on inotropes, he is on antibiotics. These also can cause fever. Or is there anything else? So in a given setup, in a ICU evaluation of fever, you have to think of a lot of possibilities and come to a conclusion which is causing fever. Unless otherwise we deal, the fever will not come down. So in this problem, the first and foremost question is it an infection? Is it a non-infection? If it is an infection, where is the infection? Is in the urinary tract infection, or it is a respiratory tract infection, or it is a lung infection? So already patient had Acinetobacter grown in the ET culture. So most of the time, the respiratory tract Acinetobacter is a common cell. So is it a colonizer or an infection which is causing this fever? And he is already using some drugs. Whether these drugs are really acting or there is some resistance. And what antibiotics we should use in this given situation? Is there any role of antifungals in this situation? What is the cost of management of this patient? Ultimately, what may be the outcome because the patient is having diabetes, hypertension, COPD, atrial fibrillation, acute coronary syndrome, CVA. So after all these things, the outcome may be poor sometimes. So coming to fever in ICU, whatever we see a fever in OPD is different. The definition of fever in ICU is different because according to American Critical Care Medicine, more than 101 degree or 38.3 Fahrenheit is called a fever, single temperature spike, more than 101 degree. So then only we should 9900. Sometimes we may be worried, but there are a lot of problems for the rising temperature. So some of the studies, they showed the incidence of fever in ICU varies anything between 26% to 88%, depending on the what ICU, it is a respiratory ICU, cardiac ICU, or a surgical ICU, or what patients you are taking, and what definition of fever you are taking. So they differ. In a large study by Lapland et al. Showed that incidence of fever, especially high fever, in medical ICU is 44%, in surgical it is 8% respectively. So whenever a patient is having fever, why we are worried about a fever in ICU? Because when a patient get a fever in ICU, his cardiac output increases, his O2 consumption increases, his carbon dioxide production increases, he may have febrile seizures, he may have rhabdolysis, and because for example, malignant hypothermia can have rhabdomyolysis, which may cause acute kidney injury. There may be reduced Glasgow Coma scale with a new fever spike, or worsening of neuro outcomes in traumatic brain injury or CVA. So these are the side effects or what are the problems we have a patient of fever in a ICU. So not only the problems, we can also have some benefits. So whenever a patient is having a fever, there is a reduced bacterial growth in the patient, and there is a promotion and synthesis of cytokines and antibodies in the body. There are also activation of neutrophils, macrophages, and T cells, which aid in the inflammatory reaction and the quick healing of the patient. So we have both problems as well as benefits in fever. So we should know when to treat, when not to treat a fever in a ICU patient. So three types of patients mainly we see. First and foremost is in ICU admitted for fever. He came with fever and admitted. So this fever can be any infection or it can be a non-infection. Our patient had some problem over that. For example, our patient, he admitted with CVA and hypotension and shock. And the third day he developed fever. So superimposed on underlying medical disorder. The second way of presentation. Or developed of hospital admission after a week or so, which is maybe nosocomial or hydrogenic. There are certain hospitals, like especially ventilator associated pneumonia. All these things can occur late in the fever. So especially surgical fevers, basically we see as pre-operative surgical fever and post-operative. Pre-operative is patient admitted for ward and suddenly he get a fever and he is posted for the surgery, and we get a referral whether this can be taken for a surgery or not. Our patient already underwent some fever surgery, then developed a post-operative fever. So these are the ways a ICU patient with a fever present to us. So sometimes some patients spontaneous rigors or rigors are shaking chills. They are nothing but chills is like a more severe intensity is a rigor. So this rigor is basically because of the hypothalamic aggressive attempt to increase the body temperature, and this may or may not follow fever. See, sometimes if a patient is elderly patient, especially uncontrolled diabetes, or sometimes a patient is immunocompromised, or we have started some steroid, all these patients may not have fever in this case. They have only chills. So sometimes we see patient complains only chills and rigors, and whenever we see there will not be fever in the patient. So all these patients also to be investigated as a part of fever. This is basically because linked most of the time with the bacteremia. So new onset of rigor, any patient just suddenly have a chills and rigor in a ICU, we also think it as a fever and treat as a fever only. So there is one rule called 102 rule. According to 102 rule, any fever less than 102 is most of the time non-infectious causes. Any fever more than 102 is most of the time infectious causes in a ICU. But every rule have an exception. So in this exception for this rule, in a non-infectious cause, see, non-infectious fever is less than 102. There are some situations where fever will be more than 102. It is like malignant hyperthermia, where it will go into 105, 106, adrenal insufficiency, drug fevers, central fevers like your CVA and IC bleed, heat stroke. All these are non-infectious causes, but still fever is high. So like that, in some infections, most of the infections fever is more than 102, but some infections fever is less than 102. This is basically cellulitis, the bed sores, or sometimes patient may have osteomyelitis, or patient is having underlying tuberculosis. All these patients, fever will not cross more than 100 in these patients. So all the infectious and non-infectious cases roughly according to the system, we can see like this. For example, in CNS, if it is a meningitis, it is an infectious cause. If it is a tumor, it is a non-infectious cause. In CVS, endocarditis is infectious cause, Dressler syndrome is a non-infectious. In respiratory system, pneumonia is an infection cause, and our atelectasis is a non-infectious. In renal, pyelonephritis is a infectious cause, and renal infarct is a non-infectious cause. Soft tissue cellulitis, soft tissue hematoma, infectious, non-infectious. Sepsis and drug fever. All these causes, everything causes fever. But most of the time, both are different, infectious and non-infectious. We should know what is exactly causing infection or non-infection, because only in infection we try to use our antibiotics or other things. So sometimes we have to decide whether we have to step up the antibiotic or all these decisions depending on the cause of the fever. So most of the time history and examination is not quite possible, because patient may not give all the history if he is drowsy or coma. For the first thing, our patient is on ventilator with multiple inotropes and lot of tubes and lines going on. it is quite difficult to even examine the patient properly. In the post-COVID cases, sometimes history may not correlate with whatever patient may be looking like sick, but his reports are quite normal. See, these situations we see in post-COVID sepsis. So we have to sometimes only depend on whatever available investigations. We may not get all the history properly, we not get all the clinical findings, but only investigations we may have to see the patient and try to take a decision sometimes. So sometimes not only the way of presenting a fever, sometimes we may have a referral even for fever not coming down. So patient is admitted for fever or patient admitted for some other situation where there is a infection is found and they are started antibiotic and fever is not coming down. So they put a referral, this patient is not improving with the fever, please kindly see. So these are all called delayed resolution of fevers or persistent fevers, or a patient may have at the time of discharge suddenly new spike of fever coming down. Fever subsided and about to discharge, and that night again you have a spike of fever. So most of the time when we see like this, we think either there is some resistance to whatever antibiotic we are using, or the bacteria is resistant, something like that we think. But most of the time recrudescence fever is less likely due to resistant organism. If there is a recrudescence, we have to think of most of the time we try to step up the antibiotic or change the antibiotic. So these are what we will be doing routinely. But these fevers which are coming late or not responding, or a new spike again coming, may not be because of resistant organism. This is very important. So what cause this type of presentation, like not responding or responded but again coming back, or totally came down again restarted? So here most important is secondary, some other infections. It's a viral fever, you have a secondary bacterial or bacterial with a lot of antibiotics, you developed a candidemia and candidal sepsis. So fungal infection super adding is one of the cause. Our patient is put on some drugs because of hypersensitive reaction, allergic reaction, he developed a fever. Our patient, there is some underlying undrained abscess which is causing the fever. Our patient underwent some TK or some sort of surgery where the implant is infected. So these people also can have fever again. So patient can have organ hypoperfusion, sometimes can cause fever, and sometimes I told you this patient have a Acinetobacter. Acinetobacter may be a colonizer there, it's not causing infection. So we are trying to treat that bacteria which is a colonizer. So you should know whether it is a colonizer or the offending agent. See, if you go on putting antibiotics to colonizer, because it is a colonizer, it is not causing fever, the offending agent is causing fever, then we should know whether it is really which is causing the fever in this patient. So in coming to antibiotics, whatever we are using, if a patient fever is not coming down, there are three things. One, you are not covering adequately. For example, patient is having gram positive streptococcus, you are giving some meropenem or some other antibiotic which is gram negative coverage is more. So you should know what is the adequate coverage of the organism, gram positive, gram negative, which antibiotic is better, what spectrum of organisms that antibiotic is covering is very important. And sometimes we try to put 3 or more antibiotics where they have opposing actions. This is called antibiotic antagonism. You can't mix some of the antibiotics which decrease their efficacy. So this is called antibiotic antagonism. In these situations, you don't get the adequate response what we expect. So sometimes inadequate blood and tissue levels. So certain antibiotics work well in lungs, certain antibiotics work well in urine, certain antibiotics will cross the blood-brain barrier, certain won't cross. So all these things we should know before using the antibiotic. Otherwise, you think you are giving adequate antibiotics, you are stepping up, and that is not, there is a CNS infection and it is not crossing your blood-brain barrier. There is no point in giving these antibiotics. So other thing is difference in vivo in vitro susceptibility. See, in your culture report, it is showing susceptible, but the same thing does not be done in your body. That is called in vivo in vitro susceptibility difference. So not that your antibiotic may be acting outside does not mean it also act in body. So sometimes antibiotic unresponsive infection means it is not a bacterial infection. It is some viral or fungal, something is going on. Unnecessarily, we are pushing more and more antibiotics. This here also, your patient will not be responsive to the fever because it is a viral infection and we are giving antibiotics, or it is a fungal infection, we are giving antibiotics. So here we should all think of all these situations before we think why the fever is not coming down in a given patient. So,
sorry for interrupting, Dr. Manoj. We were time is exceeded. Just last 5 minutes, take it as a great time. Thank you.
Sir. So in the drug fevers, basically, whenever we are using multiple drugs, we should always think of the possibility of drug fever. The most important thing is in the drug fever will be 102, 104. There can be some bradycardia or there can be rash. So this is inappropriately a patient looking very well. The patient may be 104, 104, but still patient look well. In this situation, we should think of drug fever. Patient can have eosinophilia in the blood. This is one of the markers for drug fever. And sometimes we can always think of drug reactions, drug fever, seroma, pleural effusion, atelectasis, if the non-infection mimics of the fever. So ICU environment, not only these drugs and whatever patient condition, some of the air conditioning problems, the patient is already on bypass or IV catheters or dialysis, or patient is having special matrix or heart lights, all this can also influences body temperature. And especially if you have a post-operative fever, we have to divide it early post-op, late post-op, or delayed post-op, depending on the duration, 0 to 3, 4 to 30, and more than 30 days duration. And 50% of patient in post-operative period, definitely post-operatively, we may have 1 or 2 spikes of fever. We should know how to evaluate this patient and what are the conditions we see, especially in the immediate post-op case. Especially immediate post-op, most important is transfusion reaction, because they may have given one blood in theater and immediately after coming out he developed a fever. Our patient have developed a malignant hyperthermia because of anesthetic drugs. And in early post-op especially, there is a early surgical site infection or aspiration pneumonia are important in early post-operative fever. The late post-operative fever, the patient is already having a catheter or a central line, which may be causing catheter-associated urinary tract infection, catheter-related breast infection, or patient developed 1 or 2 motions. We should think of C. diff colitis. These are also causes of patient surgery is fine, but there are the secondary causes which are causing the fever. So delayed is after 1 month. Most of the time it is not related to surgery. Always you have to look up other causes, so you don't go to surgeon again. These are the investigations what we do in a given fever patient, and cultures we will do all the cultures whatever available. Best thing is biomarkers are very important, especially procalcitonin. Don't use procalcitonin to start antibiotic, only to de-escalate procalcitonin is very important. These are the newer biomarkers which are available. And fungal things we can write galactomannan and beta-D-galan or galactomannan antibodies. These are all show us fungal cultures, because fungal culture take more time. So these are markers we can use to find out fungal infections. So basically in CBC, count is not important. If you have a left shift or a band forms are more important than the original count. So serum ferritin is one of the inflammatory marker. Procalcitonin also important to de-escalate. And IL-6 is not much important, because we did IL-6 in very well in COVID, but this is not much useful in routine sepsis and ICU patients. So nowadays we are using PCRs, biofire film array systems. This will give the sensitivity, the result within 6 hours of your culture, what organisms, especially you can detect especially 43 organisms in BCID2, and antibiotic resistant genes also can be detected, so that if you know what is the resistant genes, you can stop that antibiotic. So this is the use, but only thing is the cost is the problem here, but cost is somewhere 10 to 12,000 rupees. But in a given ICU setup, if you spend 10 to 12,000 rupees, if you are saving 1 day cost of ICU, if he is coming out of the ICU, you can save 1 lakh to him. So antibiotic usage, we should be always treat the bacterial infection only. We should optimize by diagnosing, assessing the severity, maximize the eradication of bacterial pathogen, recognize the resistant prevalence, utilize pharmacodynamics, choose the most effective agent, integrate local resistance and cost effectiveness, prescribe empirically, encourage patient compliance. These are important. And 3 things, antibiotic stewardship is very important. Right drug, right dose, right duration, right to de-escalate. If not followed, you have 5D, that is death. So This is one of the trials showed decreasing fever may not help all the patients. It is not the decreasing fever, it is the cause of the fever which is more important. So antipyretics, we use paracetamol, NSAIDs, physical cooling, and in this trial they had showed not much benefit by using just antipyretic. So in a given cause of the in a fever with ICU, you can have a lot of causes. You have to find out what is exactly causing this fever. Unless you pinpoint the cause, the fever will not subside. Just by treating all the things, we may not get this thing. It is like how you go on dig and find out what is the cause of exact fever, because there may be multiple factors operating, sometimes 2 or 3 factors operating. So just by escalating the antibiotics or changing the antibiotics is not the answer for dealing the fevers in ICU. Always we should think of non-infectious causes also simultaneously, and adequate cultures, and if possible the latest technologies like PCR are more important in coming and giving a much idea for getting this early report, so that early antibiotics or early antifungals can be started. So thank you very much for this opportunity. Thank you.
Well, thank you, Dr. Manoj sir. You have given extensive coverage of a very interesting topic. In fact, it's a very wide topic. Even then, you've given a very good insight into the topic. Thank you very much. Next session, we move on to the next topic. I request Dr. Sushmita to take over as the moderator of the session.
So meanwhile, before starting the next topic, National President is joining the program. Dr. Shyam, technology team,
Yes,
please
sir.
allow Dr. D. Srihari Rao, Vice President, IMA National, panelist list. Dr. D. Srihari Rao, IMA National Vice President, to make him as panelist. He has to address the.
I have added him, sir. He has to click on that panelist thing. Yeah.
Okay.
Yes.
Dr. Srihari, National Vice President. శ్యామ్ డాక్టర్ శ్రీహరికి వీడియో రాలేదు చూడండి.
లేదు సార్ అన్న సార్ అలౌ చేయాలి సార్, నేను ఆల్రెడీ ప్రమోట్ చేశాను ప్యానలిస్ట్ కి, హీ హాస్ టు క్లిక్ ఆన్ దట్.
మళ్ళీ ఒకసారి అలౌ చేయండి, మళ్ళీ
చేస్తున్నాం సార్, మళ్ళీ చేశాను సార్,
మళ్ళీ చేశారు చూడండి శ్రీహరి మీరు.
సార్ అన్మ్యూట్ చేసి కూడా మాట్లాడొచ్చు సార్ డైరెక్ట్.
జాయిన్ అయ్యారు.
I request Dr. Srihari, National Vice President, to address the delegates briefly on this occasion. Please unmute and speak, Dr. Srihari.
Dr. Srihari sir, sir, we have given you the access to speak. If you are unable to, yes sir, you can unmute and speak, sir.
Hello. ఫోన్ లో ఉన్నారా? ఆప్షన్ కనిపించడం లేదంట శ్యామ్ సార్కి. మ్యూట్ ఆర్ అన్మ్యూట్ వీడియో ఏం కనిపించడం లేదు.
మీరే అన్మ్యూట్ చేయొచ్చు చూడండి.
చేశాను సార్, అదే చేశాను సార్, మాట్లాడాలి క్లిక్ చేశాను.
అంటే సార్కి అన్మ్యూట్ ఆర్ మ్యూట్ చేయడానికి ఆప్షన్ కనిపించడం లేదంట కింద, వీడియో కానీ ఆడియో కానీ.
ప్యానలిస్ట్ లో జాయిన్ అయ్యకపోతే కనపడదేమో. జాయిన్ అయ్యారు అంటున్నారు, జాయిన్ అయ్యాడు, ఇక్కడ కనపడుతున్నారుగా.
శ్రీహరి అని మీరు జాయిన్ అయ్యారు.
అవును సార్. సార్ అదే అన్మ్యూట్ చేసి మాట్లాడాలి అంతే.
అన్మ్యూట్ మైక్రో మైక్ సింబల్
కనిపించడం లేదంట.
మైక్ సింబల్ కనపడలేదు.
మీ దాంట్లో కనిపించడం లేదా? హలో.
రవి సార్, మీరు సార్ నంబర్ మాకు పంపించండి సార్. ఐ విల్ స్పీక్ టు హిమ్ పర్సనలీ. లెట్స్ కంటిన్యూ దిస్ సార్. యా, ఐ విల్ స్పీక్ అండ్ సార్ట్ ఇట్ అవుట్ డైరెక్ట్లీ.
So then we move on to the next topic. Dr. Sushmita, please take over.
Sharad Agarwal, Dr. Sharad Agarwal, National President, line busy ostundi. Once he joins,
So continuing with the presentation, now we have our next speaker who will be talking on the role of interventions in chronic pain management. Dr. Sampath, over
please,
here.
no. Please kindly give a brief gap for the message of the National President. He has to attend some other meeting. Dr. Sampath Kumar, you can start after the message of the National President. Screen share thesis. Sir, please join, sir. We are waiting for your message, sir. Link, yes, again, sir. I have sent, sir. Okay. Sir is joining. National President Dr. Sharad Agarwal, sir, is joining. He tried to join at 10:15, but he could not able to join because it is asking for registration. So he has another meeting and he has attended that meeting. He is now ready to join and he will join. Once he joins, he will address the delegates. Then we can proceed with the academic session.
The next topic will start after the brief message by our National Vice President of Srihari Garu.
He joined. Srihari. Inform me once he joins. Dr. Sharad Agarwal.
Yes, sir. I'm waiting, sir. He hasn't joined.
Srihari join ayyara malli.
Sir, koncham sir number పంపియండి sir. I'll talk to him directly, sir. What is the issue?
మీకు WhatsApp లో నెంబర్ పెట్టాను శ్రీహరి. Yes,
President has joined.
Yes, President sir join అయ్యాడు. Name Shyam. Shyam.
అయిపోయింది సార్, అయిపోయింది సార్.
Sir, welcome sir. Dr. Sharad Kumar sir, National President. Sir, we are very happy to receive you on this occasion. We are organizing this 2 days CME program on behalf of the IMA AP State Academy of Medical Specialties with very eminent speakers on varied subjects with 6 CME credit hours. And APMC has allotted 6 CME credit hours. Already 650 members are on the board. We have started the academic program in the morning itself. Sir, IMA AP State activated Academy of Medical Specialties with the full team and also the College of General Practitioners. And this is the 6th IMA AP State online program, sir. And we have completed 3 regional academic conferences also in 3 zones, one at Kakinada, one at Machilipatnam, and one at Anantapuram. And we are organizing CGP monthly online programs also. Next month, we are planning for a IMA AP State AMS physical state conference at Kurnool. Both and both. I am talking both. IMA AMS state conference we are going to organize in Kurnool, sir, a physical meeting. And we are concentrating on all the branches in the state are organizing continued medical programs every month, and academic activity is in full bloom in the Andhra Pradesh state. And so we are very happy to receive you, sir, and we have good number of members in the Academy of Medical Specialties. In IMA Nanjal, we have a special IMA AMS wing also, and we are trying to increase the membership also. On the board, we have our Dr. P. Panidhar sir, General Secretary, IMA AP State on the board, and also Dr. P.A. Ramani, IMA AP State AMS Chairperson, and Dr. GTV Ramesh, Secretary IMA AP State AMS Wing also on the line, sir. And Dr. Ravindranath, IMA AP State Finance Secretary, is also on the platform. And now I request Dr. Sharad Kumar Agarwal sir to address the delegates and give his message on this occasion.
Thank you, Dr. Ravi Kumar. Dear Dr. Anil Nayak, HSG, Dr. Pankaj Mutneja, Chairman IMA AMS Headquarter, Dr. Srirangam Kari, Secretary IMA AMS Headquarters, Dr. Ravi Krishnaji, State President AP, Dr. Fanidhar, State Secretary Andhra Pradesh, respected all the past presidents joined this wonderful meeting. I congratulate Dr. Ravi Krishna and his team for organizing such a wonderful hybrid meeting of under the edges of IMA AMS State. And I can see that more than 700 participants are joining. It is a huge number. It is a huge number, and lot of offline candidates are there. So it shows that your organizing skill and your potential. And I am very happy. These kind of conferences are very important because as an aim and objective for Indian Medical Association, and that is why this Academic of Medical Specialty Wing was constituted to upgrade our knowledge amongst the specialists. But definitely we are also utilizing our all platform for upgrading the knowledge of our general practitioner friends also. So I am very happy. My all best wishes to Dr. Ravi and Dr. Fanidhar and his entire team. They are AMS Chairman and AMS Secretary of Andhra Pradesh State. And I formally inaugurate this session and wish for all the success of this session, and expect many more continuous meetings for the benefit of the fraternity on the very good topics. With these words, because you please pardon me, you can see that I am on the way reaching the headquarters. We have to attend a PACE conference because we are celebrating the organ donation month, awareness month, and on 6th, that is tomorrow morning, we are organizing a walkathon at headquarters, and we have requested all the state and the branches also for the awareness of the organ donation. They should organize a walkathon and fix the artwork and the poster. The artwork already has been shared with the branches and the state. And you should ensure that every clinic and hospital should fix that poster of Indian Medical Association towards the awareness of the organ donation. So I take this opportunity to this August gathering. Then please take place with me tomorrow for organ donation. With these words, I am again thankful to IMA Andhra Pradesh State Branch and my best wishes. Long live IMA, Jai Hind, Jai Bharat.
Thank you, sir, for
Very
coming
much,
and participating in the inauguration program and kindly inaugurated the program. And definitely we are going to organize organ donation programs throughout the state. This week we are organizing throughout the state breastfeeding week. Also we are celebrating on a big way. All the doctors in the state, all branches are organizing these programs for the last 1 week also. And certainly we are going to organize organ donation program also effectively in our state. And truly, you said that these programs will enhance and upgrade the knowledge of the doctors who are participating in the conferences. And finally, this upgradation of our knowledge is going to benefit the patients. So it is the interest of the patients. We are organizing these programs not only for the interest of the doctors for their academic enhancement of their knowledge. Indirectly, it will help the people because of their upgraded knowledge. They can give better care and better management to the public. And once again, we express our sincere thanks for coming and participating in the inauguration program in spite of your busy schedule. And soon we are also interested in organizing the sports IMA Olympics. You have allotted to IMA AP State in a big way with the cooperation of IMA headquarters, and it will be a big event in the IMA history, sir. And we request your kind cooperation in all these activities. We thank once again for your kind participation. Thank you, sir. Thank you very much.
Thank you, sir. Srihari is also on the board, sir.
So Dr. Srihari joined the program. I request Vice President IMA National Headquarters, Dr. Srihari, to address briefly on this occasion.
Dr. Srihari Garuku is facing some technical challenge with his system.
Okay, sir.
Yeah,
I request,
our team is in constant call with him. They're trying to figure that out. We can continue, sir. Yeah.
Okay.
Yeah.
Sir, unnara line lo sir, President sir, National President sir.
Exit అయినట్టు.
Exit.
Exit sir, we can go with the academic session కి వెళ్ళిపోవచ్చు మరి.
Sir, Panidhar sir, మీరు మాట్లాడతారా లేదంటే ఎకనామిక్ సెషన్ లో?
Continue with the academic session.
I request the IMA AP State Chairperson Dr. Ramani Madam to continue with the academic program.
Thank you so much,
And
sir.
those who are left for the inauguration session, the VIP guests, we will ask them to attend the valedictory function tomorrow.
Yes. Thank you so much, sir,
Thank
for getting a national president as our chief guest here. Thank you so much, sir. We'll continue with the sessions.
Yes,
Thank you.
and for all the delegates, sorry for the interruption because he is the national president and this is IMA program. It is an honor for us to listen to your message. Thank you.
Thank you, sir.
Thank you, sir. So we'll be continuing with the next topic, regenerative procedures in chronic pain management by Dr. Sampath Garu, Anesthetist, Pain Clinic, Nanjala. Sir, please, you can start your topic, role of interventions in chronic pain management.
Yeah. Thank you for giving me the opportunity to speak on role of interventions in chronic pain management. So, pain is a fifth vital sign which the body tells to a person that your body is aching, your body is troubling something. So pain is more important. Coming to definition of pain, it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And recently they have added 6 keynotes as the pain is a personal experience and pain and nociception are different phenomena. Throughout the life experience, individuals learn the concept of pain, and a person's report of an experience as pain should be respected. And there are it may have some adverse effects on the function and the well-being, everything. And verbal description is only one of the several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences pain. Coming to low back pain, as you can see, most of the patients who complain of back pain, they name it as a sciatica. Actually, 2 to 5% of the patients who are suffering from back pain are suffering really from sciatica. The rest everything, there are multiple causes in low back pain, where the fascial joint arthropathy contributes about 15 to 45%. So mostly the disc pathology and the nerve root which affect due to disc, its effect will be mostly in the anterior epidural space, where you can see in the image there is this is the disc area, this is annulus fibrosus and the nucleus pulposus. The nuclear disc bulge comes and affects the nerve root, where there is an inflammation, and the sciatica or radiculopathy comes into this. The affected area is ventral epidural space, where as an anesthesiologist, we regularly do internal epidural steroid injections blindly, and some do guided, and but the drug that doesn't seep into ventral epidural space where the etiology is more. So as a pain physician, we developed a technique as a transferable epidural steroid injections, where we directly place the medication near the etiology site where the disc bulge comes and affects the nerve root and the nerve irritation, where the nerve inflammation will be there. So the exact place where the nerve is affected, it will be treated as such. There are two types of nerve roots where there is effect. That one is traversing nerve root and the exiting nerve root. Suppose if there is an L4, L5 disc, the nerve root which affected is the L5 nerve root, not L4. So we need to know which disc is suffocating which nerve, and obviously the nerve distribution, now pain will be like dermatomal distribution. So we can classically diagnose the patient which dermatome is affected, which nerve is affected. I'll be discussing on case basis. This particular patient is a young male. He's suffering from L4, L5 disc, and his classically symptoms are radiculopathy symptoms, where the pain is radiating from back to up to tips. Mild paresthesias are present, and we take an MRI, and there is an L4, L5 disc which is abutting the both exiting nerve roots. So we plan with initially with the antineuropathic medications, but he is suffering since many months. He is not get relieved with increased dose of antineuropathics also. So we advised him in a transforaminal epidural steroid injection, where we usually do any procedure in fluoroscopy machine. As you can see, we placed the fluoroscopy machine in such a way that we are seeing the foramina, and we took a needle, actually is a spinal needle, where you can see the end-on appearance, and this is the dye spread of the L5 nerve root, which is getting affected with L4, L5 disc. Patient has obviously very good pain relief, and we reduce the dose of antineuropathics and is into regular activities so far. Coming to case 2, as you can see, this patient is a young male who is occupation as a mechanic. He had developed a back pain and with a severe bilateral radiculopathy, where both lower limbs have been affected with the pain. So we took an MRI, and as you can see, there is a big disc bulge, this L4, L5, S1 disc bulge, where it is coming and pressing on the thecal sac. As you can see, but the patient symptoms are only pain. There are no deficits, and there is no paresthesias, and bowel and bladder were also normal. So this patient, some surgeons advised him a surgery, but as there are no red flag signs and no deficits, we advised him a trial procedure. As you can see, we placed epidural needle in the caudal epidural space and threaded a catheter up to L5S1, as this patient has a big disc bulge which is coming and obstructing the thecal sac. We cannot do transforaminal as S1 ventral and dorsal, and we cannot get adequate dye spread. So what we planned is, we placed an epidural needle through in caudal epidural space. We threaded a catheter up to L5S1 where the exact disc is there, and then we deposited some drug there. The patient has very good pain relief. Even though he has a severe disc, the pain relief was very good, and he is returned to his activities very well. Coming to next, the most common cause of low back pain is facet arthropathy syndrome, where the patient complains of low back pain, and there is no spinal tenderness, and the paraspinal tenderness will be affected. And most of the patients are like farmers and occupationally. So the pain is mostly in the paraspinal area. It's not radiating. Even though if radiate, it radiates up to thigh only. So on examination, you can see there will be severe paraspinal tenderness in the patient. So we diagnose with an X-rays and MRIs, where you can see facet joint effusions in MRI, and then we can try some analysis. If there is no relief, then we'll plan radiofrequency ablation of the medial branch. Radiofrequency ablation is a technique where we ablate the nerve. So the ablation is nothing but like a cautery, but the mechanism is the needle tip will be heated up to 60, 70, 80, 90, depend on the cause of the patient, cause of the pain. And then we ablate the nerve. So if it is a sensory nerve, like this, in this case, this middle branch is a purely sensory nerve. It supplies the facet joint, and it don't have any motor effect. So we ablate the nerve at 90 degrees Celsius. So the pain relief will be there, which is the pain generator. If there is a motor component to the nerve, so we do for a resistant radiculopathy patients, neuropathic patients. If there is a motor component, we do pulsed RF, where the needle tip will be heated up to 42 degrees Celsius. The neuromodulation will be happening, and the nerve cycle, the pain cycle will be disrupted so far. So coming to next case, another cause of low back pain. This common term is sacroiliitis. So this 32-year female is 120 kgs. She has a weight of 120 kgs. So she complained with an low back pain, and multiple consultations on MRI. Basically, MRI, we diagnosed an sacroiliitis, and we advised her with a SI joint injection and caudal epidural injection in order to cover the sacral nerve roots. So the main etiology is in SI joint. Even though this is a low back pain, one of the cause of the low back pain, there will be pain in posterior suprailiac spine tenderness, and radiation up to thigh will be there. It's not completely radiculopathy, it's a referred pain. If the SI joint inflammation is present, then we advised her with sacroiliac joint, which is very tough. Actually, the SI joint has two joints where we can see on the dorsal surface and one in the ventral surface. We place the fluoro machine in such a way that we see a single line, and we advance one needle actually, but in order to get a good dye spread, we place another needle. I placed another needle in this patient because of her obesity, and we put some dye. As you can see, there is a good dye spread of the SI joint, and I placed the drug. And the next thing is I supported by doing a caudal epidural. I covered the L5, S1, S2 and nerve roots, which will supply the sacroiliac joint, which will have an additional benefit apart from sacroiliac joint inflammation. So most of the patients who have undergone cesarean section, they after some few days or next follow-ups, they'll be complaining of a back pain. So most of the times they say, sir, there is an anesthesia to my back and I'm getting that pain. Actually, if you clearly examine the patient, you can see most of the times you can see there is a PSIS tenderness, that is a posterior suprailiac spine tenderness, which is mostly correlating to sacroiliitis. It's not actually spinal anesthesia pain. It is mostly sacroiliitis. If you clearly examine the patient, there will be low back pain. Sometimes spinal tenderness may be there, but classically PSIS tenderness will be there. Apart from it, Fabus test will be positive. Coming to next case, this particular patient is a female. She had a fall on her buttocks. So she had a coccyx dislocation, as you can see in this machine. She was advised with adequate rest and analgesics, which there is no pain relief. So we advised her sacrococcygeal joint injection and ganglion impar, which is ideally indicated in coccygodynia. So we place the needle through and through sacrococcygeal junction in order to approach the ganglion impar, which is a sympathetic nervous system. We do for cancerous surgeries also. So this patient has a very good pain relief, and she has in rehab phase. We advise her a coccyx pillow and make sure that this coccyx bone doesn't touch the hard surface, and she has very good pain relief so far. Coming to another thing, there's neck pain, which is radiating cervical radiculopathy, what we call. So most of the patients who are suffering with neck pain and radiation pain, we tried with antineuropathic analgesics. If there is no much result, then this cervical epidural is a very good option. It will have very good results compared to lumbar area. A epidural injection in neck for cervical region, the results are very good, because actually there is a small neck and there is a small spine. So if you put a 5 ml of drug, it will cover entire C2, C3, C4 nerve roots, and there is no thing like you need to target a single nerve. If you just place a interlaminar epidural and put some 5 ml drug, any disc from C2, C3, C4, C5, if there is a multiple disc also, the result will be very good. If there is no red flag signs and there is no indication for surgery, this intervention is the best. So we do in prone position, and we make sure that the vertebrae are squared, because the dura and the subarachnoid space where there is a CSF, it will be very thin. So you need to have real expertise in order to a cervical epidural, that too guided. You need to see the exact needle. Epidural will be very lengthy and thick. So you need to give adequate local, and you need to place the needle in exact location. As you can see, this is my cervical epidural. This is C7 vertebrae. I targeted at C6, C7. Basically, we do every cervical epidural at C6, C7 level. And we don't go up actually, but if there is a heavy patient where the shoulders come in obstruction, we cannot see the needle in lateral region, we go up to C5, C6 level. But most of the times we do at C6, C7 level, we place the needle, and you need to see a tunnel shaped view of the entire epidural needle. And in lateral view, we need to see the depth. This is a contralateral oblique view where we need to see the tip of the needle, make sure that you do not pierce the root or spinal cord. So after placing the needle at the exact spinolaminar line, we put some dye and we confirm that is a cervical epidural. As you can see, the dye spread. After giving the drug has seeped up to almost C2, C3, C3, C4, C5, C6 levels, and the patients will get very good relief with cervical epidural for cervical disc bulge with radiculopathy. Those who are not willing for surgery, or there are no red flag signs, and patient want to try any conservative, this is a very good procedure for cervical radiculopathy. And coming to shoulders, most of the times the cause of the shoulder will be any tendon tears, or nowadays we are seeing much number of frozen shoulders. Previously, during my postgraduate days, we used to give scoline, and we just the orthopedicians will just shear the joint, and so that the adhesions will be released. The exact cause of the frozen shoulder or adhesive capsulitis is coracohumeral ligament will be thickened, and the rotator cuff interval will be thickened, so the external rotation and the overhead movements of the shoulder will be affected. Now we are doing for every frozen shoulder, they'll be trying multiple physio sessions, and some will get relief, some will don't get any relief, and the joint will be progressively getting into stiffness phase, and there is a severe pain. They cannot even sleep, they cannot even move with the shoulder. So we do with a nerve block and a glenohumeral joint dilatation, where we release manually. So this is the suprascapular nerve radiofrequency ablation, that is pulsed radiofrequency ablation, where we'll see in ultrasound the suprascapular fossa, and we'll see the suprascapular. Now we place the needle here when we do radiofrequency pulsed RF. So pain relief will be there. Apart from that, we dilate the joint. So the capsule will be stretched and the adhesions will be released. There are two indications, or two advantages of doing dilatation is, we'll stretch the capsule, and the coracohumeral ligament, which is in the stiff phase, will get released with this, and the fibroglycans will be dispersed from the joint capsule. So there will be further, there won't be further adhesions, or the patient will get good relief. So we do either fluoro guided and ultrasound guided. Ultrasound guided we regularly do, because it's a real-time guidance. Okay, we'll see the needle exactly, and the joint capsule will be there. In fluoroscopy, we don't see any glenoid labrum on soft tissues. So we do regularly in ultrasound. So it's exactly posterior glenohumeral joint, where you can see the humeral head, and this is the biceps groove, and this is the glenoid labrum. We will make sure that we are just the needle tip is just here above the capsule, and we'll inject about 40 to 50 ml of normal saline mixed with local anesthetic. So we'll distend the capsule, then the adhesions will be released. Immediately, few minutes after, if you ask the patient, just lift the upper limb, you can see the result. This is a before image and the post procedure image. With apart from few minutes, the movement will be resolved, and if you do physio, the adhesive capsulitis will be resolved immediately. Coming to next thing, most common cause of knee pain. Knee pain, where we really see knee osteoarthritis. So there will be degeneration of the articular cartilage. There will be decrease of synovial fluid production. The cartilage damage will be much, and in Indian scenario, most of our patients will be squatting. So the degeneration will be progressed. So there are 4 stages of knee osteoarthritis: grade 1, grade 2, grade 3, and grade 4. We will get an X-ray, and we can assess the degeneration. And I personally do my musculoskeletal knee examination also, in order to see the synovial integrity and the medial meniscus status and the lateral meniscus, and how the joint status is there. So we address the patient with simple analytics initially, and we say not to even scat and climb stairs. If the pain is not controllable with simple analytics, then we advise them with 2 procedures, that is one regenerative procedure and one pain relieving procedure. The pain relieving procedure is basically a radiofrequency ablation of genicular nerves of the knee, and the regenerative procedure is PRP injections. And so some patients, if there is little pain, then we directly go with the regenerative procedure, that is platelet-rich plasma injections. If the patient has severe pain and the degeneration is more, then we will do radiofrequency ablation along with regenerative procedure, that is PRP injections. So there are 6 nerves basically supplying the knee. There are superior-medial genicular nerves, and the inferior-medial and superior-lateral genicular nerves, and there is which are branches from femoral, obturator, and sciatic. So we do both fluoro-guided and ultrasound-guided. These basically nerves are very small nerves, tiny nerves, where sometimes you cannot see in ultrasound. Then landmark technique is we target the area between diaphysis and metaphysis, and we place the needle end-on position. We check the depth of the needle, and we do ablation at this level. This is for superior-medial, superior-lateral, and inferior-medial. Okay. Coming to regenerative therapy, so we do 3 sittings. We follow a protocol of 3 sittings protocol, 14 days apart. So we do first sitting as platelet-rich plasma injection, and next sitting is growth factor concentrate injection, and third sitting is again PRP injection. So previously, routinely, nowadays these many kits are available. So there is a lot of complaint from some other people that if you give PRP, there is flare, there is a severe joint pain after PRP. This is basically because of the leukocyte concentration, where the centrifuge technique doesn't take away the leukocytes from the sample. If you take an economical kit like this, is initially when I started the practice, I used to do this kit where there is severe flare after putting PRP into a joint or any tendon somewhere. This is because I assessed, I took a sample, and I checked the concentration of leukocytes, which is very high. So I assessed that the reason for his flare of PRP is basically leukocytes. So now we changed completely to Dr. PRP kits, which has a very good quality of imported quality, and a single technique, single shot, and we don't manipulate again. It's a pure centrifuge method where we do a cooled centrifuge in order to harvest the platelets. So this cooled centrifuge, basically it optimizes the temperature inside the centrifuge so that the platelet damage won't be there. it will take down to around 18 degrees centigrade, even though centrifuge spins. The normal routinely centrifuges, if they spins, the temperature will be high. So what we use is cooled centrifuge. It will cool the environment where the platelets will be harvested, and there is a minimum damage to platelets. So we take 20 ml of blood along with 2 ml of ACD solution, and after taking, we do a separation method. As you can see, the RBC are settled down, and there is a plasma above. So there is a small port-like thing. We turn it on and we lock the plasma like this above. And the second centrifuge is concentration method, where the platelets will be segregated down and the platelet fluid plasma will be
Sir,
above.
can you conclude in next 2 to 3 minutes?
Yeah, I will. So, and second sitting will be growth factor concentration therapy, where there will be prefixed ACD solution in the test tube. We put 4 ml of blood. There is an activation of the sample, and we directly get the growth factors. So we take away, as you know, there are many growth factors which is present in the PRP and the growth factor. And we do ultrasound scan, and we take away any bad fluid, any effusion fluid in the joint, and we do every procedure under guidance. So we do here, you can see under the guidance, we place the needle in the suprapeteral bursa and we deposit the sample after seeing that. So there are many indications for PRP. Previously they were using much steroids, but nowadays we are doing for any tendinopathy, tendinosis, any muscle issues, any muscle fibrosis, ACL tear, LCL tear, and shoulder tendon tears, tendinitis, where there is no response to anything. We are doing PRP for that. Coming to palliative care, this particular patient is suffering from CS stomach, and she has developed a severe pain. So basically, we have done CT guided celiac plexus block for this patient. This is neurolytic block. We target the celiac plexus, which is present around the aorta at the L1 level, and through CT guided we do. And some cases we do fluoro guided. If the patient is very thin, we place the needle at L1. We place a 2-needle technique, and we, as you can see, this is the dye spread around the aorta where the celiac plexus is there. We deposit that. Nowadays, we have added this planktonic radiofrequency ablation along with the celiac plexus neurolysis, where there are many complications regarding to neurolysis, like necrosis of pancreas, something. So now we are doing planktonic radiofrequency ablation along with celiac plexus. We are having very good results with in cancer patients. Coming to headaches, we have done many cases of Botox injections for migraine headaches. Previously, if you have migraine, you need to take multiple pills throughout your life. But now we are treating with Botox injections, where we'll be doing 5 units to 10 units in temporalis muscle, frontalis, and corrugator. So we'll assess the area where it is affected, and we put some Botox toxin in the muscles. And another thing for migraine headache is sphenopalatine ganglion block. If there is no response with Botox for migraine headaches, we do this sphenopalatine ganglion block. Some patients are having very good results with sphenopalatine. We can repeat further because it's a minimally invasive procedure. We do in guidance under fluoro, where this sphenopalatine ganglion will be present here, just beneath the nasal. So we deposit the drug, and patient will be having very good relief. And next thing is the suicidal lysis, trigeminal neuralgia. So this patient, we were doing V3. She's suffering from V3, and as you can see, my needle has entered through foramen ovale, and you can see classically the V3 motor nerve stimulation. After seeing the stimulation of the mandibular nerve, then we ablate the nerve. This patient is particularly happy with pain relief, and she has very good pain relief. Okay, these interventions helps the patient in not landing into chronic pain, which is very difficult to deal the chronic pain. In acute stage, it's very easy to deal the patient, and minimal dose of medications and minimal dose of interventions are needed to deal in acute pain. Whereas in chronic pain, it's very tough, and the patient will be financially and emotionally will be very distressed and anxious. So these are my friends which help me in delivering the services. This is a fluoroscopy machine, and ultrasound is, and this is my radiofrequency ablation machine, where we do pulsar RF and thermal RF. Thank you. I thank IMA for giving me this opportunity, particularly Ramani Madam and Dr. Ravikrishna sir is my guru. Thank you, sir, for giving me this opportunity to participate here.
Thank you, sir. That was an excellent insight into the chronic pain management. And we'll be going to the next topic by Dr. Krishna Prashanti Garu, long COVID challenges to physicians. Dr. Krishna Prashanti ma'am, welcome.
Yeah, thank you very much. Good afternoon, everybody. First of all, I extend my heartfelt thanks to Dr. Ravikrishna sir, IMA State President, Dr. Fanida sir, State Secretary, Dr. Ramani Madam, and Dr. Ramesh sir, and all other executive committee for giving me this opportunity. Make it small. So I think we are running short and it's before the lunch, but it's a very important topic that it's a very new thing. A long COVID challenges for physicians. I have no financial disclosures for this. And my flow of presentation could be definition, pathogenesis, clinical features, diagnosis, management, and few take-home messages. Am I audible and my slides are visible?
Yes, ma'am, you're audible and your slides are visible, ma'am. Okay. Please go ahead.
Thank you. Thank you. Then what exactly is the prevalence of the long COVID? Long COVID is emerging as a major public health issue. It is often a debilitating illness that occurs in at least 10% of severe SARS-CoV-2 infections. The prevalence of long COVID varied within and across many countries. In USA itself, it is around 16 to 53%, UK 1.6 to 71%, China is 49 to 76%, but our statistics shows only 22, probably underreported. 65 million individuals worldwide are estimated to have the long COVID. The estimated incidence of long COVID is 10 to 30% of non-hospitalized cases, 50 to 70% of hospitalized cases, 10 to 12% of vaccinated cases. More than 200 symptoms have been identified with impacts on the multiple organ systems. Globally, 4 to 7 million people suffered from any of three symptoms of fatigue, shortness of breath, and cognitive problems. What is the exact definition of the long COVID? There is no universally accepted definition, but the National Institute of Health and Care Excellence has given a functional definition that symptoms that continue or develop after COVID-19, and the post-COVID syndrome is signs and symptoms that develop during or after an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by alternative diagnosis. Subacute or ongoing symptomatic COVID, 4 to 12 weeks beyond acute COVID-19, everybody knows. Chronic COVID or post-COVID, beyond 12 weeks of onset of illness, and post-acute sequelae of SARS-CoV-2 infection. WHO has modified this definition a little. So a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19 with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. This is very, very important. So you know this figure has been shown in many of the COVID presentations, the timeline. So 4 weeks, 12 weeks are very, very important. Acute long COVID is very, very important. But one point I want to emphasize upon to all the practicing physicians is long COVID-19 does not necessarily signify long-term viral persistence in the body. This is very, very important, and you go on doing the RT-PCR test and you will get negative. So what are all the consisting risk factors for getting this long COVID? So advancing age, female gender, severe disease, and the probable factors which would predict long-term symptoms include severe COVID-19 requiring hospital admission, elderly age, obesity. This is very, very important. And in the first week of acute COVID, you are having 5 symptoms. That is also a significant risk factor for long COVID. So what is the pathogenesis? This is very, very important. Sometimes what they have shown is the persistence of SARS-CoV-2 and or fragments and high viral anemia at the time of diagnosis is the risk factor. Presence of SARS-CoV in different organs, persistence in the GI tract, and it causes the activation of other viruses. Most important is the Epstein-Barr virus and the CMV virus. And there is a myeloid activation, cytokines, PTX, glial cell dysregulation, tumor necrosis factor, IL-6, which is responsible for the brain fog and other things. Antibodies have been increased in number, which you have seen for getting the vaccination. Many doctors were running after getting this antibody titers, and autoantibodies have been there, autoreactive T cells is there, and fibrin amyloid microclots have also been there, endothelial cell and virus triggered microthrombi. So the hypothesized mechanisms are immune dysregulation, microbiota disruption, autoimmunity, clotting and endothelial abnormalities, dysfunctional neurological signaling, Epstein-Barr virus and human herpes virus. So this is in nutshell what you can understand, that every organ is involved in the long COVID, either it's a heart or brain or spleen or lungs or pancreas and the kidney and the gastrointestinal tract and the blood vessels, which will be knowing about what exactly is happening in each organ. When you take the respiratory, how the patients were presenting, patient do present with the shortness of the breath, persistent of the cough, exacerbation of the asthma, persistent radiological abnormalities, pleural thickening. Why all it's happening? When the virus has gone, it has almost 2 to 3 years is over, still you are seeing that there is a chronic inflammation resulting in the sustained production of reactive oxygen species. Endothelial damage triggered the activation of the fibroblasts. That's why you have seen the decreased expansion capacity of the lungs, endothelial injury, and all the hyperinflammatory response. How do the patient do present with the cardiac manifestations? We have auscultated hundreds of hearts during the post-COVID period. We have seen various arrhythmias, bradyarrhythmias, tachyarrhythmias, ventricular ectopic beats, atrial ectopic beats, everything you see, what is there in the arrhythmias you are seeing. Patient do present with the atypical chest pain. Palpitations is the most common presentation in the long COVID. Tachycardia, chest tightness, it's not a typical angina, but they feel they are not comfortable. They are taking a deep breath. That is the most common thing what the patients are explaining to the doctors. On ECGs, you are seeing the various conduction abnormalities. Patients are complaining of giddiness, orthostatic hypotension, vasovagal syncope, and the most important is the postural orthostatic tachycardia syndrome POTS. So patient do present with this myocarditis, epicarditis, and pericarditis. Vascular manifestations, it's a venous or arterial, venous thrombosis, arterial thrombosis, pulmonary embolism, thrombophlebitis, and you see the digital ganglions, various manifestations are there in the cardiovascular manifestation. So when you see that in the latest JAPI recently, what they have given this a very important figure. In the June 2023 JAPI, what they have given is what exactly is happening in the cardiac changes. There may be a direct vascular infection, hypercoagulability, myocarditis, direct myocardial infection, and inflammatory effects. What exactly is causing? It is causing a plaque rupture, it is causing an increased myocardial oxygen demand, and it is causing a decreased myocardial oxygen supply. So when you are seeing unexplained cardiac deaths, when you are seeing celebrities dying in the gym, when you see that you don't know why the young doctors or the young postgraduates are dying, that we don't know, is it because of the post-COVID, which is triggered the cardiac changes and resulting in the sudden arrhythmias, heart failure, and myocardial infarction. So I'm not going in detail, but most important thing I want to tell for the basic practitioner at the primary care level is a serial ECGs. The first ECG could be normal, but still if the patient is having a cardiovascular symptoms, you have to respect it. And a serial ECGs, echocardiogram will give the heart failure, the pumping, and the basic chest radiograph and the cardio biomarkers depending on the clinical condition. What exactly the patient is taking the pre-existing heart disease medication for his myocardial infarction, for his heart failure, for his tachyarrhythmias. All these drugs has to be continued. I have seen many of the doctors are discontinuing some of these prescriptions, and we have to continue what the cardiologists have been prescribing: the diuretics, beta blockers, AC inhibitors, ARNIs, mineralocorticoid receptor blockers, and anticoagulants. The most practical question the patients will be asking is, when should I restart my exercise? This is very, very important. Intense cardiovascular exercise to be avoided in all patients for at least 3 months, particularly for athletes and doing a very regular, very briskly walking and a gym and everything. A limiting exercise, a slow walking, increasing rest period is very, very important. Otherwise, it will cause a fatality. The other important organ is the brain. Neuropsychiatric manifestations in the long COVID we have seen, starting from the mild depression to the very extreme, the strokes we have seen. The fatigue is the most common symptom in the long COVID. Unexplained chronic headache, dizziness, and many of the patients even now they have the fever with anosmia or ageusia, and some patients didn't have the recovery within 6 weeks to 3 months, and a brain fog, a state of confusion. Many patients complain of memory disturbances, imbalance, vertigo, small fiber neuropathy, postural tremors, brain syndromes, depressions, anxiety. Many of the patients came with the palpitations, and if the family had a loss of a family member because of the COVID or a severe COVID admitted in ICU, post-traumatic stress disorder, psychosis and hallucination, sleep abnormalities. Even now we are seeing the sleep abnormalities, neurodegenerative disorders, and all the neurological manifestations like status epilepticus, stroke, ADPs, orthostatic symptoms, and a very, very non-specific symptom. So you don't know whether you are dealing with a long COVID or really an organic problem. And I want to emphasize upon one important thing is the pathogenesis of the cognitive dysfunction. Many of them, if the elderly patient comes and says that you take it's senile dementia or it's a vascular dementia or it's an Alzheimer dementia, but still we have a possibility of the long COVID into consideration because there is an activation of kynurenine pathway, there is an Alzheimer disease like signaling pathways, neuroinflammation is there, multilineage cellular dysregulation is happening, and tetrahydrobiopterin deficiency is there. So we have to understand the importance that we have to respect the patient's symptoms. And POTS is an important condition which is associated with G protein coupled adrenergic receptor and muscarinic acetylcholine receptor antibody, platelet storage pool deficiencies, and small fiber neuropathy. How do you suspect? If there is an increase in heart rate of more than 30 per minute in adults, or more than 40 per minute in children, within 10 minutes of adopting an upright posture, absence of postural hypotension, symptoms of orthostatic intolerance for more than 3 months, suspect POTS. So patient do present with dizziness, palpitation, exercise intolerance. Many patients are telling that pre-COVID I used to walk for 6 kilometers. Now I cannot walk for even 1 kilometer. This is a very significant history which we have to exclude. Abnormal autonomic function tests have been seen in more than 12% of the patients. Always suspect POTS if the patient is coming with autonomic symptoms. The other important is the chronic fatigue syndrome and myalgic encephalomyelitis. So these are the essential criteria when you want to suspect a chronic fatigue syndrome. Substantial impairment in the ability to perform activities carried out prior to the disease for more than 6 months, profound fatigue not relieved by rest, discomfort or aggravation after physical exertion, unrefreshing sleep. This is very, very important. The chronic fatigue syndrome, at least one of the 2 additional criteria must be present: cognitive impairment, impairment of executive functions, thinking that worsens with exertion, stress or pressure, and orthostatic intolerance. So cognitive impairment is very, very important in making a diagnosis of this myalgic encephalomyelitis. So there are various postural mechanisms that there is a decrease in natural killer cell function, T cell exhaustion, mitochondrial dysfunction, channelopathies, deformed blood cells, decreased cerebral blood flow, and vascular and endothelial abnormalities. And most important is the exercise intolerance. Many patients in our OP are giving this, that we are having this exercise intolerance and fatigue which is not relieved by the regular things. So what are the simple basic investigations which you can suspect? A CPK will give a clue, nerve conduction studies, CSF analysis, cognitive function assessment, brain MRI, autonomic function studies, EEGs, and polysomnogram. But for a basic primary care physician in a rural area, in a semi-urban area, in a private practice, for all the IMA doctors, what I urge upon is a good detailed history, a thorough clinical examination, regular follow-up at appropriate intervals is the best way of investigating the patient. Mind you, your MRI could be normal, but still the patient is having a neurological problem. The other important thing is the gastrointestinal manifestations. In the COVID, every person became a doctor and every patient is a doctor, every pharmacist, every lab technician is a doctor, and many patients are using the OTC drugs of PPIs, proton pump inhibitors, just like that, Pantop, Rabitop. They are using like a normal chocolates. So every patient is not giving importance to these gastrointestinal symptoms. In COVID, COVID-19 induced new onset symptoms, persistence or aggravation of pre-existing symptoms, and the drugs used in the treatment of GI for various other diseases causing the GI symptoms. For all the risky persons, severe disease, older age, admission in ICUs, RTIs, gut dysbiosis is very, very important because of our medications, either antivirals or the antibiotics. Indiscriminate use of antibiotics for each and every small issues is responsible for the gut dysbiosis. Liver injury because of the COVID-19, drugs, remdesivir, and all other alternative medications, Ayurveda, naturopathy, immune boosters, whatever is there on the globe and even on the moon, the drugs have been tried in the COVID, and the polypharmacy is the most important risk factor. How do the patient present? Loss of appetite, very, very common. Weight loss, also common. Abdominal pain, they think it's amoebiasis and APDs. Nausea and vomiting, dysphagias, diarrheas, flatulence, altered bowel motility. All these symptoms you think because of the age, because of a long-standing diabetes, or because of this chronic constipation, but still you have to keep in mind about the long COVID. Why? The gut microbiota dysbiosis is there. Higher levels of ruminococcus and bacteroids have been found. Lower levels of Faecalibacterium and butyrate-producing bacteria has been found. Higher levels of fungal translocation, which we have been forgetting all these days. So what are all the nephrological manifestations? I am not going in detail because of the time constraint. Just I want to give a bird's eye view what exactly is happening in the each organ. And when you see the kidney, new onset AKI, acute kidney injury in a native kidney or a transplant kidney, rapid progression of a pre-existing CKD, progression of CKD to end-stage renal disease, new onset of a glomerular disease like proteinuria, hematuria, renal dysfunction, new onset of hypertension and worsening of hypertension. People are more worried about diabetes rather than hypertension. How do the patients present? The same thing, fatigue, unexplained weakness, nocturia, increased froth in urine. This is a very common in diabetic. You think of albuminuria, even the rosuvastatin sometimes cause the froth in urine, or even the fungal infections or bacterial infections, but respect that symptom. Anorexia, headache, swelling of legs, facial puffiness, breathing difficulty. This could be a cardiac or a renal or a pulmonary or a combination. And the presentation could be tachycardia, tachypnea, hypertension, anemia, decreased EGFR, microscopic hematuria, and infection. So what I want to urge upon is measure the blood pressure. That is very important. Measure the albumin in the urine. Examine the patient clinically. You can pick up the renal manifestations. I'm not going in detail about what exactly is happening in the diabetes because again, it's a very big chapter. But persistent glycemic abnormalities are there. New onset of diabetes because of the COVID. Young patients became diabetic, but they got reversed. It could be within 6 months to 1 year. But many patients who are on oral anti-diabetic drugs, they need an insulin because of the beta cell restriction. Insulinopenia was there. And sometimes we have seen that the patients have been on the higher doses of insulin and the insulin infusions when the patient are in a crisis. And the thyroid manifestations, we have seen a good number of thyroid patients. Subacute thyroiditis have common, de novo new hypothyroids are common. Hyperthyroidism is also very common, and a Graves' disease has been precipitated. And many patients in the post-COVID, after 6 months, after 1 year, they presented with varied manifestations. And you have examined the thyroids, you have seen the persistent abnormalities, but don't be hasty in making a lifelong diagnosis. Recheck and recheck. And they have observed that low level of serum cortisol was there and various lipid abnormalities. The most important is the triglycerides. We have seen our practice increased triglycerides in the long COVID. And the interesting thing is on the reproductive system. All these days we were worried about the brain, heart, kidney and everything. But what they have found in the long COVID is abundance of ACE2 receptors on ovarian and endometrial tissues had some alterations, like the menstruation and 1 week before the menstruation triggered for the relapse of the long COVID, irregular menstruation, infrequent menstruation, increased premenstrual dysphoric disorders, early menopause. All these symptoms we have seen in our practice, decreased ovarian response, increased ovarian cyst, pregnancy and postpartum challenges. Why? Because all these days we are making a diagnosis of PCOD, very common, insulin resistance, pre-diabetes, metabolic syndrome. Think of these possibilities also. In males, the interesting thing is the viral persistence in the penile tissue, increased risk of erectile dysfunction due to endothelial dysfunction, impairment to sperm count, volume, motility, morphology, concentration due to increased levels of cytokines. I urge upon all the obstetricians and gynecologists, infertility specialists to take this part into consideration, that before making them as an infertility workup and everything, a very good history of a COVID, and we don't know whether the vaccines are also responsible for that. And I'm not going in detail about a varied manifestations in the dermatology. Skin rash, hair loss is very, very common. After COVID, 80 to 90% of the patients complained the hair loss, nail alterations, cutaneous vasculitis, various bacterial like viral fungal infections, mucormycosis, everybody knows, and ocular manifestations. This is also very important. Recently, we had an article on ophthalmic manifestations in the chronic COVID, impaired retinal microcirculation, corneal small fiber loss, increased dendritic cell density, red eyes, and loss of vision. So what we thought from the lung to the heart to the kidney to the brain, you have seen every organ is getting affected. Now comes the question of vaccination. Is it really beneficial, or is it have some negative effects, or really is going to have a lifelong immunity? Vaccines gave partial protection, 15 to 40%. Long COVID is 50% less common in double vaccinated persons. There are a lot of research articles showing that long COVID was more common after Omicron BA2 rather than BA1. Reinfections and increased chronic fatigue syndrome are seen in long COVID sequelae in double and triple vaccinated individuals. I repeat that some doctors have taken 4 doses or also because of protection. Increased antibodies has again resulted all these things triggering the immune system. Vaccine-induced adverse effects are seen in various mRNA vaccines, vector-based vaccines. Some people, they have gone to US, they have taken vaccine, 1 dose that one dose this one, causing some cardiac manifestations and vascular manifestations and thrombotic manifestations. All these things we have witnessed in our practice. So in a nutshell, I want to emphasize upon you is in a long COVID, immune dysregulation occurred, microbiota dysbiosis occurred, autoimmunity and immune priming has been occurred, blood clotting and endothelial abnormalities occurred, dysfunctional signaling has been there in neurospinal cord. And what we have to see in a algorithmic approach is a COVID-19 survivor, a multidisciplinary clinics, a clinical history, physical examination, reasonably simple laboratory test, whether the patient is having any mild, moderate, severe, and a basic test, not all the tests for all the patients, depending on the history and a clinical examination. The future is for a saliva test or a biomarkers or a immune markers, we don't know. But still on these days, now you don't go for a D-dimer or LDH or ferritin. You know that all these are acute phase reactants. When a patient is giving a significant history, try to evaluate that abnormality. So now a lot of treatment modalities they are searching for. Really, is it doing something else? But everything says that for a tachycardia, you want to go for a ibrandine. You can't generalize and tell that this is the drug for a long COVID. So for a myalgic encephalomyelitis or a chronic fatigue syndrome, antidepressants, coenzyme Q is little bit of trying, and toll-like receptor antagonist, and for a POTS, midodrine alpha-1 adrenergic agonist and fludrocortisone have been tried, but these are all definite, not specific drugs. Another important thing for all the skin manifestations is mast cell activation syndrome. Antihistaminics can be used, and for the exercise and other immune dysfunction, there is no role for immune boosting diets or something else. Always respect your body, respect what exactly is happening, understand the symptoms, investigate accordingly, and treat like that only. All these are under the investigation pilot studies only. No definite treatment is there. So what exactly you want to tell upon for the primary care physicians. What William Osler told: observe, record, tabulate, communicate, use your 5 senses, learn to see, learn to hear to the patient, learn to feel, learn to smell, and know by the practice alone. By the practice alone, you can become the expert. I believe in that. Long COVID, let's hear the story of a patient. Believe the patient, don't refer. Go beyond the symptoms, address the fatigue, look to the familiar conditions before referring to a psychiatrist. Exclude long COVID. So my take home messages are: long COVID is an evolving new syndrome with myriad manifestations causing challenges in day-to-day clinical practice. It has already debilitated millions of individuals, and we don't know how the number will be. Our existing knowledge of pathophysiology, diagnosis, management is inadequate. Long COVID is a multi-systemic illness encompassing so many symptoms on the multi-organ systems. Cognition targeted therapeutics, metabolic modulators, immunomodulatory medications, antifibrotic managements are being used as no definitive drug treatment is available. Treatments that address hypothesized underlying biological mechanisms, including viral persistence, neuroinflammation, excessive blood clotting, and autoimmunity, are in progress. Numerous international and national research endeavors are underway to unravel the disease. On the basis of more than 2 years of research on long COVID and decades of research on myalgic encephalomyelitis, still no action has been taken. Research, training, education in medical schools, competency evaluation for clinicians, public education modules, and robust policies are needed in future. Rehabilitation programs for COVID-19 survivors should be planned, cautiously assessing cardio-metabolic risk factors by multidisciplinary team in special post-COVID clinics, ensuring the systemic referral system for a needy patient. So thank you very much for your patient hearing. And once again, I thank Dr. Ramani Madam for giving me this opportunity to speak to all of you.
Thank you, ma'am. That was an excellent insight into the management of long COVID symptoms. I request the next moderators to please take over.
Thank you, everybody. Thank you so much. Now, for the next session, we have surgery and allied specialties. And our first speaker on the topic of management of surgical site infections will be Dr. Madhvi Shamla, who is the professor of surgery from Kurnool. Ma'am, you can slide share your presentation now.
Please unmute, ma'am.
Hello.
Yes, ma'am. You're audible.
Hello, am I audible?
Yes, ma'am. You're audible.
Good morning to everybody.
Yes, ma'am. You can do the slideshow, ma'am. Yeah.
Excuse me, who are the panelists in this group? Hello.
So the moderators of this group were Dr. Bal Madhya, Professor of Surgery, Kurnool, Dr. P. Shyam Prasad, and Dr. Ram Mohan Reddy from Kurnool. But as we have contacted them, they were busy with some urgent piece of work. So we'll be starting without our moderators in this session, sir.
I was told Dr. N. Subramaniam as one of the moderators in this group. Is it so or not?
No, sir, not in this group, sir. He's the moderator in the next session, sir.
Oh, next section, yes. Okay.
Yes.
Right.
Sir, you can continue as moderator for this session also, sir.
Sir, Subramanian Garu, please be the moderator for this session.
Yeah. Yesterday, who that Ramani called me and told me that I am as a moderator for the surgical things. So,
please continue as a moderator for this.
Sir, please, sir, as secretary of this thing, I'm requesting you to be the moderator, sir, please.
Okay. There's nothing to invite. We are all one. As the past president of IMA AP State, I am very happy to be
it's a privilege for us.
For this session. I must congratulate the Dr. Ravi Krishna and the team, AP IMA team, and Dr. Ramani, the chairman, and the Dr. Ramesh, the secretary of AMS, for conducting an excellent CME program for 2 days with 6 credit hours is an excellent topics are there in this. I am very happy because as a past president, I am very much interested in the academic aspects of IMA AP State. My only request to all the participants at present, more than nearly 700, all of you please become the members of IMA AMS AP State Academy of Medical Specialties. It is a simple procedure with a minimal payment and all become academy and is available. Now, we it's not there. It is muted. So once again, thank you very much, Dr. Ravi Krishna and the team IMA and Dr. Ramani for inviting me to be the moderator for this. IMA AP State AMS is doing excellent job by conducting this type of CMEs very frequently. I am very happy as the past president of IMA AP State to have the academic and my only request, I don't know whether you heard it or not, all the participants please become the members of IMA AMS AP State. It is a very simple procedure. By paying a very small amount, you become the life members of AMS and also enjoy all the facilities, including the getting a fellowship in the AMS. So please become the members. We contact our chairman or the state office for becoming this thing. Now we'll move on to the topics of today. We have got excellent topics. Some of them are general surgery topics. Even though I'm a neurosurgeon, basically I had general surgery MS also. So I would like to hear this thing. Management of the surgical site infections. It's an excellent topic when many of the surgical procedures may have the infections. Dr. Madhavi Shyamala, Professor of Surgery. Please carry on, madam.
Thank you, Subramanya sir, for giving a message and accepting to be the moderator for this session. Thank you, sir.
It's a pleasure. Dr. Madhavi Shyamala, please.
Yes. Good morning, everybody.
Ma'am, try to share your screen 1 second, ma'am. Yes, ma'am. It's visible. Ma'am. Please go ahead, ma'am. It's visible, ma'am. Please go ahead.
Oh, okay. Are my slides are visible?
Yes, ma'am. Yeah, they're visible. You are audible.
Thank you.
Please carry.
Good morning, everybody. First of all, let me thank Dr. Ramani Madam and the organizers for giving me this opportunity. I'm Dr. Madhavi Shyamala, Professor of Surgery from Karnal Medical College. Today's my topic is management of surgical site infections. First of all, let us know about this person, Inez Semmelweis. He is an Australian obstetrician who first said that if you wash your hands before going from one patient to other patient, especially from the postmortem to labor room, the infection rate will be controlled. Like that he told, but nobody believed him, and he died in mental asylum at the age of 47 years. And after his death, after 20 years, this has been taken up. And we all know Louis Pasteur, who proposed the germ theory, and this is the person, Alexander Fleming, talked about the magic bullet. The sulfonamide chemotherapy has given the antibiotic resistance, and antibiotic decreased in the wound infection. And Lizard, he has given about the exogenous disinfection. So, his screen image
Ma'am, it's clearly visible for us, ma'am. You can continue, ma'am. Yes, it's looking good. Yeah.
So surgical site infection is the one. Yes, this is now. Surgical site infection is the one. The infection is which is located along the surgical site within the 1 month of the surgery, or if the any implant is present or mesh is present within the 1 year of the surgery. So why we are worried about the surgical site infections? Because most of the hospital acquired infections, 14 to 16% of hospital acquired infections are are present in the surgical site infections. Here, because of this, screens are ghostly. Please give out. Yes. So, among the hospital acquired infections, third most common are the surgical site infections. These are mainly due to the healthcare personnel and because of the environment. So, which causes the increase in hospital stay and increase in the economy of the patient, and also it is disastrous to the patient.
Carry on, madam. You are audible and visible. Slides
We are encountering some technical problem here.
Okay.
Yes. Okay. Yes. So surgical site infections then be classified as superficial, which are related up to present superficial skin and submucosa, and deep up to the muscle layers and the organ space infections. These organ space infections may give rise to wound disease. So the cost postulated that what organism can be known as the pathogenic organism. So it should be isolated from the host, and you should be able to reproduce it, and it should be, when given to the healthy person, it should cause less damage, and when it is experimentally retrieved from the host, it can be seen in the laboratory. So like that. And surgical site infections depends upon type of the wound and whom we are operating, in which circumstances we are operating, how we care about the post-operatively about the patients. So surgical wounds are again classified into 4 types. Clean wound. This is a clean wound. This is a wound of simple hernia. Here there is no infection in the wound. Whatever the infection will give, that should be from the external side. And these are the clean contaminated wounds. In the clean contaminated wounds means there is already infected microorganism will be there in the one of the dissecting parts, like appendix or gallbladder or some nose like that. So organism will be already present in the infected area, in the operative tissue. So that when we spill it into the, while removing the tissue, if you spill, the surgical site infections will occur. So another one is the contaminated wound. All cavities may be contaminated, like in cases of peritonitis, in cases of any empyema gallbladder burst is there. So like that, already wound is already contaminated from the inside. And dirty wounds are the one here, because apart from the infective organisms on the skin or like that, mud, grease and everything from the environmental factors also, chemicals also will be there. These will call it as the dirty wounds. So we should know about the wounds so that for which wounds what we have to treat, like that we can see. So what are the factors influencing this surgical site infections? So when we come to the patient factors is extremities of the eyes are more vulnerable to the infection, and when the patient is immune suppressed one, and the patient who are on the steroids, and the patients suffering from the malignancies, and the obesity patients, diabetes, malnutrition, and other comorbid conditions, who has taken multiple transfusions, and the patients are on smoking, and the patients are less oxygen supply, and hypothermia or hyperthermia, and control of the sugars, less control of the sugars is there. Those patients have more prone for the infections. When coming to the organisms from where this comes, they may come from the remote site of the infection. Long term, when the patient has been admitted to the hospital for some other reason, maybe have suffered from any viral fever or anything, 2-3 days, 2-3 weeks before, and the same patient presented for the surgery, they will be harboring some microorganisms. So, and the patients who are on the long-term therapy, patient has been admitted in the hospital, they will be present for more days. The investigations will be going on, and the patients will be there. But the hospital environment itself is a pathogenic one. The mattresses, bed, environment, everything will be pathogenic of the previous patient may be present. So that also can be that also can have more prone for the infections. So duration of the procedure. If the procedure is more, it is taking more time. So the viscera is exposed to the environment more. The environmental pathogens will be present in the operation theatre. So they also can cause inoculate in the wound site. And depending upon the type of the wound, those type of wounds, except for clean wounds, other 3 wounds have more chances for the surgical site infections. And the patients present in the intensive care unit patients. Those intensive care unit patients, you can see all the ventilators, all the materials and present around the intensive care are all infectious, and the patient's resistance will be there in intensive care unit, so they have more nosocomial infections. And the previous antibiotic therapy, the patient might have taken antibiotics for some other diseases, and now if you give antibiotic, they may not respond to the patient. And the one is the perioperative shaving. We'll see show that in another side. And depending upon the bacterial number, bacterial virulence, and antimicrobial resistance, these will have the effect on the how much infection they can produce on the surgical site. So the other factor is the local wound factors. Local wound factors, the surgical technique, poor surgical technique. If you tie the knots very tightly, and if you don't bring the hemostasis, if you leave more dead space, then and if you leave the necrotic tissue, and those will have more chances for the surgical site infection. And the suture material what you are using should be sterile and used in the sterile technique only. And the drains, you should minimize the drains. Less drains, less infection. More drains, more infection, because the drains will be acting from the environment. They will carry the infection into the body cavities. So what are the foreign bodies? Foreign bodies that may be present in the dirty wounds. Foreign bodies of the vegetative foreign bodies may be present. Stones and everything, grease, everything may be present. That should be taken care of clearly. And foreign bodies we implant in the body, like mesh, any implants, that should be very sterile. So unsterile foreign body should be removed. And any foreign body we are keeping in the body, that should be sterile one. And the area which we are operating, if it has taken any radiation for some other disease, that have less healing capacity. So like that, these are all the local wound factors. And what about the environmental factors? Environmental factors, see the contaminated medications and disinfected, less inadequate disinfection, inadequate skin antisepsis, and inadequate ventilation also. These environmental factors also play in the surgical site infections. The treatment factors, like I told, drains and emergency procedures, where we cannot take much care about the antisepsis. So emergency procedures, and the patient is in hypothermia, and the environment will keep the ACs. So hypothermia, environment factor also will be present there. So an inadequate antibiotic prophylaxis and less oxygenation and prolonged preoperative hospitalization, prolonged operative time. These have effects on the surgical site infection. So when we see that all we have seen the patient factors, organism factors, and the local factors. Now we'll see from where we'll get what is the source of the microorganisms. Source may be endogenous and exogenous. Endogenous source is the one where there is already present in the host, like in the gut, nasal cavity, and oral cavity, other some cavities. So already colonizing bacteria will be present inside they are present from the patient, and the exogenous are all from outside, from the environment, from personnel and from the theater and from all materials. So you can see here, thus the patient on ventilator, see everything is infected to this, including the tubes, ventilator, drugs, everything is infected to the patient, and the patient resistance is very low. So these patients will get more infections, and also they may get pneumonias also. So that also very hazardous thing. And the remote patient having catheters in the urinary catheters or IV catheters. These remote infections also perioperative causes, they will cause infection. So these are the perioperative causes for the infection. Next is the factors that determine whether the wound will get infected or not. Like I told, host response to the injury. Whenever the organism is attacked, that if it host can able to destroy it, it won't get infected. So host response, the host is comorbid conditions are present, there will be infections. And the attacking the organism, it is highly virulent, then infection is likely to occur. And vascularity of the tissue. If the vascularity of the tissue is compromised while during the surgery, vascularity, then we can have the infections. So like that, any foreign body, dead tissue or foreign tissue will have more chances of infection. And there is one word, decisive period, presence of antibiotics during the decisive period. What is this decisive period? Decisive period is the one where the higher antibiotic concentration can be produced in the body. If we are operating for any hernia, inguinal hernia, you are operating for inguinal hernia, which is very clean wound. But while reducing the contents, you might have injured the enterocyte. If it is enterocyte, we may injure the bowel, or while doing the cesarean section, you may injure the bowel, adjacent bowel. So that the breach of the adjacent organs, especially gut, if then there will be to inoculate the organism into that wound area and to develop, it takes at least minimum 4 hours. Within that 4 hours, the antibiotic should be there in high concentration, the appropriate antibiotic with high concentration in the tissue and blood level should be there. Then that can decrease the wound infections. That is called the decisive period. So this decisive period you should keep in mind. If you are thinking that it is a clean wound, if it gets contaminated, you have to give antibiotic immediately. So how it presents? Surgical site infections, how they present? They can be presented as cellulitis, lymphangitis. See, because of the tight suture, there will be edema, and that edema will cause cellulitis, and there will be, because of the tightness, there will be lymphatic obstruction, and that will cause cellulitis. This is the one where the patient have mild pain. Mild pain, fever may not be present, and the patient will have just discomfort in this at this stage, and that may develop progress to one stitch abscess. Stitch abscess is the one suture getting infected, 1 or 2 sutures getting infected. So here the patient will have severe throbbing pain and slight temperature may be present or may not be present. Other inflammatory changes will be seen, like rubor, dollar, collar, all inflammatory signs will be seen, and the pointing pus will be there. This is the stitch abscess, and abscess along the entire length of the wound. Abscess may present. If not treated, lymphangitis, it will go to stitch abscess and it may go to abscess. And sometimes, if not treated properly, chronic infections may form the discharging sinus. And sometimes, if any bowel or anything has been taken eroded into the wound, mesh eroded or any wound eroded, it may form sometimes infection from deeper structures may come to superficial area, and superficial infection may also go into the deeper area that may have intracutaneous fistulas also sometimes. So this is the infected mesh. You can see the pus and everything is here. And after that, usually sometimes if the patient condition is not good, not wound healthy is not healthy, that may give away. That is the wound essence. So these are the different types of clinical presentation. So in the wound essence part, in the lymphangitis, there will be less symptoms. And abscess period, the patient will have all features of the infection, like high temperature and toxemia features will be there. And in the if the patient comes to the wound essence, the systemic infection, systemic disease also might have been established. So you have systemic other septic shock features also can be seen in that conditions. So where local infection may be converted into the systemic infection. What happens when the systemic infection is present? So there will be bacteremia and cells and moths may develop. So when do you say it is cells? There should be presence of 2 out of 3 of the following: hypothermia or tachypnea, tachycardia or tachypnea, or WBC count more than 12 lakhs or less than 4. So like that, it can be, we can say it as whether patient has gone into the SARS or not. And this may go into severe sepsis. Severe sepsis, 1 or 2 organs might have been involved. If the lungs are involved, the patient will present with ARDS. If the cardiovascular system is involved, the patient will present the septic shock, follows. And if the renal system is, the renal shutdown will be there, and patient may go into DIC or patient may go into coma also. So like that. So these are the multiple organ dysfunction syndrome patient may land into. Why? Because why it occurs? Because of the patient will be in parenteral nutrition. So gut has no function. So because the gut has no function, they will colonize the bacteria. Or that colonized bacteria will release the endotoxins, and that can trigger the cytokine release and leads into the mods and cysts. So how we have to manage this? How will you manage it? Depending upon the what we have to do. When you think of there is surgical site infection, just do some CBP, know the hemoglobin level of the patient, and whether the patient is anemic or this is chronically ill patient or any leukocytes count is increased or not, and you send the pus for the cultural sensitivity. We can give the proper antibiotic by knowing the organism and knowing the antibiotic sensitive. And if the patient is chronically admitted in the hospital, you can, before the surgery also, you can send the blood for culture sensitivity, because to know the already existing organisms in the body. Or if the patient is in septicemia, then also you can send the blood for culture sensitivity. And in the ultrasound also, you can see the pus cavities. And if the wound is having sinuses, you can go for the sinograms. And if there is you think any intracutaneous fistulas, so CECT, oral Candros, like that, depending upon the stage of the disease, you can have the investigations. And what is more important? See, we have seen the infection, how it comes, and in which patients it comes, and what investigations to be done. Before going to the treatment, we should think one is most important in surgical site infections is prevention. Prevention is better than cure. So how we have to prevent? Prevention by
Please
mainly
conclude, madam.
the
Please
shaving.
conclude.
Shaving is will have infection 5 to 5.6% with razors. Without shaving or with hair removal techniques, you will have only 0.6%. Depilatory method only you have 0.6%. So when to shave? When to shave? Just before keeping the knife is very safest one. If you do before within 24 hours, you will have 7.1% surgical site infection chances. If you do more than 24 hours, you have more than 20% of the chances. So use this one. And what about the environment? Environment, the operation theater is a very, very complex one where people are moving. Surgeon will be with stress, and anesthesia team will be with stress too. How to do? They may not concentrate on the sterile techniques. They will be charting, and masks may not be placed or any like that. So the personnel, the team of the team, and the entire OT, all including roof, environment, table, everything is infected to the patient. So that also has to be kept in mind. So what has to be done? There should be workflow zoning should be there. Airflow, air that flows into the theater should be pathogen free, and you should have good sterilization department, and the movement of the staff should be restricted, and there should be antiseptic techniques in each and every step. So preoperatively avoid antibiotics and minimize the hospitalization, treat the remote infection, decolonize, and you have the patient should have some chlorhexidine bath, and malnutrition that should be treated, and patient should have stop the smoking and should be euglycemic. See, these all instruments should be sterile, and the attire should be surgeon's attire and scrub nurse, everybody should be in sterile one. And intraoperatively use aseptic technique, tension-free suture, and operative time should be minimized, and minimize the exposure of the viscera. When you are doing the surgery, all intestines may be coming out. You may be operating on one side. So other intestines or other viscera are exposed to the environment. Cover them so that there will be less exposure to the environment, and minimize the drains. Keep the drains, the drains should be there, and the placement of the drain should be correct. See, this is the CRD, only dependent drainage. Dependent drainage should be in the dependent portion. If it is not kept in the dependent portion, here the pus will collect and it won't drain out. So the purpose of the keeping drain is last here. So like that, the correct placement of the drain should be there, and drain wound should be, it should not come like this from the same wound side. There should be come out from separate wound, and there should be good hemostasis. So there should not be any hematomas, and if any devitalized tissue is there by using the cartridge or anything, that should be removed. That should not be kept on like closed. So minimize the personnel in the operation theater. Minimize the personnel, minimize the personnel, minimize the personnel. So that is the during the operative period. So post-operatively, again, minimize the catheters and IV lines. Those will carry the infections, and maintain oxygenation, hydration, and nutrition of the patient. And about the wound management, dressings. Dressing should be no touch technique. See, whenever you are doing the dressing, first do the clean dressing, then go for the contaminated dressing, then go for the dirty wounds. If you do the dressing in the first contaminated case, and if you do implant the mesh, the patient will have miserable life. See, surgical site infection is a nightmare for both patients and the surgeons, for the doctors. It is nightmare for both. So we should avoid our nightmare and we should avoid the patient's nightmare by using the proper techniques. And drainage of the pus, it should be open drainage or closed drainage by vacuums like that. So we have seen the different, and the most important thing is the antibiotic use. Antibiotic, the principles in the antibiotic therapy is evaluation of the possible infection should be done by blood cultures or pus cultures, and empirical antibiotic therapy should be given. So when to give the antibiotic prophylaxis, if it is given preoperatively before the incision less than 2 hours, it have 0.6% of the chances of surgical site infections. So like I told, other one has more infection possibilities. So antibiotic prophylaxis, it is that the antibiotic should be safe and it should have spectrum, broad spectrum antibiotic should be there, and it should be narrow spectrum between the relevant pathogens, and there should not be relied, and administration should be done ideally. And if the procedure is going on, then add for add the antibiotic after 4 to 6 hours of the surgery. So all perioperative contamination should be removed. So this is the one high, the antibiotic should be how it should be high in serum level and IV route, and highest dose during the surgery should be there like that. So when to give like that, already I told, preoperatively before the cutting of the tissue, and it should have long life like that. So in colon surgeries, oral antibiotic may not be appropriate. So you can give the antibiotic along with the mechanical preparation, or you can use the systemic antibiotics. In the dirty wounds, fascia closure should be there if possible. That wound should be covered all after cleaning that, and there should be wet to dry dressing, and delayed primary closure can be seen, observed. So how long will you do? For clean wounds, one dose is enough. For if you think any contamination is there, up to waiting for the culture, you can have up to 72 hours. If the culture is negative, you can stop the antibiotic. If the abscess is there, you can give for 5 days. And if the infection is more, you can prolong the antibiotic usage. So when giving antibiotics, we have to keep the toxicities also in the mind. See, this is one of the patient who has taken antibiotics, all types of antibiotics before coming to us. The patient, when we have sent for the first for culture sensitivity, they landed in all our resistance except cholesterol. See, because in our circumstances, antibiotic abuse is there. The patients, RMPs, those who are not entitled to give the medication, they will give the medication in the medical shop or in the RMPs, or any person, any old patient also will prescribe the antibiotic. So because of that, antibiotic abuse is there. Because of the antibiotic abuse, antibiotic resistance is there, and when there is a need, we will not able to save the patient. If it goes like that, antibiotic abuse goes like that, we may sometimes again go back to the olden days and may die with infections. So,
Madam, please conclude your talk. You already exceeded your time, please.
Okay, just I'll finish off. See, the cellulitis can be treated with symptomatic treatment given, and when there is abscess, drain the abscess and keep open. The draining may be open drainage or closed drainage with suction drains, or see, you can if the sinus tract is there, the sinus tract should be excised. Here you can see the sinus tract, deep sinus tract, because LSCS infection having the umbilical sinus. periumbilical sinus. So I have made midway incision and remove the tract here and remove the tract above and kept this tube for irrigation of the wound so that to avoid the recurrence. The sinus tract should be removed, or if the implant is infected, that implant also should be removed. If there is wound dehiscence, that should be closed. So what is the take home message is prevention is better than the cure. So practice the universal precautions, treat the comorbidities, apply the good technique and less strains, appropriate use of the antibiotic, early detection of the infection and appropriate treatment will solve the surgical site infections. Thank you for giving me this opportunity.
Thank you, Dr. Madhavi Syamala, for the excellent talk you have given. It is the surgical infection or post-operative wound infection is a nightmare for all the surgeons who are doing operation, whether it is a minor or major operation. And surgeons will be very happy to see our patient without any surgical infection in the post-operative period. Now we move on to the second topic in the surgical section. And I request once again, I request all the speakers to stick to their timings. Otherwise, it is very difficult to manage it. The second topic is solitary nodule in thyroid, to operate or not to operate. Dr. P.A. Ramani, Professor of Surgery at Vijayanagaram. Dr.
Good afternoon, sir. Before we could have Ramani ma'am with us for the topic, we have Dr. T. Girdhar, MS from Kadapa. He is going to present firstly on gallstones, causes and management.
Okay, third topic, Dr. Girdhar, gallstone causes and management. Okay, please start, Dr. Girdhar.
Dr. Girdhar, we are not able to hear your voice.
Unmute yourself. Yes. You are not audible. Please unmute yourself. You are muted. You muted again. Yes. Please carry on.
Audible, sir?
Yeah, now it is audible. Please.
Sir, please screen share, sir, again, once again.
First of all, so thank you, sir. Thank you.
Yeah.
This opportunity, Dr. Nasramani, Chairman.
Is there? The slides are seen.
Chairman, IMA Academic Session. AMS. So today my topic is the gallstone disease. The presence of the gallstones in the gallbladder is referred as cholelithiasis. The Greek whole is bile, a liquid stone, and dialysis is the process. Greek surgical anatomy is a pear-shaped structure on the other side of the liver, 7.5 to 12 centimeters long, capacity 35 to 50 ml. The body, the regions are the fundus, body, neck, and the infundibulum. The mucosa contains strips of viscera. The cystic duct 3 centimeters in length, 1 to 3 millimeters in diameter. The mucosa contains walls of viscera, and it can also have got sphincter of Rutgens. So the talus triangle is important in the dissection of the gallbladder, formed by the cystic duct and the common hepatic and the lower margin of the liver. And it contains the cystic artery and cystic lymph node of Lund, which are important for the dissection of the gallbladder region in the open or in the laparoscopic procedure. The anomalies is a caterpillar type. So that's why surgeons have to be aware that so many anomalies are there. Here the hepatic artery itself is caterpillar. In the other picture, the cystic artery is an anomaly. CBD, the common hepatic duct, less than 2.5. CBD is 7.5 centimeters. It has got 4 parts: supraduodenal, retroduodenal, infraduodenal,
and intradural. Cystic artery arises from right hepatic artery and accessible cystic artery from sometimes arising from the gastroduodenal artery. Coming to the epidemiology gallstones, the most common biliary disorder, prevalence more in female population in Asia. The prevalence increases with age. In American Indians, it is the highest incidence in the world. Overall prevalence 64% in women, 34% in men. Cholesterol stones are common in developed countries, whereas the brown pigment stones are more common in developing countries. In Asia, it is 80% of the cases they are pigment stones. In USA and Europe, 80% are cholesterol stones. More common in North India compared to South India. Prevalence is more in females. Risk factors for gallstone formation. Incidence increases with age because of more cholesterol production. Female gender. Central obesity, metabolic syndromes, and eating high calorie carbohydrate diet. And many people after bariatric surgery, about 35% of the patients they develop gallstones. And after 3 months of ATM, total parenteral nutrition, 45% patients they develop the gallstones. The patients who are with low physical activity are more prone for it. And 30% of the gallstone disease has got genetic predisposition. The other risk factors are hemolytic disorders, multiparic, cirrhosis, decreased bile salt synthesis and absorption. You know that cholesterol is kept in solution form by detergent action of phospholysis and bile salt. Crohn's disease and ileal dissection, malabsorption. Estrogen increases cholesterol secretion because of the hormonal effect, and in progesterone it causes impaired contractile motility. Also, long-term use of antibiotics are not responsible factors for the gallstone. Coming to the types of gallstones, cholesterol stones, pigment stones, and mixed stones. The factors which are associated with the gallstone formation are impaired gallbladder function, that is, delayed emptying, absorption, and excretion, and cholesterol mediating factors like production of mucus, glycoprotein, and infection. Supersaturated biologics, content of the cholesterol is more, or the content of phospholipids or bile salts is less. So, the bile is supersaturated and results in formation of the stones. As it increases, more cholesterol is produced. Next woman is more hypercholesterolemia, genetical, sometimes obesity, and diet factors, and absorption and enterohepatic circulation of the bile acids, which are responsible for the detergent action to prevent excess cholesterol. So when there is a resection or under some other factors, it also leads for the formation of the gallstones. The necrodensis, the cholesterol supersaturation, nucleation, and growth of the stones. The pigment stones, they contain less than 30% cholesterol. There are two types, black and brown stones. The black stones, 20 to 30% of the cases, insoluble bilirubin pigment polymer, mixed with calcium phosphate and calcium carbonate. The incidence rises with the age, and hemolysis, hereditary spherocytosis, or sickle cell disease. The brown pigment stones, where in the gallbladder, the more in the bile ducts, related to bile stasis and infected bile. They contain calcium bilirubinate, calcium palmitate, and calcium stearate with cholesterol. Due to decombination of bilirubin accumulated by bacterial beta glucuronegases, insoluble unconjugated bilirubinate precipitates they form. And foreign bodies also responsible for the formation like endoprosthesis like parents. Parasites, Clonorchis sinensis or Ascaris lumbricoides, blocking the lumen of the duct, predisposed for the formation of the brown pigment stones. These are the mixed gallstones. Natural history of the stones. Most gallstones are asymptomatic. Only 10 to 20% develop symptoms over the 5 years. Only 1% develop the complications before onset of the symptoms. The clinical presentation, most of the cases, is visceral finding. And some people they present with right upper quadrant pain or epigastric pain radiating in the back. Dull constant pain may be colicky. Patient may have dyspepsia, intolerance to food, fatty food, biliary colic, right upper quadrant pain with nausea and vomiting. Pain often starts might awakening the patient. The effects and complications of the gallstone. If the gallstones are present in the gallbladder, it can present with one biliary colic or with acute polycystitis, or it can present with the mucosa of the gallbladder, that the stone blocking the neck of the cystic tract. So the bile gets absorbed and mucus produce a huge swelling. Sometimes these swellings are called in glandular fossa. And once they get infected, it becomes an empyema of the gallbladder. Gallbladder can be perforated and the acute polycystitis becomes gangrenous. Next one is chronic polycystitis. Suppose the stones are in the bile duct, it can produce biliary obstruction, acute cholangitis, acute pancreatitis. Suppose in the gallbladder, by the Mirifies syndrome, suppose the stone is in the intestine, it can produce gallstone lesions because erosion of the stone through the duodenum, through the gallbladder into the duodenum and passing through the bowel can cause intestinal obstruction, that is gallstone lesions. The grading of the acute polycystitis Stoffel consensus guidelines for severity grade. It is grade 3, grade 2, grade 1. Grade 1 is the mild type, whereas grade 3 is the severe type of polycystitis. Pathogenic mechanisms, how the acute polycystitis infection, bacteria, E. coli, Staphylococcus, Enterococcus, Klebsiella, Clostridium, and Proteus. The viruses of the hepatitis, the parasitic infestation of the gallbladder and duodenum. They can all produce infection and be responsible for it. The route for viral contamination, hematogenous from portal vein or respiratory, or it may be lymphogenous, or the infection can be ascending from the intestine. The source for viral contamination, all total chronic infections in the body like tonsillitis and sinusitis, they can also lead to the infection and gallstone. And increased immunodeficiency. Investigations routine mammogram, LFT, blood sugar, routine investigations, and PT, CXR, EC, ultrasound, MRCP, CT scan, PETA scan. Ultrasonogram, innovation, great innovation in diagnosing the gallstones, highly sensitive and specific, and the appearance and embodiment focus, acoustic shadowing, that is characteristic of gallstones. It is also helpful in polycystitis and also in cholelithiasis. CT scan is less sensitive. Gallstones are isodensed by useful for cause and site of obstruction of the biliary tree. Also, there is very useful in the neoplasms of the biliary tract. This is the shadow gallstone. MRCP can define superior anatomical definition. Both intrahepatic and extrahepatic biliary tree can be located. Also, it is very useful for the complex biliary disease and in the neoplasms. PRCP, invasive, diagnostic, and also therapeutic, useful in the complicated gallstone disease. The MRCP picture of the picture. PRCP, normal, is dilated CPD with multiple stones in the common bile duct. Differential diagnosis, where the people may appendicitis, a perforated gastric ulcer, and acute pancreatitis. The rare causes acute pyelonephritis, myocardial infarction, pneumonia నివారణ రైతు పరిధిలో treatment conservative operative. The gallbladder will tolerate the presence of large number of stones for indefinite period of time. Right? That is a master. The operative is laparoscopic and open cholecystectomy. Innocent gallstone is a myth, and early cholecystectomy decreases mortality and morbidity associated with prolonged gallstone disease. That William Mayo. Non-operative, only typical oral bile salt therapy, contact resolution, SWA, lithotripsy, but 50% recurrence rate is there. Now, the gold standard method followed entire world in laparoscopic cholecystectomy for symptomatic gallstone disease using 4 ports, umbilical, epigastric, and calcular, and anterior activity ports. Prophylactic cholecystectomy is advisory condenser pneumonia anemia. Gallstones can be the size more than 2 centimeters, and calcified gallbladder organ is the porcelain gallbladder. Laparoscopic cholecystectomy is a standard procedure, gold standard procedure, minimal invasive. The removal of the gallbladder essentially has replaced the open cholecystectomy. Indications are symptomatic cholelithiasis, urticolitis, gallstone pancreatitis, cholangitis or obstructive jaundice, asymptomatic cholelithiasis, that is sickle cell disease, total parenteral nutrition, chronic immunosuppression, open bariatric surgery, and also it is indicated in acalculous cholecystitis, gallbladder dyskinesia, gallbladder polyps, and in porcelain gallbladder. Contraindications are absolute and relative. The absolute contraindications are refractory coagulopathy, metastatic disease. Relative contraindications: diffuse peritonitis, gallbladder carcinoma, cholangitis, cirrhosis, COPD, polycystic morbid obesity, and pregnancy. Complications of bleeding in the cystic artery, infection, especially if it is emphysema, suffering gases, injury to surrounding structures, CBD, and to take care of the CBD, deodorant, leak from the biliary by the cystic duct or biliary fistula formation, or injury to the CBD resulting in biliary stricture. So this is the procedure that we have procedure for progress, umbilical progress, scope, port, operating port, and clavicular port, IMA and anterior activity port. This case has multiple gallstones. This is the lab position. These are directions. On of these are functions to make that so that we can put the gallbladder. Grasper, we have to hold and push it upwards towards the right shoulder so that the dissection will be easy. And the second grasper will hold the vestibular for dissection and creating a window in the posterior peritoneum. Holding the gallbladder until one touches the finger towards, it should go towards the direction towards the right shoulder. And holding the second instrument towards the infundibula, dissection of the posterior peritoneum, creating the window so that cystic duct and cystic organ carefully lift mechanisms without injuring any other structures. This also to be applied towards the gallbladder rather than going towards the right. Open so that we can For patient doing a conversion, suppose there are plenty of additions, plenty of additions. It is a wise decision to convert from the open cholecystectomy. The incisions recommended for open cholecystectomy is after incision, subclassical incision, after midline incision, a right paramedian joining the midline, where you have the ligate cystic artery dissection in the carotid triangle, ligate cystic artery, ligate this carefully, and the gallbladder is dissected away from the gallbladder bed. Polypolypiasis, stones in the ciliary, due to polypolypiasis or a new pathology, could be due to infection of the biliary or it is due to infestation in the cross carrier system, one of the synapses. Any obstruction to flow by stasis and leads to stone formation. It is more likely associated with infected bile than polypolypiasis. Primary ciliary stones are due to stasis, biliary dyskinesia, benign biliary stricture, sclerosing cholangitis, biliary dilatation, choledochal cyst, congenital Carolis disease, infections. Clinical presentation, incidental with or without jaundice, Lafrance fire, jaundice, recurrent abdominal pain, fever, biliary colic, jaundice, fever with 6 and 20, steatoria, darkening of urine. Supervisors not right here. In obstruction of the ciliary due to a stone, gallbladder distension, cellular markers, already because of inflammatory fibrosis. Investigations advised ultrasonogram when there is severely dilated ATM with gallstones. CT to locate the stones, location, structure, ductal dilatation, or intrahepatic dilatation. CT cholangiogram, MRCT. Now endoscopic ultrasound is available. ERCT or PTC. MRCT, CBD stones. The management, resuscitation of the patient, correction of the clotting abnormality, giving antibiotic, broad-spectrum antibiotic, relief of the obstruction, conservative medical resolution, endoscopic sphincterotomy, is ERCP, endoscopic sphincterotomy and retrieval of the stones. Preoperatively, we have vitamin K and IV antibiotics. Indications for choledochal require palpable Dutch stones, open cholecystectomy. Jaundice and history of jaundice, dilated ciliary with abnormal liver function. ERCP, endoscopic sphincterotomy followed everywhere now, and simple procedure. Then followed by laparoscopy. Laparoscopic ciliary exploration when stones cannot be extracted through ERCP. And open cholecystectomy. If the on-the-table cholangiogram CBD stones are present, choledochotomy has to be done. Open choledochotomy with choledochoduodenostomy or choledochoduodenoscopy. If duct is grossly dilated or a better biliary drainage. Thank you.
Thank you. Thank you, Dr. Giridhar, for an excellent talk on the gallbladder disease, gallstone disease and their management. I think we will have the interaction with the speakers after the fourth talk. Some doubts expressed in the chat box. Now, is Dr. Ramani there? Dr. Ramani?
No, sir. Ma'am has still not returned.
Then we go to Dr. Murali Krishna. Is there?
Yes, sir.
Murali Krishna, Dr. Murali Krishna, recent advances in fistula in nano treatment. Let us say in the olden days, fistula in nano is most complicated and difficult problem to manage. Dig, and then try, and every time the recurrence of the fistula comes. So this is a very a serious problem. And now Dr. Murali Krishna is there with his experience, recent advances in the fistula management. Please carry on, Dr. Murali Krishna.
Good afternoon, all of you. Just thank the moderators and thank the AMS giving the opportunity. And I just stand before you just a brief talk on recent advances in the fistula in nano. Screen passing also.
Sir, try resharing the screen once again, sir.
Reset the screen.
Yeah, reshare. You'll close the screenshot and then redo it. Yeah.
Is it okay?
Yes, sir. It's okay, sir. Go ahead, sir.
Okay. As our beloved moderator told, the fistula is an age-old problem, and from BC, that is about 800 in BC till today, there is no specific curative dogmatic treatment for the fistula in ano. It says that's how complex it is. There are so many causes for causing the fistula, right from cryptic abscess to the one which you are seeing, a terrible diseases like Crohn's, tuberculosis, actinomycosis, post-operatively, and you can see that some of the foreign body can cause. See the impalement, it will also may cause the fistula, and azole LGV is the one which is still culprit. When you want to proceed with the fistula in ano, a brief classification of the fistula in ano, that is the commonest classification which everyone follows, a Park classification, intersphincteric fistula, transsphincteric fistula, suprasphincteric fistulas, and extrasphincteric fistula. As we all know, but this is an abnormal communication between the anal canal and the exterior. The internal opening of the fistula is the one which is very culprit, and it will change the fistula to be classified like this. And the track, the procedure, the process, and the lengthening and course of the track classifies this way. Now, when we have a fistula in ano, we have to investigate further whether really a fistula in ano or not. By rectal examination, almost 86% it will confirm. And we have added investigations like scopy, like another scope. We have a fistula scope and sigmoidoscope, and we have image, fistulography can be done. An ultrasound and recent evaluation, it will have what is called as the type of the fistula by submucosal plane, intersphincteric plane, or supralevator, pelvic rectal fistulas. These are all the things that can be assessed by a latest investigation technology, what's called ultrasound and MRI. These investigations further augmented by injecting what you call as a hydrogen peroxide, whatnot. And the fistulography, injecting a dye into the external opening, taking the films, it will say a road map of the fistula and the branches. The fistuloscopy again have a direct vision. It will catch that what you call branches of the fistula, or it will delineate the internal opening. By fistula, that is called as a by fistuloscopy, one can also find and confirm the internal opening. If at all it is sealed, it is confirmed by illumination. Anal ultrasound, the submucosal layers, the extent here you can see it has gone up to the perineal body. So that can be achieved by a sophisticated investigations like MRI and other things. When it comes for the treatment, my talk, I just briefly confine to the recent advances. Before that, we just recapitulate what was the day which the fistula been treated. Commonest one is the fistulotomy. The fistulotomy is the one is the opening of the fistulous tract. Entire fistulous tract is opened up. And fistulectomy, mucosal advanced lift, certain procedures. And we have an advanced technology like filling of the tract, WAFT, FILAC, OTSC, PERFACT, trophies, TFSA, SLOV, eczema. Eczema now recently has come from Germany. We are still doing it our own setup. Now, when you take want to recapitulate what was being done and as old fistulotomy. And this fistulotomy, as you all know, is a lay opening from external opening to the internal opening, cutting open all the structures which comes across, maybe even sphincter, we don't know. Hence, there are a lot of what is called incontinence, and they are called reoccurrence. And this fistulotomy may be augmented by staging. Say one stage we just a little bit go by like that, or it can be augmented by marsupialization, or it can be combined with other procedures. And the risk of incontinence now with this 37 to 54%. Surprisingly, this still be practiced in combination with recent advanced treatment. So this is an age-old one which we do. Particularly the Spain, other countries, they still follow the fistulotomy technique. Fistulectomy. Ectomy means just entire removal of the entire fistulous tract. And first we have to pour out the fistula and lay open the fistulous wound, and there will be a lot of post-operative big wound, and depth of the wound is more, hence it tries to heal by at later date. And we have an age-old procedures like a seton. Seton is an age-old procedure. It is introduction of a foreign body into the fistulous tract for number one, draining the fistulous tract. Number two, for cutting the fistulous tract. We have a drug-eluting statins also, where it irritates the mucosa or what are the granulations of the fistulous tract or the mucosa of the anal canal for sealing by fibrosis. It invites a lot of fibrosis. Depending on that, there are cutting statins, draining statins. So many statins have been evolved. This is an old procedure, still be followed in combination. Like Penrose drains can be put as a statins drainage. And anorectal advancement flaps means the way the aim of surgery and operation or a definitive treatment for a fistula in ano. The main culprit is an internal opening, which is the fellow which makes the contents of the anal canal to slip back into tissues and can cause a sepsis. And again, a reoccurrence, the fistula seals off and come back because there is a patent internal opening of the fistulous tract. Our aim is towards the closure of the internal opening of the fistulous tract. We have so many procedures. Age-old procedure is a advancement flaps. In advancement flaps, even the mucosa can be drawn down. First we will open and excise the internal opening, and that excised internal opening is being covered by indrawing or downpull of the or advancing the mucosa of the rectum and anal canal. And the further opening, further tract, distal tract will be debrided further. The contraindications of this is when there is a rectal mucosal problem or anal mucosal problem, one should not venture to go by a mucosal surgery. That's endoanal surgeries like mucosa advanced flap. We have got myocutaneous flap, cutaneous flaps instead of a mucosal advancement in such a scenario. And we have another one, a lift procedure or ligation of the intersphincter fistulous tract. The fistula in ano connects the anal canal to exterior by passing the tract passing through a space between the intersphincter space. That can be easily be identified in intersphincter space and is ligated as near as possible for near the mucosa of the anal canal. This alone can be done for a complex fistula. Not only this lift procedure can be augmented or been combined with placement of a biological materials or what is called as a synthetic materials across the cut end of the fistula tract. Another one which is come recently, a filling of the tract. Most recently, the stem cells we just prepare from the adipose tissue, particularly gluteal adipose tissue, very suitable for this. And we take the stem cell, what called the fat scaffold, and we just fill it in the tract by injecting the same material into the fistula as depicted. Another fibrinogen, so many things can be taken. With this advanced technique is the entire tract is being sealed off and the stem cells grow and causes the reunion or what is called healing of the entire fistulous tract without leaving a smallest part as to recur. Number two, less chances of sphincter damage and no incontinence, and hence the recovery is the fast. Some studies they claim up to 92% of the studies what you call success rate and what you call recurrence is nil. In some studies they're claiming that a filling of what is called as a biological fill with stem cells. Nowadays so many medicines are been evolved. Some medicine which is come recently to give is altimab can be injected into the tract, which tremendously with wonders it seals off the tract. Another procedure we have a plug. When you pullette the infected granulation tissue of the fistulous tract, the fibrotic tube of the fistulous tract can be plugged with what is called biological materials like a lamina propria of the porcine is taken as a graft and just can be put inside by delivering from the internal opening, slowly draw towards that external opening and slowly stitch it. And the external opening is being excised to drain further if at all any remnant. The success rate is 55%. And synthetic collagens are available to fill it. Waft is a fashion technology. They say we have a minimal access surgery. Why can't we for the fistula nano? So that WAFT video assisted anal fistula treatment is evolved. There is a 5 mm scope which you see there. We just irrigate and cauterize with the second picture. The cauterize the granulation tissue of the tract and we just seal it off by closure. Filac, there's a laser closure. A radial emitting laser probe is inserted from external opening to the internal opening of the fistula after curating the infected granulation tissue of the fistula, and this is being sealed off. That's by laser technology. As the internal opening persists, it has to be combined with other procedures to seal off the internal opening. That's one commonest procedure we adopt is a mucosal advancement plan together with the lasers closure. It has 71% the closure rate. And we have another technology, all scope clip system. And then here, like an endoscope, upper G endoscope, we have an endoscope. We just go and visualize the internal opening of the fistulous tract. We just, like a varicose banding, we just clip it, the mucosa or the opening of the internal opening, and we just clip it, we just come out. It's a daycare procedure. It's a daycare procedure. A success rate falls 60 to 92% and no incontinence and recovery very, very fast. Perfect is a method, proximal superficial cauterization, emptying of the tract, curettage of the tract. These are to be put together into a fall of a treatment, a combined put together to a treatment of latest technology. This goes as perfect a procedure. So the combinated technologies are useful in all complex fistulas where we expect some mucosal damage, where we expect some sort of a incontinence, where we expect some sort of a delay in healing. Such a situations we have in all type of complex fistula, multiple tract, osteofistula, recurrent fistulas, anterior fistula in females, and the fistula tract more than 10 centimeter onwards. We just combine the recent advanced technology, and this is contraindicated in simple low fistulas. It doesn't require so much technology. And the fistula which is above or pelvic rectal fistulas, supralevator fistulas, that we should do. We have another transanal opening of intersphincter space. As it is depicted in the anal MRI, there's a tract which is there. Once we just close and once we open the external opening and the internal opening, naturally slow the drainage, and this drainage will be, which has what is of overall healing rate of 90.4% when we do this transanal opening of the space of intersphincter space. And we have still, which has come in vogue, or tunnel-like fistulectomy, that is TFSIA. Another one, submucosal ligation of the fistula, SLOFT, and excimer. Excimer is a core cut. A fistula from external opening to internal opening is drilled like an ordinary borewell drilled like machine. Entire tract will be taken out in toto by closing the internal opening. The excimer has a very good, tremendous 80% success rate. Thank you. I thank Ramani Madam and other AMS giving this opportunity. I thank all the delegates for the patient listening. Thank you.
Thank you. Thank you, Dr. Murali Krishna, for an excellent talk on the recent advances in the fistula in ANO, which is a most difficult condition. And now the MRI and the other latest investigation, the technology is helping you. They have gone into the perianal region also, and they are helping both the diagnosis and treatment of the various perianal conditions. And I hope all your latest techniques and all will reduce this burden of perianal problem to the patient. Thank you very much.
Thank you, sir. Thank you.
Now, Dr. Ramani has come and joined.
Yes, sir. Ma'am is here. She'll be joining with the presentation on solitary nodule and thyroid. Sir.
No, can I, sir? Good afternoon, sir. I have a request.
Okay. You just carry on. I'll wait.
Can I present? Because I have another session. Thank you. Thank you so much.
Oh, now Dr. Vijay Sankar is going to talk?
Yes, sir.
So the next topic, we are going into the next group of the topics, management of unconscious patient with head injury in emergency medicine department. It's a very interesting and important topic to most of our participants here. The head trauma is increasing in severity and all that. The patient who is having head injury with who is unconscious shows that he has got severe intracranial injury and then damage, and he needs very very careful management. And now Dr. Vijay Sekhar, a neurosurgeon, I think he is going to give us some concepts of the head injury management in unconscious patients. Dr. Vijay Sekhar, please carry on.
Thank you, sir. Sir, is my screen visible, sir?
Not yet.
Now, sir?
Yeah, yeah, it is seen.
Okay. So, is a full screen seen, sir?
No, it's not full screen.
Ah.
Yeah, now it is seen, full screen.
So, good afternoon, one and all. First of all, thank you, IMA, AMS, for giving the opportunity, and my heartfelt pranams to my teacher and mentor, Dr. N. Subramaniam Garu, who was my professor and mentor during my MCH neurosurgery. Good evening, sir. Greetings from Kakinada. Friends, if you open any news channel or print or electronic media, daily you will be seeing some or other sort of accidents, whether it is road traffic accidents, rail accidents, fall from heights, and it may be varied etiology. But the ultimate problem is either the head injury isolated or a long bone injury or a polytrauma. I will be confining myself to the management of unconscious patient with presenting with head injury. If we look into the history, during the excavations, age-old excavations, people found some of the skulls showing openings with regular margins. That means this specialty of neurosurgery was very old and ancient, and this old healing round margins indicated that the persons have lived substantially significant time following some procedures. And in the stories, it is very well evident that the man, whoever hunts maximum number of skulls or heads, will be made the king of that particular tribe, or will be marrying a particular girl, so like that. And based on these, there are some fictitious movies also. These are all only to show that this is an ancient topic. And coming to the latest information, as per the Ministry of Health and Family Welfare, this is the latest data, 2nd August. Every year, you can see the number of deaths here. Almost 531 deaths from accidents. People are worried during the last pandemic, COVID pandemic, that so many lakhs of people are dying daily and the total toll across the country and across the globe is so and so. But if you see the actual figures given by the ministry itself, it shows that the burden is far, far beyond the imagination, and there is a need to have a preventive measures which are more effective to prevent these number of deaths. Friends, on an average, in our country, approximately 2 million persons are injured and 1 million succumb to death. That means every 1 minute, one accident is taking place, and every 4 to 5 minutes, one death is taking place. That means if you consider my talk for 15 minutes, by the end of my talk, almost 3 to 4 people will be dying across the country. And this burden of head injury spares none, whether it is a film star, or whether it is a celebrity, politician, or a minister. And many parents are left without their children because of who have died or succumbed during these accidents. These are the this is a burden in the society. The high-speed vehicles, the not following the safety measures are the main culprits for this increasing incidence and the increased prevalence of the head injuries in our country. You can just see a very brief video. This demonstrates the use. You can just see carefully. In fact, this person is very lucky because in spite of passing of the truck tire over his head, he is saved because of the helmet. So definitely the preventive measures will be useful to some extent. And as you can see, these are all the survivors of the severe head injuries. You can see the one common factor in all these individuals are, you can see a scar mark in the neck. So this indicates that this person, the first person with a raised sub, is in a persistent vegetative state. So this is the burden only to show the, to know the importance of a head injury. So these are the statistics. Coming to the mechanism of head injury, it may be a focal or diffuse one. It may be a coup, counter coup. You all have might have read in your student period. But one thing is the diffuse injuries are more serious compared to focal injuries. And if we look anatomically, various layers of the head may get involved. If it is only the injury to the skull, or if it is there may be a resulting contusion, laceration, or avulsion of the scalp. Sometimes if the impact is more, beneath the skin layer, scalp layer, we have the bone which may get fractured with simple linear fractures. It may be a closed fracture, it may be an open fracture, depressed fracture, and so on. So relatively, these two entities are non-fatal. The scalp and bone layers, if they are involved, are less fatal. Whereas the same impact, if it is more, then the involvement of meninges with either the tear or rupture of the overlying dura, CSF leaks, and if the blood vessels over the meninges like middle meningeal artery or vein are involved, there may be an extradural hematoma. If there is a blood vessels beneath the dura are affected by sharing strain, then there may be subdural hematoma or subarachnoid, various types of hematomas. So once we go down beneath the meninges, blood vessels, then we have the brain parenchyma, which may be damaged, and we call them as contusions. So these three entities, the involvement of the meninges, the involvement of the rupture and the involvement of the blood vessels and brain parenchyma, these constitute the severity of the head injury. So this is again a brief classification. How we know it is a primary head injury or a secondary head injury. All of you know, primary is the injury happening at the time of impact. So we cannot modify that primary impact. The only thing is preventive measures by wearing a helmet or safety precautions. Secondary injury is one wherein there will be subsequent changes in either in the blood flow or increasing edema and other homeostasis mechanism, release of free radicals and all, so that the increased intracranial pressure may set in following the primary injury. So this is what is called secondary injury. So the target of our treatment should be a primary injury should be prevented and a secondary injury should not set in. So that should be our management protocol. Again, there are various classifications, but because my topic is management of unconscious patient. Unconscious means they fall under the severely head injured. So we classify the head injuries clinically as mild, moderate, and severe depending upon the Glasgow Coma Scale. You all know the GCS is a uniform scale which is trusted and developed globally, and it gives the uniformity. It takes three parameters: the eye opening, verbal response, and motor response. So if this EVM, eye opening, verbal, and motor responses, the score is less than 8, it is severe head injury. It is more than 9, it may be moderate or mild head injuries. So now coming to the management, that is the treatment part. The standard protocol for any trauma patient, more so for the head injury, is the treatment should simultaneously be followed or started along with the investigation. It is not sending the patient for some investigation and waiting for confirming the diagnosis and then starting the treatment. If that is followed, the number of patients will succumb. So resuscitation should simultaneously be started along with the evaluation of the underlying condition. So here the basic fundamental is, as all of you know, the principle of ABC. The airway, to prevent the tongue, maintaining the airway. The tongue fall may be there, the patient may be unconscious, and there may be a vomitus, and there may be a broken tooth, or in all these cases, the oropharyngeal airway should be kept and the airway should be maintained. So this is A of the ABC protocol. Next is breathing. One has to check the breathing of the injured and have to check the oxygen levels and adequate oxygen, whether it is reaching or not, and it should be, head end should be elevated. And then circulation is to prevent any kinks in the neck vessels, which will increase the cerebral edema, so that the neck should not be kinked. And also, you might be seeing in most of the movies, there will be tight bandage applying across the neck vertically. So they are not recommended. They are only cinema bandages. So any pressure over the neck will obstruct the venous return, thereby increasing the cerebral edema. So these bandages should be horizontally placed over the scalp to minimize any scalp bleedings. So circulation, then IV fluids, and the most important fundamental thing is head end elevation. So this will reduce any accumulating edema within the brain, and there will be a head end elevation will help. It is a non-pharmacological method of reducing the ICP. Next, one important thing for any clinician, it need not be a neurosurgeon always. See, a simple parameter clinically, once a patient is brought to emergency medicine or casualty, is just to check the pulse and blood pressure. The relation between pulse and blood pressure will give a clue to the severity of the underlying head injury. I will be showing in the next. All of you know, in a hypovolemic shock, suppose whether it is due to blood loss or any other prolonged diarrhea or anything, hypovolemic shock, there will be tachycardia and hypotension, low volume pulse will be there. So that is known for everyone. In head injury, it is just the reversal. There will be bradycardia, that is slowing of the pulse, and hypertension, the blood pressure is elevated. So this is what is called Cushing's reflex. And so we do not, even before sending the patient to CT scan, even before shifting the patient to somewhere else, some other diagnostic or investigation, just to check his pulse, blood pressure, and any signs of bradycardia, hypertension, one has to suspect a serious underlying intracranial lesion producing raised intracranial pressure. And then, of course, incidentally, along with the monitoring of the vitals, one has to look for the associated injuries like any fracture of the long bones, any cervical spine injury, blunt injury to abdomen and thorax. So these are the associated injuries to be checked out. Then the assessment of the level of consciousness, that is by using Glasgow Coma Scale. EVM 4, 5, 6. That is eye opening, 4 parameters are given, 4 points are given, verbal response 5 points, and motor response 6 points. So this is a universal scale to assess the consciousness of the individual. Once this is done, how to assess the or suspect a severe head injury? It is from the history. If there is a associated loss of consciousness from the time of accident, if the patient is having an associated vomiting, either once or more than more number of times, an associated bleed from the ears or nose. Similarly, following the accident, if the patient throws a fit or seizure, then death of a co-passenger, if some traveler passengers are going in a vehicle, any death of any co-passenger from the vehicle, the accompanying person should have, we have to suspect that that individual also is having a serious head injury. So these, unless we have a strong suspicion, we cannot rule out. And any evicted victim from the accident, if the patient is evicted from the vehicle, that is also a significant history. So these are all the findings from the, these are all the history which will suggest that there may be a underlying severe head injury. And on clinical examination, as I told, there should be, one should look for the any bradycardia, hypertension, in addition any pupillary asymmetry. Immediately one should be alarming, it should be assessed that pupillary dilatation should be the alarming finding. Similarly, any focal neurological deficits like a monoparesis or a hemiparesis, or there may be a facial nerve palsy because of the mastoid, fracture mastoid, one side of the face may be flabby, and even though the patient is unconscious, the cheek may be going in, going out and in with each labored breathing. So that indicates clinically that facial nerve is involved. So these are the clinical findings on which we have to suspect a severe head injury. And these are the history findings where we have to suspect, based on the history, that underlying head injury is a severe one. So this is the table which I have been mentioning. In hypovolemic shock, which everybody is familiar with, there will be tachycardia and hypotension. In case of head injury with severe raised intracranial pressure, there will be bradycardia and hypertension. And if it is a spinal cord injury associated with cervical spine, there will be hypotension and bradycardia. So for that, even without sending for any major investigation like CT scan, by simply palpating the pulse and recording the blood pressure, one can exclude or confirm the spinal cord injury versus head injury. Next, these are some of the etiological factors. The most common factor is injuries under the influence of alcohol. You can see bilateral black eye, so much of extensive injury. Still the patients are unconscious and they are deeply enjoying their alcohol. And the other common etiological factor is assaults. We see most of the times in our villages and especially these groups of individuals fighting for reasons best known for them. So they may be assault with rods, sticks, axes, whatnot, everything. And you can see here these are all the clinical pictures. All are our own clinical material, none from the internet. You can see the spicuous fractured bone fragments. You can see in this right hand image, the hair and some of the dirt, the dust particles, everything will be seen in the open injuries. Then, though rare, these gunshot injuries, this is a patient from tribal area, Orissa patient has come. You can see the intake, the injuries here, entry wounds, and you can see in the X-ray, plain X-ray, there are pellets. One in the spinal cord, this patient presented with paraplegia, and of course, again there is a injury to the chest wall. One has gone into the eyeball, so like that. So these are also not common. Increasingly, we are seeing gunshot wounds and other assaults. This is a simple example of a road traffic accident. You can see an individual, the clinical picture, the same patient. If the CT scan is taken, you can see the fracture of the frontal bone, superior orbital rim, and also the fracture of the inferior orbital rim, fracture of the maxilla leaf. So every detail can be seen, especially the bony injuries, can be very well demarcated with CT scan. This is another example of a clinical picture. You can see the scalp is reflected and it is showing a multiple comminuted depressed fractures. And the same thing, of course, this is a different patient. Even before going into the OT, we can know how the bony spicules will be and how to repair, and we can plan even our surgical procedure. So this is a 3D CT scan. In the earlier days, there was only axial sections were available. Then reconstructed images. Now the latest gadget is the 3D technology. So even by rotating the image, we can see from the aerial view, the basal view, lateral view, everything we can know, and we can plan our surgery better. And other etiological factors, all of you know some famous cricketers, Raman Lamba from India, and this is another cricketer. There may be sport injuries also, which are very lethal and may be detrimental. Similarly, it is not uncommon to get accidental and very interesting penetrating injuries to our government general hospitals. We have treated such cases in both the King George Hospital, long back, an arrow penetrating into the individual who has survived and without going discharged without any further deficits. And recently, in East Godavari also, we have one child while playing at a construction site had accidental fall and there is a penetrating injury. Luckily, it has gone beyond the orbit, so the child has preserved vision, but it could be removed very successfully without any deficits and the child was discharged. So these are only some of the clinical pictures for you to understand the various etiological factors of the head injuries and how we classify them into severe head injuries. So now our target is once the patient comes with severe head injury, that is with Glasgow Coma Scale less than 8 to casualty, then how to do? Resuscitation, simultaneous resuscitation, and then sending the patient to CT scan. As I have mentioned, it is the CT scan is very gold standard. We have what are all the various lesions which can present with unconscious patient. There may be an extradural hematoma. It may be a subdural hematoma, massive acute subdural hematoma, intracerebral hematoma. Mostly you can see these are all hematomas or hemorrhages, intraventricular hemorrhage, subarachnoid hemorrhage, traumatic subarachnoid hemorrhage is the most common form of SAH. Sometimes there will be very bad or significant injury to the cerebral parenchyma, especially when a person gets a sharing strain, suddenly going in a vehicle, gets evicted or gets hit to the speedily moving vehicle. Then the brain will go and get rubbed or friction against the irregular surface of the frontal bone or orbital roof. In such cases, there will be more cerebral contusions. Similarly, whenever the sharing strain is diffuse, it is an entity called diffuse axonal injuries. So it is called diffuse axonal injury. So these are all the various pathological entities which will lead the patient to a severe head injury. So now, having suspected these, how to diagnose? It is the CT scan which is the diagnosis of investigation of choice. It is universally available. Even a small town is having at least 1 or 2 CT scans. It is very less time consuming. Parenchymal injuries as well as bony fractures are well demarcated, and only risk is risk of some radiation. MRI is never the investigation of choice because most of the RMPs are in the periphery. People think that MRI is an expensive investigation. It will give more information. No, it is false. It is a paradox. It is more time consuming. Suppose you imagine a patient being sent into MRI gantry. It takes minimum 15-20 minutes to half an hour, depending upon the generation of MRI. Half an hour. If we leave the patient without any monitoring, there are occasions there where the patients deteriorated within the gantry. So MRI is only specially indicated cases to be done by neurosurgeons when we suspect brainstem injuries like that. Otherwise, CT scan is the investigation of choice. Then these are the various protocols. These are textbook protocols. But anyhow, if the patient is, I have already mentioned, history-wise, if there is a history of persistent vomiting, history of seizures, history of focal neurological deficit, or 1 or 2 persons sustaining a severe injury or death in the same vehicle, that is the history-wise indication for CT scan. Not every patient should be sent for CT scan. If the patient is stable, vitals you have to observe. Moreover, any hyperacute CT means patient comes immediately road mein padipai, within 2-3 minutes or within 10 minutes, patient will be brought to the opposite nearby located hospital. If we take a CT scan, it will not give the actual information. It is called hyperacute stage. But after a few hours, after 6 hours, so there may be a new lesion may be appear, and we may be under false impression that CT scan is normal and patient deteriorates. So it is always the timing and the indications are very specific. And whenever in doubt, you have to refer to a neurosurgeon. These are some of the cases I will just show briefly because I know time is up. This is the classical biconvex or idli shaped or lens shaped. You can see in the CT scan hyperdense lesion suggestive of extradural. Biconvex is extradural hematoma, classical teaching. The moment you can see in the operative picture, the moment the bone is removed, you can see a thick black currant jelly clot. Similarly, you can see here is a thick acute subdural hematoma. You can see here there is a jora is reflected, and once the jora is reflected, you can see the black thick blood clot. You can see once this is the CT scan. On the right top, you have the bone flap removed. You can see the jora with underlying clot. It is black and bluish discoloration. Once the jora is open, you can see the clot. And once the clot is dissected, we use a mucus sucker with saline. Simply irrigate and remove the clot with suction and also normal saline irrigation. This is a brain. You can see, of course, the brain is little bulging here. In extradural, brain will be normal because the clot is outside the jura. But in subdural, the brain parenchyma also is involved. You can see the red, angry looking brain. So these subdural hematoma patients are more prone for seizures or convulsions. So these patients, we have to start anticonvulsant immediately. This is one case of chronic subdural hematoma. You can see the CT scan here. On the left side of the picture, you can see the sulci gyri. There is spaces. But on the right side, you can see a sickle shaped or convex on one side, concave on one side, and it is hypodense on superiorly, hyperdense to the bottom. So it is nothing but chronic subdural hematoma. Sometimes a membrane is formed. You can see in the right side, the perioperative picture, the jura is reflected. You can see a thin membrane which is almost like a magnetic membrane. Once it is, unless this inner membrane is removed, there, if you put a simple borehole and drainage, there is more chance of recurrence for these chronic subdural hematomas. So the acute subdural hematoma is craniotomy. Chronic subdural hematoma, even with simple borehole, we can evacuate, or when a membrane is suspected, we have to remove the membrane. So it is only if a chronic subdural put a single borehole, there may be a conventional Hudson brace craniotomy or a mechanized, you can see the drill here. And again, a small video which may be interesting for you. So borehole is made, the jura is exposed, and with a Levin blade, a crisscross incision is given, cruciate or plus-shaped incision. You can see the blood coming in under pulsation. You can imagine under what pressure the blood is there, and the same pressure is being exerted into the normal brain. So you can see in this particular case, almost more than 150 ml or 200 ml of the blood has been removed. So the free edges of the jura also will be coagulated. So that is the amount of the clot. And once the liquid blood is removed, we irrigate the subdural space. See the entire bowl full of subdural hematoma. So this is one example of how we remove the chronic subdural hematoma with a borehole. Similarly, following a trauma, there may be severe intracerebral hematoma, big clot. So in such cases also, if the patient is very critical, even we can put a single borehole and aspirate with a brain cannula. You can see the liquid blood in the syringe here. Or if we suspect a significant edema within the clot, you can see we did a craniotomy, but to minimize the parenchymal injury, we are taking the aspirating the blood, liquid blood with the syringe. So these are some of the examples of evacuating the intracranial hematomas. So apart from these examples where you have seen the importance of CT scan, there is another principle by which we can detect an underlying hemorrhage or the blood clot. So this is what is called near infrared scanner, NIRS. This utilizes the principle of a light, which is in some particular specific frequency of 700 to 800 nanometers. And the principle is similar to ultrasound. It is a handheld device. It is a portable one. It does not have any risk of radiation like CT scan. So especially in mass casualties, when patients come, 4 or 5 people following a lorry accident or a bus accident, this can be held at the scalp, and the rays will be, infrared rays will be sent inside. They will be reflected back just like ultrasound waves, and the return will be fed to and gives an image. If there is any blood within the intracranial compartment, the hemoglobin will be absorbing some of the light, and only the reflected rays will give us the information that there is a clot. So this is another advance which is recently coming into the Indian market. Already some publications have been done, and this is the instrument you can see. Portable instrument, no radiation risk of CT scan. It is much, much better and can be kept in casualty of any institute. So this is an advantage, and if it comes into the market freely available, will serve a very good purpose. So I think this is how we have to assess the patient once the patient comes to casualty, and then suspect, start the resuscitation simultaneously, exclude the other injuries, stabilize him, then send us to CT scan, and then depending upon the lesion, we can manage. I think this finishes my talk, and this is a skull tower. You all of you can refer Skull Tower of Serbia. Man has been going into modern era. Mankind has been seeing so many generations, but still the human mentality has not changed. All the skulls have been taken and they have constructed just like an ornament. So they have made a skull tower. So thank you. Thank you for the opportunity. Hello.
Thank you, Dr. Vijay Sekhar, for an excellent outline of the management of the head injuries, especially the severe head injuries.
Thank you, sir.
So, as I see, there are not many questions or doubts in the chat box. So with this, we will conclude this part of the sessions. And before I hand over to another moderator, I just once again request all the participants in this group to join in the AMS IMA AP State Academy of Medical Specialties. Those who are having the postgraduate degree or postgraduate diploma or FCGP, they are eligible to become the members of AMS, and you will have a number of CME programs. And if you are qualified, you will also get a FIA-MS fellowship also. So there are so many benefits, and more than that, the academic wing of the IMA has to be strengthened. So I request all of you to enroll yourself into the AMS of IMA AP State with a very minimal amount and a simple procedure. Contact our AMS secretary, Dr. Our chairman, and then the IMA State Office. Thank you very much. With this, I hand over to the next moderator for continuation of this session. Dr. Ramesh. Dr. Ramesh.
Sir, yeah, thank you. Thank you for being with us, sir.
Oh, okay.
Yeah.
Welcome. Please take over and hand over to someone.
Yeah.
Thank you.
Dr. Ramani is also here. She'll take over.
Yes.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, President and Secretary of AMS, Dr. Ramesh and Ramani. Thank you.
Thank you.
Thank you, Shekhar, Vijay Shekhar. Thank you.
Good afternoon, everyone. Am I audible?
Yes, ma'am, you're audible, ma'am. Please go ahead.
Thank you so much. Good afternoon, respected delegates and the leaders of IMA. I'm immensely thankful to allow me to present this topic of solitary nodule thyroid cooperate or not. I just want to present this in the perspective of a general physician, a general practitioner. When a patient comes with a nodule in the neck, whether to refer him or to just say not necessary, you can be just like that. Sometimes some people do say that. I just want to throw a light upon what is exactly a nodule of thyroid and how to proceed. Only that much, not in the general surgical perspective, surgeon's perspective. So now the thyroid gland is situated in the neck. It is in the lower part of front of neck, situated in very close proximity to the laryngotracheal complex, and also deriving blood supply from the external carotid artery and draining the the venous drainage going in directly into the internal jugular vein. So it secretes thyroxine hormone, which is like an engine oil. It may not be absolutely necessary for survival of a person, but it is surely necessary for proper working of all the systems and maintenance of the internal milieu. This is possible only with the thyroxine hormone, which acts by stimulating the sympathetic nervous system in the body. So you should also know what is the normal level of thyroid in the body. So the TSH is the simple test. When abnormal, we have to estimate the T4 and T3. If the patient cannot afford to get the entire thyroid profile done, simple TSH can be done. If this is abnormal, low or high, then we can go for a total T4 or T3. So now this thyroid gland is about 20 to 25 grams. The functional unit is a lobule, and each lobule has 24 to 40 follicles. These are lined by cuboidal epithelium. It is filled with a colloid, and apart from the follicular cells, 2% parafollicular C cells are there, which secrete the thyrocalcitonin. So now we are now today talking about the thyroid nodule. What is this thyroid nodule? This thyroid nodule can occur with or without the enlargement of a thyroid gland. If the thyroid gland enlarges, we call it as goiter. If this goiter has a small discrete lesion which is palpable, which is different from the parenchyma, and it is radiologically distinct from the rest of the parenchyma, we call it as a thyroid nodule. This is according to the American Thyroid Association. But our dear Bailey Love has said palpable nodule in otherwise normal gland. This is called a solitary nodule. And if the gland is abnormal and diffusely enlarged and you palpate a nodule, this is a dominant nodule. So palpable nodule in an abnormal gland is called a dominant nodule. So what is the prevalence of this thyroid nodule? How often do we encounter them in the general population? So this, the incidence of the nodule increases along with the age. So this can be around 4 to 11% in a normal population. But then if you want to see radiologically by imagiology, like an ultrasound and MRI scan, this increases to as much as 30 to 60%. And also the nodules are more common in women, 3 times more common in males. Now, okay, now we understood what is normal thyroid, what is a goiter, and what is a dominant nodule, and what is a solitary nodule. And then why should we know about this solitary nodule at all? Because 15% of these small nodules, which may be or may not be palpable also, and which are picked up only by imagiology, can be malignant. But then 30 to 40% of them are only adenomas. But then we cannot say whether these adenomas are benign or they may lead precursors for follicular carcinomas. The remainder 50% are other causes like non-neoplastic enlargements, which can be colloids, goiters, degenerative cysts, thyroiditis like Hashimoto's disease and all. So the incidence of malignancy increases when the nodule is solitary and decreases to half when it is a dominant nodule. That means there is a diffuse enlargement of the entire gland. So now we have a patient with a nodule that is palpable or a nodule picked up by an imagiology, which is done incidentally. It is noticed when he has undergone some other investigation. So how do we go about evaluating this person? So then we have to evaluate thorough clinical examination, biochemical examination, radiological and pathological evaluation. So what is simply a clinical examination means? We'll examine the entire neck, whether this nodule is moving up with deglutition or any other lymph nodes are palpable in the rest of the neck. Because if the lymph nodes are palpable and there is a nodule, this is 100%, it can be a malignant mass. So then biochemically, we have to assess whether there is the TSH. How is the TSH? Then ultrasound scan and the FNAC. So now when we are palpating, we should see whether this is a solitary or a discrete or a dominant by examination. Here you can see the upper part. This is the nodule, while the lower is the trachea that is visible. This is a very thin and long necked individual that we are seeing. Here you can see a solitary nodule. The opposite side is entirely normal, while you can see an enlargement on the left side. So this can be this woman, if you carefully see, there is an enlargement in the left side, middle, and also some area on the right side that is visible. So this is a dominant nodule. So now, as I said, after clinical examination, this is the TSH. So if the TSH is very low, that means this is a case of hypothyroidism, and the radioiodine thyroid scan has to be done to see if this nodule is a toxic nodule. Then if the TSH is higher than normal, then that means this is a hypothyroidism. In such case, the only medical treatment, medical management of either hyper or hypothyroidism, but not surgical. Now coming to the imagiology, the ultrasound scan has become very important in assessing the nature of the thyroid gland or the nodule. So much so that it is now competing with the pathological confirmation. So this we call as a thyroid image reporting and data system, TIRADS, just like a BIRADS for a breast. So we can know completely the nature of the thyroid gland and the nodule that you're seeing. So here, what are we going to see in the ultrasound scan? The composition, the echogenicity, the shape of the nodule, the margins of the nodule, and whether it is having any echogenic foci. So these are graded as 0, 1, 2, basing on the composition. If it is purely cystic, 0, purely solid, 2, intervening in the middle, it becomes as 1. Anechoic, 0, very hypoechoic is 3, because thyroid carcinomas are cystic. You should not think that soft nodule, no need of any treatment. This is a thyroid paradox where soft nodules can be malignant, hard nodules can be benign, which can be a multinodular calcification. So this we have to keep in mind. So hyperechoic has low score, while very hypoechoic is having a high score of 3. Taller than wide nature also is a feature of malignancy. Smooth margins are again a benign feature. Irregular lobulated margin, extrathyroidal extensions, all these are malignant features. Echogenic foci, like we call samoma bodies. There are fine echogenic foci within the nodule. Again, this is a malignant feature. So basing on this composition, echogenicity, shape, margin, and the presence of calcific spots within the nodule, the thyroids are scored as thyroid 1, 2, 3, 4, and 5. So thyroid 1 benign, 2 suspicious, well 5 is a frankly malignant thyroid. I'm just giving a little few pictures I'm showing here. This is spongy form where, and this is a solid cystic. Together they're solid and cystic, and this is a hyperechoic. This is a very hypoechoic picture, which shows that this is a malignant mass. This picture shows a smooth margin of the nodule, and is almost isoechoic or little hypoechoic than the surrounding parenchyma. So this comes to a benign. Lobulated margins. Then this picture you can see where there is extension into the muscles and taller than wide. See, more taller than wide. This indicates that this is a malignant potential. So now, when we have done till now we have done a clinical examination, then we have done a thyroid estimation, then now we have done an ultrasound scan imaging. Now we want to know the histological nature of this nodule. So we'll order for an FNAC. More if the scores are high. Thyroids 3, 4, 5, we'll order for FNAC. If it is a purely cystic one, we can wait and watch. We need not even give an FNAC. We can ask to come after 3 to 6 months, right? So now when these FNACs, like Bethesda system for reporting thyroid cytopathology, which are again classified as 1, 2, 3, and 4, and 5, 6, while the ATP of unknown significance, follicular lesion of unknown significance, or follicular adenoma, when there is suspicion for malignancy and frankly malignant, we have to go for surgery. We have to refer them for surgery, but not just maintaining them with any of us. So this is again a slide showing the various types of cells that we have discussed in the cytopathology. So now we have done an examination, we have found a nodule, and the TSH is high, that means hypothyroidism. Low, that means hyperthyroidism. Then we have ordered an FNAC, and it came as malignancy, straight away surgery. Suspicious, again surgery. Benign can be follow up like Hashimoto's thyroiditis or other cyst. But if it is again ATP of unknown significance and suspicious, we will go for surgery. So if it is non-diagnostic, no impression can be given, we repeat FNAC. So To conclude, the recommendation, the guidelines of American Thyroid Association and other European guidelines are all thyroid nodules which are more than 1 centimeter. They need evaluation, even if palpable or not palpable. If it is less than 1 centimeter, we can wait and watch. And if FNS is normal, we can wait and watch. Personal history of head and neck irradiation, particularly in less than 28-year-old, more than 70 years, and in male sex, if there is a thyroid nodule, there is a high chance of malignancy. Then the serum TSH, ultrasound scan, FNSE need to be done. Most benign nodules do not need any specific intervention. Surgery is indicated if there is compression or uncontrolled toxicity or the permanent feature of a multinodular goiter, and if there is any suspicion of malignancy. So when a patient comes to us with a thyroid nodule, we have to do a clinical examination, ultrasound examination, FNAC, and then think what surgery, what fits the particular patient, and individualize the treatment basing on the age, sex, and other parameters. Thank you so much, dear IMA. Long live IMA for giving me this opportunity to be in front of all the 700 delegates that are watching me. Thank you. Thank you so much. My students.
Thank you, ma'am. We have for the next topic, guidelines for management of overactive bladder by Dr. Bhargav Vardhan Reddy, who is consultant urologist. So are you ready?
Yes, madam. My screen is visible.
Yes, sir, it is visible. You can make it a slideshow once.
Okay, sir.
Yes, sir, go ahead, sir.
Yeah. Thank you, my dear professors and delegates. This is Dr. Bhargav Vardhan Reddy, urologist from Nandyal. Thank you for giving me this opportunity to share my experience about the overactive bladder. It's a little dry subject. Bear with me for 15 minutes. The overactive bladder is defined by International Continence Society as a symptom complex. It includes urinary urgency with or without urgent continence, that is leakage of urine, and associated with the frequency and nocturia. The incidence increases with age. Even in less than 18 years of age, it is seen in 5% of the patients. And after the 18 years, it is seen in 25 to 30% of the patients with increasing of the age. And it also varies between the region. In Asian countries, the incidence is more around 30%, and in the Western countries, the incidence is less, that is between 20 and 25%. The overactive bladder, it affects the quality of life very much in many ways. Like physical, there is limitation of physical activities, there is loss of self-esteem and depression, and sometimes reduction in social interactions, requirements of specialized underwears and bedding. Occupationally, it affects the work and decreases the productivity and the avoidance of sexual activity. It is categorized into the two categories, that is neurogenic overactive bladder and the non-neurogenic overactive bladder. Non-neurogenic overactive bladder again categorized into two categories, with identifiable cause and with non-identifiable cause, that is idiopathic overactivity. So neurogenic detrusor overactivity is commonly seen in spinal cord injury patients, either iatrogenic or because of trauma, cerebrovascular accident patients, in case of multiple sclerosis patients, dementia patients, and Parkinson's and other neurological diseases. When it comes to non-neurogenic overactive detrusor overactivity, commonly this is identifiable cause. Subtype of non-neurogenic detrusor overactivity in category of identifiable causes: urinary tract infection, acute or chronic; GUTB in case of a patient complaining of this chronic dysuria, that is more than 6 months of chronic dysuria with sterile pyuria. You have to suspect genitourinary tuberculosis, and you have to subject the patient to urine for AAB, urine for PCR tuberculosis, sometimes cystoscopy with biopsy, and you have to treat accordingly. And carcinoma in situ, a patient complaining of chronic dysuria with hematuria, that to smoker, you have to suspect the carcinoma in situ, and you have to get a urine cytology, sometimes scopy and biopsy, and you have to treat accordingly. And the BO means bladder outlet obstruction. In male patients, commonly it is due to benign prostatic hyperplasia and urethral stricture disease. And sometimes vesical calculus will also cause the bladder outlet obstruction, and in terms again overactive bladder. In female patients also, urinary stricture is a common possibility, and you have to rule out this bladder outlet obstruction whenever you are treating the overactive bladder. And interstitial cystitis patients, chronic pelvic pain syndrome patients, and the radiation cystitis. If we exclude all these conditions, then there comes idiopathic overactive bladder. So in overactive bladder, most common possibility in 75% of patients is the idiopathic overactive bladder. You have to know basic information about the neurological innervation of the bladder. As for any organ, it has got a sympathetic, parasympathetic, and somatic nerve supply. But during bladder, sympathetic supply comes from the T10 to L2, and the parasympathetic comes from the S2 to S4 segment. And this is the pudendal nerve which supplies to urethral sphincter. So whenever there is a two phases, there is a bladder filling and the bladder contraction. During bladder filling, sympathetic hypogastric nerves are very active for the relaxation of the bladder, and the somatic pudendal nerve is also active for the contraction of the urethral sphincter. And whenever the bladder contracts during passage of the urine, parasympathetic nerves are active, and in terms of parasympathetic nerve sends to the inhibitory signals to the somatic pudendal nerve, that to urethral sphincter, to passage of the urine. So bladder has got many receptors. The most common are the muscarinic receptors. There are 5 types of muscarinic receptors, and is the beta agonistic beta 3 receptors that is stimulated by norepinephrine. The release of acetylcholine from the cholinergic nerves causes the stimulation of muscarinic receptors and the detrusor muscle smooth muscle contraction. So this is the urothelium. Urothelium not only acts as a barrier for the chemicals, and it also acts as a sensory organ. Whenever the bladder fills, the stretches of the urothelium sends the neurotransmitter signals to the interstitial cells. The interaction with the interstitial cells, they relaxes this bladder smooth muscle, that is detrusor muscle, to allow the smooth filling of the bladder. For the basic evaluation, whenever you are dealing with overactive bladder, to rule out any identifiable cause. It's simple urine examination and the urine culture and sensitivity to rule out infection, blood sugar test and renal function test, urine cytology to rule out carcinoma in situ, and AFB, that is acid fast bacillus test, to rule out genitourinary tuberculosis. Ultrasound KUB with post-war residue, especially neurogenic patients will have high residual value that pressure transmits to the kidneys and leading to the hydronephrosis, ureteric dilatation, hydronephrosis, ultimately renal failure. So we have to have ultrasound abdomen with the post-war residual, and uroflowmetry to check the flow to rule out any bladder obstruction, cystoscopy to rule out stricture, prostate, carcinoma in situ, any genitourinary tuberculosis, like that. And urodynamic study to demonstrate the detrusor muscle contractions, involuntary detrusor muscle contractions. So after evaluation of the patient, comes the management. The OAB treatment goals and expectations. This is the only one goal. Ultimate goal is the symptom resolution. The realistic goal is symptom improvement and not the cure. We have to reassure the patients for the symptom improvement only, but not the cure. So International Continence Society has guidelines for the management of the overactive bladder, the initial first line management and the second line therapy. Non-surgical treatment is the mainstay. It should include lifestyle changes on the dietary modification, bladder retraining programs, that pelvic floor training exercises with or without biofeedback. Next comes the pharmacological treatment. So first line treatment of OAB is most commonly behavioral modifications. That is less fluid intake, and ask the patient to not to take more than 100 to 150 ml fluid per hour, and decrease or avoid the caffeinated beverage per day. So in addition, ask the patient to stop drinking fluid at least 2 to 3 hours prior to bedtime, with the exception of sip of fluid with medications as needed. With these minimal behavioral changes, many patients will demonstrate significant symptomatic improvement in daily incontinence symptoms. So this is pelvic floor muscle exercise, originally described by Kegel in 1948 for stress incontinence. So these exercises are also useful for to prevent urge incontinence episodes. These are the pictorial demonstration of pelvic floor muscle exercise in female. The next slide is the pelvic floor muscle exercise in male patients. This is a biofeedback exercise. Biofeedback ensures that the pelvic floor muscle exercise, whether we are contracting the right muscle or not, by keeping electrodes in the vagina or anal canal. The technician will see whether you are contracting the actual muscle, that is levator muscle or not. This is why this exercise will go. So for patients who do not respond to behavioral modifications, that is first line treatment, then comes the pharmacological treatment. So before knowing the pharmacological treatment, you have to know about the muscarinic receptors. These are the 5 types of muscarinic receptors in the bladder. Most commonly seen muscarinic receptors are M2, M3. Acetylcholine activates these muscarinic receptors and reduces myocytes and is the main contractile transmitter in the bladder. So there are various anti-muscarinics are available in the market. The most commonly used are the oxybutynin, tolterodone, and solifenacin. And darifenacin is selective for M3 receptors. And the fesoterodine is a newer anti-selective agent that acts as a competitive muscarinic receptor agent. So we commonly use this tolterodine and solifenacin and darifenacin. The others, there are many side effects for this anti-muscarinic drugs: dry mouth, constipation, blurring of vision, arrhythmias, dry skin, giddiness, and transient bradycardia sometimes. The other subtypes of this one bladder inhibitors are beta-3 agonists. Stimulation of beta-3 receptors in the bladder inhibits bladder contractions. The only molecule available in the market is the mirabegron, that is 25 or 50 mg. You can combine this mirabegron with the tolterodine or mirabegron with the solifenacin to have maximum effect. So not all patients respond to pharmacological therapy and may still experience the significant OAB symptoms. These are called as refractory OAB. So what are the treatment options for this refractory OAB? First line is the exercise and behavioral modification. Second line is the pharmacological treatment. The third line will be the refractory OAB. Or next we will see what are the treatment options for refractory OAB. Most common treatment is the for refractory OAB is the botulinum toxin. This is toxin extracted from the Clostridium botulinum. First described in 1985. There are many serotypes are available, but we commonly use the serotypes A and B. The intradetusar injection of botulinum toxin may have beneficial effects in patients with refractory detusar overactivity. This is a minimally invasive technique because we will inject the botulinum toxin through the cystoscopy into the bladder. This is usually approved for cosmetic uses. In 2002 and 2004, they have got FDA approved for cosmetic uses. After 2010, it's FDA approved for treatment of the OAB. So this is what is the mechanism of botulinum toxin. Botulinum toxin acts by inhibiting calcium-mediated release of acetylcholine vesicles at the presynaptic neuromuscular junction in peripheral nerve endings, resulting in temporary flaccid muscle paralysis. So this is the cystoscopic. This is a specialized needle to inject the botulinum toxin into the systematic way all over the bladder, except into the trigone. So we have to inject 0.5 ml of botulinum toxin into the bladder. Total dose will be the 200 to 300 microns. So botulinum toxin is not believed to enter the central nervous system, but there is no definitive evidence. So muscle function was noted to eventually return in treated patients in 6 to 12 months of the bladder. So we have to counsel the patient before subject the patient to the botulinum toxin for few complications. So for the repeat injections and need for the CAC. If the detusar muscle completely paralyzes, so then the patient has to do clean intermittent catheterization for time being. And there is a common complication of cystoscopy, the urinary tract infection. So then what comes after botulinum toxin? There is a cutaneous stimulation of the posterior tibial nerve for controlling the bladder dysfunction. This is FDA approved in 2006. The next comes the sacral neuromodulation. SNM is a therapeutic technique that involves electrical stimulation to a sacral nerve root to modulate the neuronal pathway. So it is a minimally invasive procedure for with a good long-term outcomes for the bladder and bowel dysfunction also. So thin leads are inserted near the sacral nerves at lower back. They will control, which will control the bladder and bowel. So then the wire is connected to the small external pacemaker-like device, which delivers stimulation to the nerves. So then comes the last option, bladder surgery. The main principle of reconstructive bladder surgery for refractory OAB involves the enhancement of the functional bladder capacity and the reduction in the spontaneous increments in intravesical pressure. So our aim is to decrease the transmission of pressure to the kidneys, so that we have to prevent the renal damage. So there are two procedures: augmentation, enterocystoplasty, and the retrosor myomectomy are the two bladder reconstructive procedures available till now. So this is the bladder augmentation. So we have to bivalve the bladder, and this is a bowel segment. Commonly, we will take the ileum around the 10 centimeters ileum. We have to separate from the common ileum, and with the mesentery attached, and we have to create like a pouch, and we have to stitch with the bladder. So this is the anastomosis to the bladder. Final picture we all see. In augmentation cystoplasty, the bladder capacity is increased by bivalving the bladder and replacing it with a segment of the bowel. So incorporation of the bowel segment has a potential in diminishing retrosor contractility, so that we will prevent upper tract damage. So to conclude, OAB is a very it interacts with the quality of the life. So there are so many treatments for this: behavioral therapy, pelvic floor exercises. It is diagnosed easily and managed effectively with both pharmacological and pharmacological treatment. The first line treatment will be lifestyle interventions like bladder training and pelvic floor muscle exercise and restriction of the fluid intake. Antimuscarinic, the drug of choice for the OAB, or tolterodine, solifenacin, darifenacin, and recently miravigoram. And refractory OAB cases, botulinum toxin and sacral nerve modulation and percutaneous tibial nerve stimulation and the augmentation cystoplasty. Thank you. Thank you for IMA for giving me this opportunity to share my experience about overactive.
That was a very wonderful and detailed presentation of overactive bladder, sir. Very nicely you have presented. Thank you very much.
Thank you, madam.
Now Sushma ma'am is joining us as a moderator. Ma'am, are you there? Hello?
Hello.
She's an MS in plastic surgery. Ma'am is joining us for the next speakers. And the first speaker after joining will be Dr. K. Sagar Babu. He's MS MCH CTBS Associate Professor of CTBS AMC AGH Vizag. He'll be speaking on CABG best practices. Sir, Dr. Sagar Babu, sir, are you there?
Yeah, am I audible?
So kindly turn on your video as well, please.
Is it blurred or is it okay? My video is blurred a bit.
So you're not audible. Please check the mic once again.
Yeah, am I audible?
No, sir.
Unmute yourself.
Yeah.
Sagar Babu.
Yes, unmuted. Hello.
Can,
Am I audible?
yes, sir. We can hear you.
Okay, sir.
You have to join with audio, I think. Join with audio.
Yeah. Am I audible?
Sagar Babu.
Yes, sir.
He's not able to hear.
Hello.
Madam, we are able to hear, ma'am.
Cut him.
Hello.
We can hear, sir, but the video is not clear, sir.
Yeah, that's what. Yes, sir. Yes, sir. I'm audible.
Yes,
video
sir.
A bit
Screen share. I can do the screen share, sir, once. Yeah.
Need audio to join now, but
Okay. Okay.
Mr. Shyam, please.
Yes, ma'am.
Shyam, are you there?
I'm here, ma'am. Please tell me.
Tech support team.
Yes, ma'am. We are able to hear Sagar Babu sir's voice.
But
Next. We'll ask.
Or
Sir, try sharing your screen, sir, once.
we'll ask the next.
Yeah.
Sagar, sir, please try sharing your screen.
Yes.
Yes.
Is it okay?
Yeah, make it show, sir, please.
Magnify.
Yes, sir.
But my video start problem is there.
It's fine, sir. Let's go ahead, sir. Yeah. Keep it that way.
Okay, sir.
Good.
Good afternoon, everyone. I am Dr. K. Sagar Babu. I am working as an associate professor in the Department of CT Surgery in King George Hospital, Andhra Medical College. I thank the organizing team for giving me this opportunity to speak on coronary artery bypass grafting and its best practices. So coronary artery bypass surgery has been the most intensely studied operation in the history of surgery. The reasons are it being the ubiquitous presence of the disease in our society and the visibility and the mortality of the coronary artery disease and its complications, and finally the economic implications that it causes. So mainly the CABG should improve the quality and duration of life. The decision to revascularization is based partly on the coronary anatomy, the left ventricular function, and the medical comorbidities and the patient preference. So it is very important to assess the patient prognosis before attempting going for surgery. The four main determinants of the risk in coronary artery disease are the extent of ischemia, the number of vessels of disease, the left ventricular function, and the electrical substrate that is present after myocardial infarction. So coming to briefly the subgroups where the patient presents to us are mainly based on the American Heart Association classification: the asymptomatic or mild angina patients, stable angina patients, patients with unstable angina or non-Q wave myocardial infarction, ST segment elevation or Q wave myocardial infarction, poor LV function, the life-threatening ventricular arrhythmias, patients who come after failed stenting, that is a percutaneous coronary intervention, and patients with previous coronary artery bypass grafting. So the main indications broadly, these can be classified into significant left main coronary stenosis, that is more than 50%, and significant or greater than 70% stenosis of the proximal LAD or the proximal left circumflex artery, and triple vessel disease. These three form patients should be subjected to coronary artery bypass grafting, as they are proven to have a better outcome compared to stenting. So the timing of CABG for acute myocardial infarction usually broadly can be classified as with patients with more than 65 years, you have to wait for 30 days to improve for the myocardial edema to subside, and if it is patient is less than 65 years, about 1 week we have to wait. So there are very many studies for suggesting which is better, like medical or surgical. Coming to the analysis of 7 major trials where the outcomes have come for 5 and 10 years, which showed patients with left main disease with a median survival of 13 years if they're subjected to CABG, whereas if they're subjected to PCI or stenting, the median survival is only 6.6 years. So this is a significant result that has come, and result has shown that compared to stenting, CABG is better for long-term survival patients with left main disease, and patients with triple vessel disease more benefit from the CABG for severe angina, left ventricular dysfunction, and patients with LAD, left anterior descending artery stenosis. So the overall quality of life, the physical activity, the employment and cost were similar in the early phases of 3 to 5 years for both stenting and for the CABG. But in the long-term results, the CABG have a better outcome. So these are the various studies, the Veterans Association study, European study, the CAS study, and other various studies have shown that the CABG have a better, longer survival rate and with lower comorbidities compared to the stenting patients in long term. So for the better outcomes, the patient should have a proper preoperative evaluation prior to subjecting the patient for a coronary artery bypass grafting. That is, preoperative risk assessment has a critical importance in minimizing the perioperative and long-term morbidity and mortality. So the preoperative evaluation is of various phases are there, where the components include the history, the physical examination, the lab investigations, identification of the risk factors like renal dysfunction, etc. And there are risk scoring systems, various risk scoring systems of various countries and various regions, whereby we can assess the morbidity and mortality of the patient. Coming to the physical examination and laboratory investigations, we have to detect whether there is a presence of vascular disease, which the risk increases for the patients, and patients with aortic insufficiency, where we need this is important while doing on-pump CABGs, where we have to give cardioplegia. Whereas the other disorders, where like neurological disorders, because of the carotid stenosis, since it's a vascular disease, so the carotid Doppler has to be done, and other routine investigations. Coming to the risk factors for morbidity and mortality, the age and gender is very, very important, because there are studies that have shown that women with triple vessel disease have a greater morbidity compared to the males. Whereas with renal disease also, the patient, we have to assess the patient, and during the intraoperative procedure also, we have to maintain the adequate blood pressures while doing the procedure to prevent the renal shutdown. In diabetes mellitus patients, these patients have a triple vessel disease and they have better outcome if they're subjected to CABG rather than stenting or PCI. Patients with ventricular dysfunction, patients with perioperative arrhythmia, they have a poorer outcome in both the situations. But compared to the PCI, CABG patients, subjected patients to CABG have a better outcome. Nutrition and BMI also play a role in outcome of the patient. Compared to the pulmonary disease, since it's a COPD patients have a poorer outcome, and prolonged ventilatory support is required for these patients intraoperatively and postoperatively. Peripheral vascular disease and carotid artery surgery disease is also important, where we do a concomitant procedure of like carotid endarterectomy and CABG simultaneously for a better outcome to prevent the neurological complications like CVA, postoperative CVA. There are various risk stratification systems based on area, type of operation we do, either off pump or on pump, based on the age, gender, patients with coming for the resurgery, reoperation, and emergency procedures, and depending on the cardiac function, and patients with recent MI and comorbidities like diabetes, hypertension, and other vascular disease. So score is allotted to each of these things based on that Euro score, Parsonet score, and other various French score are there. So basically, these scoring systems are based on the region wise, whereas each of these scores have its own disadvantage. Like you can see in this, patients with a 82-year-old woman, where the score is high because of the based on her age, she will have a high risk. But on looking at the angiogram, we can see that there is a good graftable vessel beyond the stenosis. So based on her score, which you say it is high, it is wrong. Whereas in this patient, 46-year-old male smoker with a very poor distal graftable vessel, for him the score will be high actually, but the outcome also will be poor. But based on his age, if he score it is very, very low. So each scoring system has its own advantages and disadvantages. So finally, the factors which are identified, which can improve the CABG mortality rates are: you have to use the continue to preoperative aspirin, adequate beta blockers, use of internal mammary artery graft, avoidance of hemodilutional anemia, early recognition and treatment of low cardiac output, and protocol for high-risk patients who are having low cardiac output and heart failure, strict control of diabetes, and follow early extubation protocol. So finally, the ingredients of the great CABG surgery or for a better outcome is you should have a good functional multidisciplinary team involving the cardiologist, anesthetist, and the surgeon. And use of guidelines as given by the American Heart Association or other associations, where most of the people go for a PCI or stenting compared to CABG because of the fear of incision or the surgery. But if you follow the proper guidelines, the outcome, the long-term results are very, very better, much better, and the patient will have a better outcome. So there is decision support of the patients and the physicians. The patients have to be explained properly. And the important thing is evidence-based approach to CABG surgery. The measurement system, the data information should be explained clearly to the patient, and clinical process like use of arterial grafts as much as possible and other protocols. So these are the various arterial grafts. So arterial grafts are much better compared to the venous suppressed vein grafts because of their nature and the longevity, which is shown in many other trials. So the various arterial grafts that are used are the somatic, like internal mammary artery and inferior epigastric artery. The type 2 is the splanchnic artery, that is the right gastroepiploic artery, and the radial artery. So based on this, the pedicle grafts, and you can use the free grafts. Pedicle grafts, that is the internal mammary artery. Now this is widely accepted, and it is proven that internal mammary artery grafting to the left anterior descending artery is the gold standard for all CABGs, because there is incremental benefit on adding arterial grafts because of better survival and longevity of the graft patency. Whereas the venous grafts have a lower early closure, where within 10 years, only the survival patency of the venous graft is only 60%, whereas that of internal mammary arterial graft is about 90%. So arterial grafts have better outcome if you use it rather than using a venous graft. So you can see, and next is the form of surgery which we use, like whether you do off pump or on pump. On pump, we use an CABG. We will divert the entire body blood to the external circuit, where there will be a systemic inflammatory response and also leading to other neurological dysfunctions compared to the off pump. So in off pump CABG, which has shown that the functional MRI image activation images, where you can see almost pre-op and post-op is the same. Whereas in on pump, this shows a frontal dysfunction, and patients having some cognitive dysfunction post-operatively if you do on pump CABG. So similarly, using a better procedure like doing an endarterectomy for the coronary artery LADs or the RCA gives a better outcome than leaving them, because in diabetic patients, the vessels are diffusely diseased, they're calcified. So just grafting the area where it is better is not good for long-term outcome. We have to remove the entire plaque and then graft the vessel. Here we have done the endarterectomy, and there is a wide opening which when doing endarterectomy, we have to open it wide open. And then so we grafted with a small vein graft, and over this we will place an internal mammary artery. And this is the octopus where we do a beating heart surgery. This is the octopus, that is a stabilizer that is used to stabilize the heart. So these are the arterial grafts where you use the left internal mammary artery and the right internal mammary artery. So the left internal mammary artery is used to graft the left anterior descending artery, and the right internal mammary artery is used for right coronary artery. Similarly, we can use a vein for the posterior descending artery, the PDA, that is the branch of the right coronary artery. So these veins on the right side are proven to be a good because of the low pressure system and the area of the supply. Whereas in the left system, it is always better to use the arterial grafts like internal mammary artery and the radial artery. Some patients we can use for some patients we can use the radial artery and the internal mammary artery. Whereas in this patient, where it is now the advances have come is using a TCAP, that is a total endoscopic coronary artery bypass grafting, or mid-cap, that is minimally invasive direct coronary artery bypass grafting. So now the best decision is by using a mid-cap procedures, where we use a left submammary incision and then use a octopus to directly graft the vessels by using long instruments, and elevator. This steel rod that is used is being to elevate the sternum to harvest the internal mammary artery, and then we can directly graft the LAD. So these are now the latest and the best method to use for the patients to undergo coronary artery bypass grafting, because we are preventing the sternotomy, and thereby the pain and the recovery is much faster, whereas in mid-cap procedures. So in mid-cap, the other advantage is early recovery and faster they can go back to their own routine work. Because we will go through the intercostal space, there is no bony pain that the patient can experience post-operatively, and he'll be much ready to go for the back to the work. And we can encourage much patients for by mid-cap to avoid stenting rather than, or partial revascularization, rather than by this method we can go for a total revascularization of all the vessels. Previously they used to graft only the LAD and OM, but now that techniques have come where we can graft even the PDA by this method. So this is the outcome and a small incision that is being used for mid-cap procedures. The other one is the robotic, which is used in almost other branches also, but it's not much widely accepted because of the certain constraints. So finally, the best procedure of NSCA is that when I am sick, I want a doctor that will treat me and not an average. I want a doctor who will recognize the various ways in which I differ in my particular demographic, clinical, and other pertinent attributes. I want a doctor to recognize that the average obtained is a mixture of different kinds of people. The doctor should then sort out those treatments and apply the treatment most suitable to me. This was given by Alvin Feinstein, and it holds very good even till today. And I think most of us will accept to this. Thank you.
Thank you very much, sir. Dr. Sagar, sir, thank you.
Thank you.
Our next speaker is Dr. G. Ramohan Garu, MS MCH from Kakinada. And he's going to tell us about the best practices of bariatric surgery, current global scenario. Dr. Ramohan, sir.
Dr. Ramohan, sir? Sir, are you there?
Hello. Hello.
Hello, sir.
Hello,
We can hear you.
Yeah. How do I share my screen share?
So there will be a green color screen share button, sir. You can directly press on that.
Yeah, I'm not getting here. Yeah.
You can share the screen.
Just trying to share. I'm not seeing any button here, green. Yeah, this only.
Are you able to see, sir? You exit from full screen.
Exit from full screen.
Yeah, try to change the view of the screen, sir.
Viewing options. There you click, sir.
Viewing option.
You click and exit, you can find your PPT.
Video. I'm unable to see it, sir.
What's happening?
Sir, try to exit and rejoin, sir, if that is the case, right?
Yeah,
then,
I'm unable to see any join this.
Can you on the right side top, sir? You will see something called view. Try to change that, sir. My view. There are, yeah. We are able to see your video, sir. You just have to see.
The video coming, but I am not able to see anything. Shall I rejoin?
Yes, sir. Do the, try to do that, sir. Should we continue with the other session, ma'am, till the issue is rectified?
That's up to a moderator. Sushma ma'am, what do you say?
Yes, ma'am. Until sir is ready, we can go with Gopal Krishna sir if sir is ready.
Okay,
Gopal Krishna Gokhale sir.
Yes, ma'am, I am ready.
Yes, sir. Good afternoon, sir.
Good afternoon, ma'am.
We welcome you for enlightening us on transplant surgery, how to make it feasible and accessible.
1 second, ma'am. I'm just saying that. Can you see my slides?
No, sir. We are able to see your email, sir.
Screen.
Can you see that?
No, sir. We are able to see your Gmail account, sir. There's a email that has come.
Oh, no.
You can stop the screen share and then try to redo it.
Okay.
Sir, able to see do the screen share, sir?
Gopal Krishna sir. Hello, sir.
Jasmine, can you check on with Gopalakrishnan sir on the call? What is the issue?
Yes, sir. 1 minute, please. Since we have lost connection with the two speakers, I would ask our moderator, ma'am, to see if we can proceed with the third one for now. Meanwhile, our tech team and we will try to contact the previous speakers. Is that okay, ma'am?
Yes, ma'am. Can we ask Anjali ma'am or the next speaker?
Yeah,
Yes, ma'am.
I'm there.
Anjali ma'am is online.
I'm there. I'm here. Do you want me to start?
Yes, ma'am. Okay. We welcome Dr. Anjali Saple, ma'am. She's a consultant plastic surgeon from Visakhapatnam. Regarding, she's going to tell us about the best practices in the management of burn wounds. Welcome, ma'am.
Yeah, thank you, Sushma. Thank you very much. Is my screen visible?
Yes,
ma'am,
ma'am.
it's visible. Go into slide mode. Yes.
Okay.
Yes, ma'am. Please go ahead.
This is good.
Yes.
So first of all, let me just thank the IMA and Ramani ma'am for giving me this opportunity. Today, my topic is management of burns wound, best practices. So burns is the second most common cause of death, and with one death every 4 minutes, it definitely poses a huge physical, social, financial, and psychological burden. So for us, basically, when we want to talk of burns wound management, the first thing we need to do is the entire assessment. Assessment of etiology of the burns, assessment of extent, assessment of depth. Then we need to see if there are any critical areas like face or oral cavity or fingers, perineum. Basically, any critical areas, if they are involved, then they need attention first. And of course, last but not the least, any comorbidities. Coming to etiology, primarily we see thermal burns, but then we also have electrical burns, chemical burns, and rarely lightning burns. So more or less the fluid management in all these will be more or less similar, but the wound management will differ depending on the etiology. Next, we will see the extent of burns. I think we are all aware of the rule of 9. And in children, the London Browder chart. So as the child increases, the head and neck surface area decreases and that of the lower body increases. So I'll not dwell much on this because I think everybody knows this. Coming to the depth of burns. So we have first degree where only epidermis is involved. Second degree where you have superficial dermis, that is the papillary dermis. Deep is where the reticular dermis is involved. And third degree where the soft tissue is also involved. So this is a representative picture where if you see in the lower part, there is redness and it will blanch on touch. It is more painful. If there are hair follicles present and it is highly sensitive, it is more superficial. Whereas if you see the part on the thighs, it's more or less white or a black eschar that is forming. The hair follicles are absent, there will be no sensation, there will be no pain. So that will give us an idea that this is more of a deep burn. Fluid protocols, there are multiple protocols, but what we normally follow is the modified Parklands or the modified Brooks, where we give 4 ml per kg per percentage of burns. And that is the total volume requirement in 24 hours. Half of this given in the first 8 hours. The next half in 16 hours, and the other is modified Brooks. Now, the main monitoring of the resuscitation is that the urine output should be about 0.5 to 1 ml per kg per hour. So if that outcome is there, that means that the patient has been well hydrated. So this is something that the first responder should do. Adequate hydration of the burns is essential because the moment a patient sustains burns, there is a huge shift of fluid from the intravascular compartment to the extravascular compartment and causes a lot of hypovolemia. So the first and most important thing is hydration. And these are the various parameters that can be measured to see if the hydration is intact, is good or no. One important factor of hydration or one important advantage is based on this, what happens in thermal burns. So all of us are aware that when there is a direct burns, there is a coagulation of the proteins of the cells. So that gives what is known as the central zone of coagulative necrosis that is surrounded by the zone of stasis, and that is further surrounded by the zone of hyperemia. So when we give adequate fluids, we are actually preventing the conversion of the zone of stasis to the zone of coagulation. So that is one of the most important advantages of giving adequate fluids. We are restricting the amount of burns and the degree of burns. Also, the next thing is that we need to prevent infection and early coverage. That will be coming later. Now, what are the aims of wound management? One is obviously to decrease pain, decrease the risk of infection, we need to cover the wounds as early as possible. And not just cover, we also need to prevent late sequelae like contractures, painful scarring, and deformities, because that will always give a more complete functional and psychological recovery to the patient. So we have a huge number of dressings nowadays in our armamentarium. If you see, these are the traditional dressings that we always have been using. These are the biological dressings, and now we have a lot of synthetic dressings. Now, the most commonly used dressings are the silver-based dressings. Most common, everybody knows, is silver sulfadiazine. Another modality there is nanocrystalline silver. And then we have the non-silver-based dressings, that is Vaseline gauze. You have various antibiotic impregnated gauzes. You have antibiotic ointments, and you have solutions. Now, the advantages of silver sulfadiazine: it is easily available and it has good bacterial and fungal coverage. But the disadvantages are, very often it forms a pseudo eschar, and we are not really able to assess the depth of the burns once the silver sulfadiazine is regularly applied. Another disadvantage, it has poor eschar penetration, and long-term use may give rise to leukopenia. So a good alternative to that is nanocrystalline silver, which does not have any burning sensation when we apply it. There is a constant cover of the wound. It releases the silver very slowly. So the wound has a constant cover with silver. It stays on for about 5 days. We don't need to change it. So every day we just need to activate the dressing with distilled water. So dressings are not painful. And we have also noticed that there is a reduced requirement of higher antibiotics. We need to start higher antibiotics much later in the treatment. Another modality is collagen sheet application. Now, indication for this is second-degree superficial burns. This is an ideal cover. The advantages are it has decreased fluid loss, decreased pain. It promotes early epithelialization. And again, there is no need of frequent dressing changes, so definitely increases the patient comfort. So as you can see in this slide, it has stuck to most of the areas where the wounds are superficial. Disadvantages, though, it needs proper assessment of the depth of burns, may need anesthesia in certain cases, and it cannot be used if the patient presents late. Now, we also have a lot of skin substitutes that consist of only dermal equivalents. There are substitutes which have both dermal and epidermal equivalents. And then, of course, there is the allograft, that is cadaveric skin, which if you have access to a skin bank, that is a really good medium that we can use. Advantages are that these can be used as temporary cover of large wounds, or they can be used for covering wounds with critical structures, like if you have tendons or bone exposed in small areas and there is a huge burn area on the body, at least these areas we can cover temporarily with these skin substitutes. Another advantage is it can be used after tangential excision till the patient is ready for harvesting autograft. But the disadvantage is the huge amount of cost that is still prevalent because of these are newer substitutes. So once they become more affordable, definitely they can be used for more number of patients. Tangential excision is a modality that is now the gold standard. Definition is excision of superficial necrotic tissue by taking repeated slices parallel to the skin surface. Normally, it should be about 0.005 to 0.01% of inch. And we gradually start excising these till we get good punctate hemorrhage below. And that is when the excision should be stopped. Once we get this good punctate hemorrhage, then we cover it with either an allograft for larger burns or an autograft if it is a small burns. This is an example of tangential excision with autograft done for hand burns. Advantages, it reduces the toxic load on the body, early cover of the wound, and it gives a better function and aesthetic outcome, especially for areas like face and hand. Disadvantages, blood loss, it requires proper assessment of wounds, and it needs a good intraoperative and postoperative intensive care, especially if you're using it for large areas. Okay. So that was about thermal burns. Now, electrical burns poses a totally different problem. Usually, most of these burns are deep. So if you see in this man, there is an electrical entry wound where this thing appears to be directly connected to the underlying skull bone. So the moment we debride it, the skull bone will be exposed. So usually these are deep burns. There is severe muscle damage. As you can see here, there may be compartment syndrome in extremities leading to vascular compromise. There is usually arcing burns in extremities, as again you can see in this picture. And there is a very high risk of renal shutdown because of myoglobinuria, especially if there is widespread electrical burns. Most of these patients may need early fasciotomy to prevent vascular compromise. So in this man, electrical worker, you see that the fingers have been charred, but then we have done a fasciotomy so that we can try and prevent the loss of the other remaining fingers. Similarly, here there is an electrical burns where the skull is exposed without any periosteum. So these patients usually go in for a flap cover. Chemical burns, I'll just touch upon this. Usually the management is the same, but the most important thing is thorough irrigation with copious amounts of water, and you need to address injury to critical structures like eyes, nose, and mouth. And usually, again, chemical burns are also deep and they need flaps for reconstruction. Now, topical wound management, the management does not stop there unless you give a simultaneous systemic management with the help of nutrition, enteral, parenteral, blood transfusions, albumin transfusions. Pain management, this has become a very important part and parcel of burns management and burns care, and chest care and physiotherapy. Unless this is done, a wholesome treatment of burns is not possible. Supportive care in the form of splintage. You see here, if a graft has been put, but the splintage has not been done, the hand goes into a non-functional position. Whereas if you give a splint, the patient gets back to work early. The treatment continues even after the discharge of the patient. You see this young girl, she was working on her, she was playing on her mobile, which suddenly short-circuited, and she had almost 60% burns. But you can see that we have given her compression garments, neck splints, and then under this, she's using silicone gel sheets. So that helps in maturing the scars. We need to follow them up with laser therapy, intralesional injections. Fat grafting is a new modality. Fat grafting and PRP, these are newer modalities that help to improve the appearance of the scars. Few examples. So this was a 70% mixed burns. We did stage skin grafting and she was discharged after 40 days. These are some of the complications when they come late. So this child, he was a 17-year-old child who had already undergone grafting in a local hospital, but all the graft had got lost, and he came to us with bilateral flexion contracture of the knees. And this is after he was stabilized and stage grafting was done. Scar management. This patient had a very itchy and painful scar. Although it is not raised, but he was still affected by the continuous itching on the back. And this is what we did, along with, of course, the scar management protocol. Now, this was a representative case where rehabilitation really helps. So this was a bilateral electrical burns. If you can see this side, the index and the in spite of the fasciotomy, which you saw in the earlier slide, we were not able to salvage the hand, but the fasciotomy did help us in restricting the amputation to a below elbow. Otherwise, he would have gone to a above elbow amputation. In this case, we managed to save his elbow, and on this side, we gave him a groin flap. We did a toe transfer for the left side, and we gave him a myoelectric prosthesis for his right side. So this is how he is now functionally helpful, or he's able to at least carry on his functions. Complications, scars, contractures, Marjolins ulcers, and cannot emphasize the importance of team approach. where all these specialities need to work in tandem so as to give the best possible outcome to a burns patient. Thank you very much.
Thank you very much, ma'am. You have given a wide spectrum of knowledge about burns. You have covered all the etiologies, acute management and chronic management, along with the skin substitutes. Thank you very much, ma'am.
Thank you.
Dr. Gokhale and Dr. Ram Mohan sir, both our speakers are back. I would request Dr. Ram Mohan sir to please check the connection and see if they can proceed with the presentation. Dr. Ram Mohan sir, so can you hear
I'm
me?
online. I'm trying. You can proceed with the next sir's talk. I will be connecting in between.
Okay, okay.
I'm unable
for
to
the
share
next
screen.
speaker,
Okay. Yeah.
okay, sir. So the next speaker is Dr. Gokhale. So can you proceed?
Yes, ma'am. Sure. Can you see my presentation, ma'am?
No, sir. We can see your video, but not your presentation.
What is happening?
So can you try changing your screen view, sir? On the top right side, there's a button called view.
Yeah, it is there.
Now we are able to see, sir. Can you
Here,
make that?
see, Ram on screen, I think.
Yeah, this is.
Try doing yours, sir, once.
Okay, 1 second. And yeah, I'm going to the view. Then what should I do? Full screen, is it?
Do gallery or something and then start screen sharing. Yes, sir.
Can you see my screen?
Yes, sir. We are able to see your screen, sir.
Yeah, transplant surgery, how to make it feasible and accessible. Can you see that, sir?
Yes, sir. Yes, sir.
Okay. Good afternoon to all of you. My apologies for all these delays and technological inefficiencies from our side. And I thank the organizers for giving me the opportunity to talk about transplant surgery. I was asked to talk about how to make it feasible and accessible. Can you hear me?
We can hear you, sir, but we are unable to see your PPT, sir. Again. Now it. It has gone again, sir.
Can you see now?
No, sir. We are unable to see. Sir, have you connected with two devices, sir? Or is it just
only one device? It says it's sharing my screen. Sorry?
No. Try taking that to slide mode, sir. Slide mode.
Slide mode.
Yes. Third option.
Can you see now?
Yeah, we are able
So
to
we
see.
can see. Can you just go to the slideshow, sir?
Yeah. Now
Yes.
I went to.
Yes,
Can
sir.
you see?
Yes, sir.
Yes, sir. Yes, sir.
Okay. Thank you very much. See, as we all know, we do the transplants when the various organs reach their end stage, where we cannot do anything other than transplant to keep them alive and have good quality of life. However, majority of these patients with end-stage organ disease are never placed on transplant waiting list. Well, the term health equity is a very fashionable word to say. We all know that it's next to impossible to provide equity in practical terms. It remains an elusive goal with multiple barriers in the registration of all these patients for transplant. Ideally, this is how it looks. Any transplant system should have be able to provide equity to all the people, should be transparent, should add value. And within the policy and regulation environment and various coordinating agencies like transplant providers, donors, and then donor hospitals, whereas non-governmental organizations, governmental organizations, all these should be able to provide effectiveness, safety, access, and timeliness, efficiency, patient and family centeredness. All these things are ideal. However, even developed countries like America, it has been shown that this equity doesn't happen. All the patients do not get organs either registered or get the organs. There is a limited access to the transplant waiting list combined with the scarcity of organ pool result in over 1 lakh deaths annually in the United States. This is a publication done in last year that shows that transplantation is a difficult area to handle. You know, there are a lot of problems in registration in that country. The women get less options, the donors are less, Black people get less options. So there are many issues they have found in countries like America, forget about India. These are the various aspects when we think of a transplantation. There are legal aspects, recipient, and the providers, donor, non-governmental or governmental organizations, infrastructure of organizations, and finances. All these things, everything is very important in providing the opportunity for transplant for those in need. Fortunately, in our country, legal aspects actually reasonably advanced. We have this Transplantation of Human Organs Act, first passed in 1994, which decided about the brain death declaration, and after that, human organ transplantation. As we all know, from an All-India Institute, Professor Venugopal did the first heart transplant the same year. Later, a few modifications have come as per the need at the time. And today, with the present Act, there are a lot of things, like say retrieval centers have been defined. It has been shown that the brain death declaration is actually mandatory in most of the places. Provision of transplant coordinator and brain death certification. Various issues have been sorted out most of the way in a legal fashion. And they have been established a central monitoring organization, NOTO, in 2011 with a job of monitoring all the transplant programs, educating the people about transplantation, maintaining the data about how many transplants, how many donations are happening, training people involved in transplantation. Yes, this has been done officially, but however, there are many issues for the NOTO. For example, in our country, health is a state subject. And states obviously not like to follow what center says in the health area. And there are coordination problems between NOTO, ROTO, state organizations. And there is no legal mandate on provision of data. Exactly how many transplants are done, we are not sure. And we have different allocation systems based on the state's likings and dislikings. We do not have a centralized system. There were some patients who are eligible in one state may not be eligible in other area. But the main constraints in providing transplants to those in need are, one is organ availability and allotment. And second, very important, especially now that more than 600 people got registered in this CME, the primary care providers, where they are physicians or basic practitioners or even specialists, and the referral pathways problems, complaints of patients, financial constraints, and transplant service providers. These are the main areas wherein we have to work to make sure that more transplantations can be done to those in need. As you can see in this map, mainly in the south, most of the states have got these transplant programs. Northeast do not have much programs, and north only these days it is actually picking up. For example, in Delhi, hardly any donations. Even today, there are more live transplants being done in Delhi compared to the south. The organ donation rate in our country is quite low. It's 1 per million. I have to tell you all that it has grown enormously. About 15 years back, it was 0.05. Then it became 0.5. And today is 1 per million. And Telangana tops the list with 5 per million, followed by Tamil Nadu. But on average, it's 1 per million. Look at the rates in other countries like Spain, where it is 32 per million. USA 25, UK 17. Ours is a minuscule, and there is so much that can be done in the organ donation. Is it because we do not have the donors? We all know, especially the accident patients are the most important donors, apart from the bleeding in the brain and neurosurgery patients. And we have about 17 people dying with major accidents every hour in our country for the last few years, showing that there is a huge potential donor pool that is there in our country. In case we can raise the organ donation rate to say 2 per million, we'll have about 2,000 hearts, 2,200 livers, and imagine that we reach 10 per million, then there's a huge pool. Probably no other country can do as many transplants as possible. But then we have to blame our own colleagues in certain areas. For example, there is a lack of awareness of concept of brainstem death among stakeholders. We ourselves do not declare brainstem death. Unless brainstem death is declared, we cannot proceed to the next phase of donations and transplant. And second major issue we all face, we are all those in the transplant area, we face our maintenance of donor. We do not have a standard protocols. The kidney people would like to give a lot of fluid, thereby damaging the lung, are giving a lot of vasoconstrictors, damaging the heart. So we need to have a protocol for maintaining these donors. Look at this. Are we using all the hearts that are available? For example, you can see there are a lot of donor hearts, whereas those used are very less. The reason for that is there are a lot of wastage because of marginal donors, some of those badly managed in the ICUs, some allotment issues, some people have transport issues in the middle of the night. If the recipient cannot come to the hospital because they are far away, or we cannot get an organ from a long place, that is because everyone cannot afford a chartered flight or travel by other means to get the organs. However, we have developed a lot. We got green channels these days with the government, which is very important to bring the heart and lungs especially. And certain state governments are supporting even air transfer. For example, Kerala is providing air transfer, and sometimes Army and Navy also give support, but this is not enough to bring the organs in the middle of the night. Do we have enough number of patients for transplant? As you can see, there are about 180,000 are expected to have kidney failure, and we do only about 6,000 kidney transplants. There are about 50,000 people who require heart transplants. Only about 200, 230 are being done. And you can imagine, look at the liver, pancreas, and lungs. The lungs are hardly being done, about 100 to 150. There are many things that are happening to make organs available to those in need. For example, the ex vivo perfusion methods. These are new methods that have come to make sure that we can transport heart, kidneys, liver for a longer distance, but they cost a huge amount. That itself cost by about 5 crores, and the disposables will cost about 25 to 30 lakhs just for this. Forget about the cost of the transplant. So this is where I think the government and some private organizations, maybe a group of hospitals, need to step in, get this equipment so that more people can be helped. The other option is opt-out method of donation. As we all know, the transplant modality is in our country opt-in. Anyone who has a brain death, we talk to them, then we find out if they are willing to donate, and most of the people are not willing. Whereas in countries like Spain and recently UK have gone into opt-out method, wherein any person who is declared brain dead, we can take the organs unless the family says no. The other new area that is happening is the DCD donations, where instead of brain death, after circulatory death, immediately put them on pump, perfuse the organs, take them. That's how you can see in Spain, almost 25% have gone up the transplant. In USA also doing some work. UK also almost 50% of the work has gone up with this opt-out method. These are some of the things that can be looked into. Some of the peculiar problems we have, especially in our country, they are there in all the countries, is a referral. There are many patient, provider, and system level factors that contribute to delays in referral. For example, patient level. They are not aware, most of the people, are not aware that such transplant facilities are available, either by themselves, not even the providers. The doctors also do not tell them. I have many patients who come almost on the deathbed being treated by cardiologists just because they have not been told that there is such an option they can explore. And some patients also have negative attitudes, beliefs, religious and socio-economic and psychosocial religious challenges. Those preclude some of these people coming for transplant. Whereas the provider, as I said, lack of knowledge about when to refer patients and lack of knowledge about the availability of facilities. I'm sure in Andhra and Telangana, for example, most cardiologists still are not aware where heart and lung transplants are being done in our own states. And many of them do not have time to communicate enough for the people. And some people believe that transplant they don't work. I am aware of cardiologists and surgeons who believe that transplant is not for India, it is only for America. These are some of the blocks we have in our country. And as you all know, most of these facilities are the private hospitals and patient has to pay from the pocket. And government hospitals, unless they are involved, unless government organizations are involved, transplant service can never reach the common man. And we have huge financial constraints. Insurance is hardly there for 15% people, maybe 2 lakhs, 3 lakhs, 5 lakhs. They all have to pay from their pocket. And we all are aware that the Telangana and Andhra government and the Prime Minister's fund, they are to some extent supporting this transplant, but the funds are not enough for either surgery or for immunosuppressants after. These are some of the things that need to be looked into. And central and state governments should take the responsibility for these transplants with the help of philanthropists and CSR. And again, as I mentioned, donor management is a big issue that is something that needs to be tackled. We all have seen so many problems. What can we do? Some of the solutions in nutshell are public education, including knowledge about organ donation and its uses, starting from school and college curriculum. I think when people talk of organ donation, they should not raise their eyebrows. It should become part and parcel of that happens only when the education starts from school and college curriculum. And it is very important that we educate professionals like what we are doing today through IMA conference and discussions, that such facilities are available and they need to know when to refer. And we need to develop donor management protocols so that more patients, more donors are available, and many donors will lose because of bad management. And I also feel that all medical colleges should provide these transplant services. And unless the medical colleges provide these facilities, they cannot reach the common man. And we need to look at the financial support for donor management and recipient surgeries and immunosuppressants. And it's also important that, as what our PM said, one nation and one organ and legal mandate to NOTO in allotment supervision. I think this has to become a national program, and the center supporting the states and center working together so that any patient anywhere can be allotted an organ, and one nation, one organ. I think these are some of the things when we do, probably we can help more patients than what we are doing today. I thank you all again for giving me this opportunity to talk my little knowledge in this transplant area. Thank you, ma'am.
Sir, that was a very really in-depth analysis of the state of transplant surgery in Andhra Pradesh, sir. Probably we have to put forth all the guidelines that you have told to government, sir, to increase the transplant surgeries, which is a dire need now, sir.
Thank you.
Probably you could and give us from, I think you are working in a medical college now.
Yeah, I'm trying to help the Guntur General Hospital develop the transplant
You're very near to a
program and
DME
open hearts.
office and center of action in the Andhra Pradesh. I think you please guide us. We will also take suggestions from our, because now the government has started transplant surgery throughout the state. We have to take the your suggestions to improve the surgeries, sir. Thank you so much, sir. It's an honor to have you here in the midst of us, and we are privileged, sir. Thank you, sir.
Thank you.
Namaste.
Thank you. Bye.
Thank you, sir. Now we have again Dr. Ram Mohan, sir. So were you able to connect this time, sir?
Yeah, I'm online. I think I'm sharing my screen. Are you able to see it?
Yes, sir.
Yes,
We are
sir.
able to see. Go ahead, sir.
Yeah. Good evening to the chairpersons, and at the outset, I would like to thank IMA AMS for giving me an opportunity to speak about bariatric or metabolic surgery global scenario with best practices. As you all know, there is a $2 trillion burden on because of obesity in the entire global scenario, and 30% of global population are overweight or obese, as the data shows. And coming to Indian perspective, almost 10% of country's population are obese, and we are genetically susceptible because of SNP polymorphism, where we are more prone for central obesity. And as per the Aussie guidelines, Obesity Surgeon Society of India, almost 1.37 billion people are today obese, and we are third in number after USA and China. And as per 2018 data, almost 20,000 bariatric or metabolic procedures were done in 2018, and we are among the largest hub for bariatric surgery in the Asian continent. As for the projections, by 2030, almost according to International Diabetes Federation, 438 million people are going to be obese, are going to be diabetic, with increasing trends of obesity, almost 54% increase. And as for India, you can see that almost 87 million people are supposed to be diabetic by 2030. And obesity can be measured commonly by, you all know that body mass index is the basic what we all follow, followed by biometric impedance like body fat analysis machines, what we use for the bariatric centers. And obesity is classified based on BMI criteria, where Western criteria is different from the Asians because of we are prone for central obesity. Normal weight, normal BMI is from 18.5 to 25, where for Asians it is 23. Overweight we call when we are above BMI of 23 in Asian population, we call them as overweight, but Western is 25. If the BMI is more than 27.5 for Asians, we call them as obese, but for the Western it is more than 30. And if it is more than 35, we call them as severe obesity or class 2 obesity, whereas for Indians it is 32.5, whereas morbid obesity is more than 40 for Western, whereas Asian for Indian population. Surgery or metabolic surgeries we interchangeably use because obesity with diabetes, we classify it as a metabolic surgery. So how to identify that metabolic syndrome? We take into consideration five parameters, where out of these 5 parameters, if 3 are elevated or deranged, then we call them as the metabolic syndrome, like elevated waist circumference, elevated triglycerides, reduced HDL cholesterol, elevated blood pressure, or elevated fasting glucose. Any 3 out of these 5 constitute a metabolic syndrome. And as you all know, obesity is associated with comorbidities like diabetes, type 2 diabetes, hypertension, dyslipidemia, gout, polycystic ovarian syndrome, infertility, joint pains, chronic heart diseases, sleep apnea syndrome or hyperventilation syndrome, and metabolic syndrome. And obesity is a chronic medical condition, and WHO has now classified it as a chronic disease. Earlier, it was thought to be a cosmetic problem, but now it is considered as a disease. So when it is a disease, it requires a treatment. So, and for a successful definition of a treatment of obesity, ideally patient has to attain a normal weight, no treatment-induced morbidity, where this is rarely achieved in clinical practice. As for the Aussie guidelines, for recommendations for bariatric or metabolic surgery, a patient should be of a BMI of more than 30 with presence of 2 or more obesity-related comorbidities, or a patient may be more than 35, more than equal to 35 with or without presence of any obesity-related comorbidity. A person with a BMI more than 27.5 with uncontrolled type 2 diabetes, despite optimum medical management, can be recommended a metabolic surgery. Whereas central obesity with waist circumference of more than 80 centimeters in females and more than 90 in males, along with type 2 diabetes and other obesity-related comorbidities, bariatric surgery or metabolic surgery can be recommended for that. And age, more than 18 years of age and less than 65 years of age, the recommended age as per the Indian Aussie guidelines. And now the Diabetic Federation of American Diabetic Federation, where this now the metabolic surgery has come into the flow charts, and it is recommended now that class 3 obese with for Asians more than 37.5 with can be recommended a metabolic surgery, where class 2 obese with poor glycemic control can recommend a metabolic surgery, where class 2 obesity with adequate glycemic control or class 1 obese with poor glycemic control can consider metabolic surgery. So diabetic federations have now recognized that bariatric or metabolic surgery is part of the algorithm for treating obesity with diabetes, or we call it as a diabesity. What are the contraindications for bariatric and metabolic surgery? We usually see when the patient is not compliant and unable to follow for follow-up or take nutritional supplements, we straight away tell them not to undergo a bariatric surgery. Or any patient who is medically unfit, then we don't take them for any bariatric or metabolic surgery. Or patients with non-stabilized psychiatric disorders, it's an absolute contraindication for bariatric surgery. Chronic smokers, alcoholics, drug dependencies, unless they are through a de-addiction program, at least for 6 months prior to the surgery, they are not off those habits, they cannot be recommended a bariatric surgery for them. Patients who have a short life expectancy for terminal illness are not a candidate for bariatric surgery, or pregnant women who wish to conceive within a year after surgery are not recommended bariatric surgery, because after a bariatric surgery, ideal time is 1.5 to 2 years waiting period to conceive after a bariatric surgery. What are the bariatric surgical techniques are divided into 2 groups, like a malabsorptive procedures, or it can be a restrictive procedures, and or a combination of both of those. And recommended procedures as per the Aussie guideline, the standard procedures which are recognized are gastric banding, sleeve gastrectomy, Roux-en-Y gastric bypass, BPD with duodenal switch, or one anastomotic gastric bypass, or it is earlier called as mini gastric bypass. There are other associated procedures also as per the Aussie guidelines. But Aussie data says in the 2018 publication, which was published in 2018, data published in 2020, say almost bands are in vogue. We are not putting bands nowadays unless it's a sleeve plus procedures or bypass with a band. Routinely, the major almost 60 to 70% of surgeries in India and across the world are sleeve gastrectomy, followed by one anastomotic gastric bypass, followed by Roux-en-Y gastric bypass. And all other procedures now, endoluminal procedures are also picking up with the advent of endoscopic sleeve gastroplasty. What do you need to start a bariatric program in anywhere? You need the equipment. You need a bariatric table which can bear heavyweight patients. You need a good endoscopic system which requires energy sources, high-end energy sources, and you require anesthesia and team trained to give anesthesia to these patients, because the intubation is a problem, maintaining the patient is a problem, extubation is a problem unless you optimize the patient before surgery. And you also require gadgets like staplers, like stapling devices, which are now all powered guns, what we use nowadays for all bariatric surgeries. And to talk about bariatric surgery, we understand the physiology sometimes. What is the benefit of undergoing a bariatric surgery? We mainly concentrate when we counsel a patient regarding the ghrelin, because ghrelin is the hunger producing hormone, which is secreted mostly from the stomach. Or we are more interested in GLP-1 and PYY, which are incretinogenic hormones which help in alleviating the type 2 diabetes, what we say remission of type 2 diabetes after bariatric surgery. As you can see, there is an anti-incretin. When the food passes through the stomach, through the duodenum, we have an incretinogenic cells which produce incretins, as well as anti-incretin cells, which are mostly concentrated in the duodenal wall. So when food passes through that, anti-incretinogenic effect causes the type 2 diabetes in obese patients. And mostly nowadays research is all about, they say that diabetes is not because the engine is not in the pancreas, but it is in the duodenum nowadays. That's what the research is going on about. So how does it help? When you do a bypass, we are excluding the duodenum where the food is not passing through the duodenum, where we are mitigating the anti-incretinogenic effect. So the incretin cells are stimulated where it produces a GLP-1, PYY, which increases the production of insulin, thereby the remission of type 2 diabetes, what we see in post-bariatric or post-bypass patients. This is called the foregut hypothesis, where we are excluding with anti-incretins and stimulating the incretin cells. And distal small bowel or a hindgut hypothesis of how the bariatric surgery works is when the food is hurried and reaches the terminal small bowel faster, then there is an increased release of GLP-1 and PYY, which has an anorectic effect as well as an incretinogenic effect. It's called the trigger, which triggers the ileal brake mechanism, thereby producing the beneficial effects of bariatric or metabolic surgery. And gut hormone studies have been studied after a bariatric surgery, where they have found that PYY, GLP-1 increases after a bypass. Whereas if you put just a band, which is a restrictive procedure, it doesn't give the same result as a bypass. So nowadays we are not putting bands, as you can see, it's only associated procedures. Bands earlier almost 70 to 80% initially were bands only, which are now being removed mostly. And most common procedure world over is a sleeve gastrectomy. And a small video where you can see a small pouch is created and the part of the stomach greater curvature is removed. So this is how you can see a small video running there. We first coagulate and cut, we mobilize the greater curvature of the stomach. I'll fast forward it. We use energy sources, like we can use a harmonic, we can use a ligature, whatever energy sources you're comfortable with. The difference in doing a bariatric surgery and a common routine laparoscopic surgery is the instrument length, because we use a long length instrument. Either we use a long length sealers, we use long length graspers and bowel graspers, which are long length, because otherwise routine length 37 centimeters you can't reach. Now I have mobilized the stomach greater curvature. Now I'm firing the staplers. These are all powered staplers. Here I'm using a tri-staple tech in this video. And we use a gastric GCT tube, gastric calibration rule, which is 38 French, which is available. And then along the guidance of the GCT, we fire our staplers to create a pouch, which is hardly 100 to 120 centimeter capacity of a sleeve pouch. So this part is an irreversible surgery because we are removing a part of the stomach in this. So sleeve is an irreversible surgery, where here you can see in the end there is a small, you can cut it off, but we don't take chance in bariatric surgery. So we fire another stapler in the end. So finally we do a leak test. We do a routinely we have stopped doing methylene blue leak test. We only do a air leak test, and we remove the specimen and put a drain. It's individual choice of putting a drain or not to put a drain. And second most common surgery in India and around the world is now MGB or OAGB. It's called one anastomosis gastric bypass, where we create a pouch and we anastomose the small bowel. Now the limb lengths have been mostly arrived upon. Earlier, the limb lengths were not defined in OAGB or MGB. With several studies now, they say that 150 centimeter length of small bowel bypass is enough to give the metabolic results what you see after a MGB or OAGB. If you want a weight loss, more weight loss, you need to increase the limb length. Say earlier we used to do 200 centimeter of small bowel bypass. Now we have now come back to 150 to 170. Depends on the BMI of the patient and his diabetic status, on how his HbA1c levels. We based on that we define how much length of bypass has to be created. And we are creating a gastric pouch there, where this is little, we don't do a tight pouch here. We in MGB we keep a little wider pouch, because it's not a restrictive procedure, but it's a malabsorptive procedure. So restriction, we don't add much. Here you can see a small bowel. We measure the length of small bowel from the DJ, and we take around 150 centimeter to 170, depending on the BMI of the patient. Now we are anastomosing in this to the pouch of stomach. We are anastomosing the bypassed bowel, which is a loop. The controversies regarding MGB, OAGB is that they say there is a lot of bile reflux, future chances of malignancies are more, but Indian data as on today, with almost 10 years experience with MGB, they have not seen any increased incidence of malignancy with MGB or OAGB, and it gives the best results comparable to the Roux-en-Y gastric bypass. It gives a better resolution of diabetes, better excess body weight loss. And these are all reversible surgeries. So you need to follow up the patient regularly, and it can be reversed if there are any associated complications or so. This can be reversed back. So this is a small video about MGB, and this is a routine component. It's a conventional gastric bypass, Roux-en-Y gastric bypass, where the anastomosis at two sides. That we create a small pouch, say 50 cc of pouch, gastric pouch, where the small bowel is anastomosed with the biliary limb and alimentary limb, depends on the BMI of the patient. And these are all the other bariatric procedures which are done in few centers like SADI, sleeves, and duodenal ileal bypass. And this is SGIT, so ileal transposition, where it is done mainly for metabolic reasons like type 2 diabetes. And these BPD-DS are very rarely done in India, because we are all mostly vegetarian diet. So we can't maintain the protein intake after BPD-DS, where the metabolic nutrition deficiencies are very, very much high after BPD-DS. And other procedures like endoluminal procedures are picking up, like gastric balloons. Earlier, we used to have only 6 months balloon. Now we have a balloon which can be kept for 1 year. Balloons, as well as adjustable gastric balloons, are also available. And this is a daycare procedure where we do through an endoscope. We put the balloon, which can stay for 6 months to 1 year, depending on the balloon what we use. These are endobarrier linear systems. What now research is going on. Last time, Dr. Nageshwar Reddy told that they are doing some research work in Asian Institute, where they are putting a barrier through the duodenal wall, so that they are able to get the metabolic benefits of a bariatric surgery. But these are all temporary, because once these cannot stay lifelong, they have to be removed back. So the metabolic effect, what you are going to get when the barrier system is there, when you remove, I think we'll not be seeing the same results. These are other endoscopic gastric plication. What is nowadays we do, mostly we do for patients who are post-bariatric, regain weight, their pouch has dilated very fast, and they want some kind of procedure to mitigate that. We do an endoscopic sleeve gastroplasty. The excess body weight loss with these endoluminal procedures like a balloon or endoscopic sleeve is not more than 10 to 15%. Maximum we achieve is 20% excess body weight loss with these procedures. And what are the problems associated? Mostly the patients whom we counsel, they are more worried about the complications. Like mostly we see a recurrent vomitings. We see in patients, few patients, there is a chances of leak, which is 0.5 to 1% leak chances, where in bypass procedures, if there is a leak with severely obese patient, then the chances of getting out is a little bleak, because they are already compromised. And there is a chance of post-op bleeds, because we are doing an obese patient with uncontrolled hypertension. There is a chance that post-surgery, they may end up with a bleed, which requires a re-exploration by way of doing a laparoscopy. And the mortality is around 0.5 to 1% what we see in all the bariatric procedures. And the benefits of bariatric procedures outweigh the complications what we see in severely obese patients, where their diabetes gets resolved in almost 80 to 90% of patients, where hypertension is around 60 to 70% in sleeves, whereas in bypass almost 85% resolution of hypertension we see. Sleep apnea is almost 98% resolution after for a severely obese patients. And in females, PCOD with infertility resolution is almost 75 to 100% in some of the patients. So these are few of the benefits what you can get after a bariatric or a metabolic surgery. Thank you for giving me an opportunity to IMA and AMS. Thank you, sir.
Thank you, sir. Ramon, sir. We are indeed honored to have you here, such a senior surgeon from this part of the state. Thank you very much, sir. And this bariatric surgery is not only a weight reduction surgery, now it has become a metabolic surgery to reduce other metabolic syndromes like diabetes mellitus and all. But they are all non-physiological methods which need very experienced surgeons like you to deal, I think, sir.
Thank you, madam. Thank you for the compliment. I would like more surgeons to take up this metabolic or bariatric surgery as a specialty, so that more number of surgeons doing this, then the conversion rate of patients who really need it. Not that every patient requires a bariatric or metabolic surgery, but really in dire situations, some people we see in the OPD, they come on wheelchairs, unable to walk because of obesity. And so they are the patients who require our services rather than the routine patients. Thank you, madam. Thank you for giving me an opportunity.
Thank you, sir.
Thank you, sir. Now, before we begin for the next session, I want our moderator, Dr. Sushma, to conclude this session with a few words.
Sushma madam,
Ma'am, are you there? Sushma ma'am? Okay, we'll proceed with the next session. Our moderators for the next session are Dr. Jayashekhar, MS Ortho, past president of IMA AP State, and Dr. Manikumar, associate professor and HOD orthopedics from GMC Vizianagaram. And our first presenter will be Dr. BVRN Verma. He'll be presenting on total knee replacement surgery, myths and facts. He's the Honorable Secretary, North Andhra Orthopedics Association.
Hello, can you hear me?
Yes, sir, we can hear you, sir. But yeah, we are unable to see your presentations.
How to go about now?
Can you once stop the screen share and redo it, sir?
Yeah. Okay.
Try doing that once again, sir.
And it is.
Yes, sir. You can go to the slide mode. Yeah.
Good evening, everyone. I thank the IMA for giving this opportunity, Dr. Ramani Madam, also for giving me this opportunity. Adult knee reconstruction has been on increasing mode all these last from 30 years to the present day situation. This is the normal knee joint anatomy of the knee joint, but usually on the X-ray, if you see the X-ray shows, it just shows a bone with a knee gap. But when you open the knee joint, it looks totally different. This is how the normal knee joint looks. When you open the knee joint, this is a normal cartilage, well grown, nice cartilage, shiny, and this is a complex structure knee joint. It has a lot of ligaments, like cruciate ligaments, and you have menisci here and collateral ligaments.
And usually we think that this is the joint having only flexion and extension movements, but there is also something like screw home technique where the femur rotates over the knee joint. So this is the normal view of, this is how a lateral view of a knee joint looks with the cartilage around 4 to 8 millimeters. And this is how it looks from the top. These are called the washers, or you call it as a menisci. That is the reason which have this, what do you say, the gap in between the knee joint, femur and tibia. Although you have this lubrication because of the synovial fluid. And but there are certain most facts and myths regarding on the knee joint. Does everybody get arthritis of the knee joint? Yes, of course. Most of the patients get most of the world population are suffering from arthritis these days, especially because of increase in obesity. Like the risk factors for osteoarthritis are the systemic factors. Systemic factors include like age. There will be a tenfold increase from 35 to 35 years to 65 years. And genetic predisposition is also there. Gender, men less than 50 years or women aged more than 50 years. And nutritional values like low vitamin C and D are all intake also are risk factors for osteoarthritis. And the joint biomechanical risk factors like joint trauma, obesity, occupation, abnormal joint biomechanics like dysplasias, malalignment, abnormal innervations, knee extensor weakness, and sports and joint risk factors. The sports injuries means usually for young athletes, or even most of our own colleagues also during the games like shuttle or tennis play, usually tennis or cricket. We already come across with the meniscal injuries or cruciate ligament injuries. For that, we go about with arthroscopic surgeries. And this is how a normal look like, well-aligned knee joint with both the compartments equally aligned. And this is the stage 3 arthritis. And stage 4 arthritis is just like, you can see most of our old elderly people in our household also, they have a knee bending. So this is how a great stage 4 arthritis looks. Osteoarthritis is most prevalent form of large joint osteoarthritis in the world. And this is because 60% of weight on your knee joints. The more obese you are, the more pressure on your knees. According to the research published in 2001, when you walk on level ground, the force on your knees is equal to 1.5 times your body weight. Being the largest and the most complex joint in the human body, it can absorb vertical force of nearly 7 times body weight. What are the treatment options? Okay, regularly the patient comes with a knee joint. Young patients, usually if they come with a pain, might be some injury, knee injury, without any MRI may not be showing. Some patients, MRI shows a meniscal tears or ligament injuries or cartilage erosions. But aged patients, usually they are, especially after 40 years, especially females above 40, they keep on coming with you with a severe knee joint. Squatting is different, climbing your staircase is very difficult, doing your activities of daily living are difficult. Usually you start with the painkillers. Analgesics also have come off good the quality these days, though they are very mild, but you can give for a long time. But like diclofenac or other paroxycam are more injurious to your renal kidneys. Painkillers or physiotherapy or surgery. The knee surgical treatment options include scopies, synovectomies, osteotomy corrections can be done even 30-40 years back. For arthritis of a knee, they used to do a corrective osteotomies. Even now, certain patients, if we can young patient with severe arthritis, we can do a tibial osteotomy and delay the replacement surgery. But as the last 15 years or 20 years, as I am seeing here, that the amount of knee replacement surgeries have gone on tremendously. As of now, around in the US itself, per year, there's a 6.5 lakh knee replacements are being done. And recently, India also, they have done a study. It's almost at 3 lakh replacement surgeries per year. So the goals of joint replacement surgery should be to relieve the pain, restore the function and the mobility. But the moment you say that most of the patients' surgery, they are scared of hospitals and doctors. They are biased. They have a lot of options like homeopathy, allopathy, physiotherapy. They say some injections will be given, but they're all for stage 1 and 2. But if you stage 3 and if you advise a total replacement surgery, it improves the quality of life and relieves the pain, restores the function, and increases the functional mobility of your patient. If you are considering the joint replacement surgery, you should always have an open, honest discussion with your surgeon, with the surgeon who you are contacting about, but never setting in high expectations. The moment you set high expectations, the patients after surgery will be dissatisfaction. That is one of the most common complications we are facing these days. The moment you say the knee replacement surgery, they have a lot of options, lot of surgeons, lot of hospitals. So each surgeon will have his own way of telling, but that is the reason they'll be superstitious, semi-informed, and suspicious. This is the normal arthroscopic view of a knee joint. This is the femur, and this is the tibia, and this is the meniscus. This is how a normal knee joint without arthritis looks. But in a stage 2 arthritis or stage 3 arthritis, you can see the cartilage is frail and you can see the meniscal tears. That's the reason they cannot squat on the floor or climbing up staircase. And in stage 4, you have severe meniscal tears, degenerative tears, where the moment they sit and get up, it will be moved. They cannot even walk. So usually we give a spinal anesthesia or epidural anesthesia, and this is how we position our patient. And this is what a knee replacement looks like. What we do is 8 to 78 millimeters of bone is cut on the femoral side, and we implant the femoral implant, and we cut around 7 to 9 millimeters depending on the tightness of the knee, how much we want to cut on the table. And in between the femoral component and tibial component, we put a polyethylene. This polyethylene is usually it is a very tough bone, tough poly. It is highly cross-linked, so it can bear a lot of pressures on that. This patient is a young patient, not a 60 years patient with severe knee arthritis. There is not much of a deformity, but severe arthritis. The medial compartment shows less. It's almost touching the femoral part. Is the medial side is touching the tibial part on the both the medial side. And this is how a knee replacement looks on the table. This is the femoral component, metal, this poly and the tibial component. But the patella can be replaced or cannot be replaced, depends on the table how you decide. But most of my patients, I never do a poly for it. We don't replace a patella. And this is how it looks, normal knee, primary TKR, how it looks. So the simple knee replacement patient, this is how it looks. And this is, you can correct your alignment is correct, your knee joint varus or valgus deformities are also corrected. This patient, 62-year-old, she is a patient with a CABG, she's having diabetic, hypertensive and all those, even renal problems. She was walking with walker, and this is how it looks. So I explained to the patient that you have, besides all these high risk factors, if you are willing to go for surgery, this is the best option for you to relieve and do your activities of daily living. So we went ahead with the surgery, and this is how it looks. Now this patient is a 63-year-old male. This almost is a 6'2" height and overweight person. And this is how it looks. Is a varus complete deformed knees. Okay, it's almost 10 to 20 degrees. Left is more, and this is how it looks post-operatively. Is doing fine. This patient, but once the patient is operated, he is no more. He's operated. He is no more a patient. He is now very impatient. He starts bothering you. He says, oh, "You have done surgery. You have paid 2 lakhs for you. Why should I exercise? I'd rather watch my wife and my TV." They just sit and idle. They don't do any exercise. That's the reason we have to mobilize the patient pre-operatively. We have to tell them that pre-operative exercises and post-operative exercises until they die, they have to do after knee replacement surgery. Because if you allow the patient, if you tell the patient and motivate them to do the quadriceps strengthening exercise, it decreases the load on your implant also. So to reduce the complication rates post-operatively, you should always see that the patient is fit by reducing the weight and do not allow them to squat on the floor, minimize the staircase. The first myth after most of the patients surrounding the knee replacement surgery, after TKR, you have to be in bed for 3 months. This was almost 30, 40 years back. They used to almost keep the patient on bed only for 1 month or maximum 3 weeks. And in the 90s, patient used to be mobilized with walker, non-weight bearing. But nowadays, immediately the patient is motivated enough. Even in the morning, if you do the patient surgery, evening you can mobilize with a walker. The common myth is, these are the patients, they feel that once your surgery, we will be bedridden for a few months. So this is how we mobilize the patient after knee replacement surgery. The second myth is, after TKR, one should not or cannot climb the staircase. You can the males, usually we can ask them to even 3 weeks or 4 weeks. Female patients, we usually tell them 6 weeks to 8 weeks, depending on their confidence levels. Now, the third myth is, this surgery is, I'm almost 60 years or 50 years, or I'm too old for operation. Some patients, even 45 years or so, they severe arthritis occurs because of rheumatoid arthritis. Some patients, even with osteoarthritis, just 45 years because of the genetic factors. So they go for surgery. It is not that the surgery even 80 years or even 90, the patients who go replacement in life for 90 years also. So I'm too old. Who said that? So the patients, my patient is almost the last patient we have done around 82 years of age. And this is the common problem we are facing in India. I mean, my patients, my neighbor could not walk at all after surgery. But this is the commonest problem. Maybe the patient might have some other problems, some other medical problems, or the patient is not even motivated to do. Some patient, and most of the common complications we see is psychological problem. And this is replacement surgery is being maybe better than lying down. This is the way they used to treat almost 60 years back in Western countries. They used to fuse the knee joint by putting a POP cast. There may not be a pain, but the patient functional, there will be no functional this thing. The third thing is, fifth one, the complication is too costly. Facilities are not good in India. Anyway, operation is not successful. And nowadays in Andhra Pradesh, monthly almost 1,000 surgeries are being done all over the state. The sixth myth is, I am too fat, implants might break. Whatever the age, it is not the problem. Any age, any amount of this thing, but most of the patients, overweight patients, obese patients, we have to be careful of the infection parts. Implants will not break just because of your overweight. And the thing that immediate post-op physiotherapy should like a physio-terrorist. And I always tell my patient, I do the surgery. It is you have to get the physiotherapy. My part is 50%, your part is 50%. So to take the help of a physiotherapist. I have given you a new motor, and you should get the petrol from your muscles. The more you strengthen your muscles, the more advantage is the pain will decrease, your muscle strength will increase, bone pain will come down, your blood circulation will improve. And what is computer-assisted surgery? These days we are reading from last 10 years about navigation and robotic surgeries. Computer navigation surgery is, it tells you how much bone you have to correct, or your alignment, how it should be. Only to preserve the amount of bone you want to cut and your alignment also. This helps. But once it comes to robotic surgery, it gives a more, once it takes into account alignment, and second thing is amount of bone you cut by your hand will be less. But I don't use any robo. And these are the patients where we can, with this navigation or robotic surgeries, may be useful. These are the patients with a very severe valgus knee or severe varus knees. Good results can be obtained with a robotic and or a navigation surgery. And the post-op TKR pain this is the most problem. Once the knee replacement surgery is their patients, initially they may not have any problem, but certain patients to start up that they have this implant loosening might be because of the osteoporosis. But we do have complications. We do every 100 patients, we have one patient of complications. And the causes of complication might be because of aseptic loosening. That is the most, almost nearing 30%, infection 14%, instability. And the fourth most common is the patellar extensor mechanisms. Your quadriceps mechanisms might be disrupted, or patellar tracking or uneven patella also can be one of the common causes for revision. So the timing of total joint replacement failure can be early or late. Early complications might be like in a knee replacement also can be dislocation, because patients might have trauma or wear of the articular bearing surfaces, osteolysis, mechanical loosening, or a periprosthetic fracture. And this is one of my patients, and this patient is my first patient I faced in 2014. This patient was done by 2007. We have done a replacement. He was doing well. He was a farmer, but he fell down in his while he was working. So he sustained this fracture of the medial condyle along with the tibial base plate. So we had to remove this implant. We had to remove the tibia, the poly, and even the femur also we had to remove. And we had to reconstruct the entire femur by using a revision knee system. The patient is doing fine. And recently he has again come with a second knee loosening also. This patient was, the patient is a known patient of cardiac problem. Just before, when he came to me for knee replacement surgery, he had this problem of cardiac problem. So we referred to a cardiologist. Stenting was done. After stenting of 3 months after that, we done a TKR for this patient. But this patient, after 2 years, almost 3 years, he came back with it. He was calling me and saying a lot of pain. He was in Bangalore. So I asked my teacher in Bangalore to see. So sir said he is having some subclinical infection. So sir, ESR was very high. So then the patient went to Guru Reddy in Hyderabad. Then finally he came back to me. The moment I started an IV antibiotics, and initially I never saw the lesion here. Can you see the lytic lesion? Just this is the pocket of pus in the bone, just adjacent to the metal. So there is sinus started. So we had to mobilize the patient, motivated him for a revision knee, and this is how it looks post-operatively once you remove the implant. So we had to go for a revision surgery after 8 weeks. Once the ESR and CRP have come to normal, I have done a revision knee replacement. This patient is one of the common. This patient is especially 60 years of age or above. She is almost more than 65 years. While she was coming to a knee replacement surgery, she fell down in the house. So she sustained a fracture of the femur. So we had to do a plating. And this patient, I had to do a handheld navigation, disposable navigation, because to get an alignment, we usually use a rod into the femur. So to avoid that rod, because we have screws, so I had to use a navigation. And this patient is a patient from Orissa. Post-operatively, this patient had a difficulty in bending his knee joint. So it was operated initially for compound fracture, and he was put on external fixator, and he had a stiff knee, and he wanted a function and pain-free. Though he is relieved of pain, he wanted some function. So I explained the risk, because it's very difficult to do these type of surgeries. So we had to remove the entire patella, the quadriceps. We have to release entire quadriceps up down the femur, and with difficulty we have done a knee revision, but we had to revision surgery. And post-operative, immediate post-operative, this is what he got after 1 week of surgery, 80 degrees. But patient he was happy with that. This patient, usually most of the replacement surgeries, when she came to about 64, but she had early arthritis at the age of 45 or 44. It was done, and It was done in Hyderabad, but she came with a loosening of the implants. So we ruled out infection because ESR, CRP were normal. So this is how it looks when we open the knee joint. Once the knee is painful and without infection means we have to think of metallosis. The metal debris releases onto the bone and soft tissue. The more metal debris, once it is loosened, metal debris is out into this tissue, the more loosening of the implant because of the lysis of your bone. So we had to remove the implant and we had to clean the entire bone. This is a post-op. See how much of debris of bone. We had a lot of femur. There is no one side femoral conda. We didn't have much of a bone. So we had to do a revision knee. And this is how a revision knee looks. And this is post-operative X-ray. This patient is a case of infected trachea, one of the most dreaded complications we are facing now, because once the patient also, one of the reasons will be a patient, other thing is our hospital. And this patient was operated in Bhubaneswar, and we had to do, once this is how, can you see the left and right? Right side is, you can see the femoral loosening is there. So initially they have already done, before coming to me, the patient has already gone somewhere, they have opened the joint, cleaned with, and they have debrided, but still there is a post-operative loosening. So we had to remove the femoral components, tibial components, and this is the bone, amount of bone we have cut, and this is post-operative X-ray. Now this patient, just 2 years back, post first COVID wave, patient came with a pain in the severe knee joint pain, and there was no patella. Patellectomy was done because this patient had a infective arthritis because of tuberculosis. So because of tuberculosis, this, can you see the knee joint here is almost worn out there completely. The medial condyle, you can see irregularity. But still, second, post-patellectomy surgeries are a little difficult because we don't have patella, and we have to be very careful of retracting your patellar tendon. If the patellar tendon ruptures again, you have to reconstruct the extensor mechanism. So 2021, I think we have done. The patient was doing fine. Regularly, she was following me. This is the post-operative X-ray. But just in April, this year, April, she came with history of injury, but arthritis has flared up, and tuberculosis, the infection has flared up. So I had to remove the implant and put a cement spacer. Lot of pus was there. So for almost June, 2 months, we have put her in AKT. ESR CRP has come down. Just yesterday only, we had to, we have done this surgery. And this patient post-operatively knee X-ray, knee replacement was done in 2016. This is a case of acute infection. Immediately after surgery, bilateral key care was done. So, but the patient was not a diabetic patient, but somehow the left knee got infected. So we had to remove the implants. We had to put a cement spacers, but ESR CRP was not coming down. So after the first surgery, we had to do 4 times. We opened the knee joint 4 times, 2 times we had to change the spacers until the spacers, and we have to routinely keep on washing with the vancomycin infection, because first time when we have done culture sensitive, there is no organism. Second time when we have seen, we got a Pseudomonas and Klebsiella. So we had to do 2 times of wash before the final implantation was done. So gradually ESR has come down, and this is the post-operative look. And after 5th time of surgery, we have done a revision knee. What evidence is? BMI as a risk factor. Its strong evidence supports that obese patients have less improvement in outcomes with total knee. Diabetes is a very high risk factor. Moderate evidence supports the patients with diabetes high risk with complications of knee, especially infection. Depression, there is a limited evidence supporting that patients with depression and anxiety have less improvement in patient-reported outcomes with total knee replacement. And pre-operative physiotherapy definitely helps in post-operative pain relief and the function of a knee replacement surgery. And delayed total knee replacement, can be delayed. It is not so emergency that we have to do immediately. Certain patients, we might say today that you might need, but they might come after 8 months or even 1 year for knee replacement surgery. Peri-articular local anesthetic infiltration after total knee replacement definitely decreases the pain and opioid use. And nerve blocks post-operatively, these days our anesthetists are giving adductor canal blocks. The post-operative pain is patient are improving psychologically. And because of the spine, earlier it was spinal anesthesia, now we are more concentrating on epidural anesthesia. And this improves definitely the selective perioperative outcomes. And blood loss reduction also, tourniquet, you have a clear picture of the knee joint where your bone is cut, and blood loss also can be reduced. And tranexamic oxide also reduces the bone. And antibiotic cement definitely reduces the chance of knee replacement surgery. And there are different types of knee replacement implantation, like cruciate retaining, where we can retain the posterior cruciate ligament. But nowadays, most of the patients, if you retain the cruciate retaining, but not every surgeon does a cruciate retaining arthroplasty. We are removing the cruciate and we are doing arthroplasties. And the polyethylene tibial components, definitely nowadays, all poly to the modular tibial components, definitely we have a better outcome. Patellar surface depends. Certain patients we do and certain patients we do not do, but most of the times we don't do also. The pain and function, patients are comfortable. Cemented replacement is the most commonest part we do, but cementless tibial components and the cement femoral components, they just come into the market. We still don't have clear data. Bilateral knee replacement definitely is having a high risk. I usually don't do knee replacement bilateral on the same day, unless it is below 45 years or 50-year patient. I usually take 3 days gap and do, or 3 months to 6 months we can wait. And peri-articular local surgical navigation supports, strong evidence supports that using intraoperative navigation in total knee replacement, but there is no difference in outcomes in complications because still a lot of research is going on. Only for severe varus greater than 20 degrees or valgus greater than 20 degrees, we can use navigation to get a good alignment. And patient-specific instrumentations, it depends. For a female, you can get a better, or a male patient. Patient-specific instrumentation we have been using, but not much in India. Drain definitely is recommended, and post-operative mobilization and the length of stay. On the day, evening, if you do a replacement surgery, if you mobilize the patient in the evening or next day morning, make them step psychologically, a lot of moral boost up. At least he stood up, and for successful 3-4 days, once you start mobilizing them, the psychological pain comes down. The post-operative knee pain also comes down, and usually early stage supervised exercise programs definitely improves the function of the knee joint post-operatively after total knee replacement. But the most unhappy patient will be psychological, because psychological factors, because pre-operative depressive patients or more of a hyper anxious patient, psychological distress or unrealistic expectations of post-operative benefits like pain relief, mobility, independence from the consultant it should be avoided. And to avoid infections, because that is the most dreaded complications almost world over is facing, infection. So we have to take care of the OT environment. You have to educate your OT personnel, educate your patient before surgery, and encourage your patient the importance of physiotherapy post-operative. Definitely teamwork helps. Thank you.
Dr. Varma Garu, it's an excellent talk. In India, we regularly see a lot of OADs.
Yes, sir.
Once we advise the general public, they start telling all kind of complaints. You explained nicely myths and facts, what all to be we face for the TKR, for undergoing TKR. And along with that, really explained very nicely in a complicated infected TKRs, what is to be done and how it is being followed and what all, how we are benefiting patients. Anyway, we congratulate for your excellent talk.
Thank you, sir. And thank IMA and Dr. Ramani Madam for giving this opportunity.
Thank you so much, sir. We now have our last speaker for the day, Dr. V.V. Rajshekhar, who will be presenting on scope of minimally invasive surgery in orthopedics. Sir, are you ready? So kindly unmute yourself.
Yeah. Are you able to see my screen?
Yes, sir.
Yes,
Yeah.
yes, right.
We are able to see your screen, but it's half cut, sir. If you can.
Half cut. 1 sec.
To pull it to the center and drag it.
Is it?
Sir, is it a PDF that you are trying to show, sir?
No, that is no, that's a PPT only.
Okay.
Now it's okay.
This is fine, sir. Go ahead, sir.
Yeah, is it visible now?
Yes, it is visible, sir.
Yeah, 1 sec. 1 second. Just coming back.
It has gone again. The same.
Next slide. You put next slide.
Is it the same?
Yes, sir. It is half cut.
Okay, 1 second. Just try. I'll try again.
Yes.
Now?
Yes, sir. It's visible. Yes, sir. It's fine.
Yeah. Okay.
Yeah.
So, good evening, everyone. Good evening, everyone. Thank you, IMA and Ramani Madam, for giving me this opportunity to talk about a newly advancing part of orthopedics, that is the minimally invasive surgery in orthopedics. Good evening, Jai Shekhar sir, Verma sir, Manikumar sir. See, minimal invasive surgery, as in other parts of the surgical branches, in orthopedics also it has been a very prominent one, because the advantages of minimally invasive surgery are always pretty clear, that it gives us a benefit of early patient recovery. But firstly, I would like to say one thing, that the minimal incision surgery is not the same as minimally invasive surgery. Firstly, because what happens is, if we keep a small incision and we retract the soft tissue so much and cause damage to the soft tissue, then that will never be a minimally invasive surgery, because we are causing more harm than good by doing such a minimally incision surgery. So then what is minimal invasive surgery? Minimally invasive surgery can be defined as a one which has reduced operative traumatic insult, but the therapeutic benefit is still maintained. So a minimally invasive surgical procedure should be defined as one that is safe and is associated with a low post-operative patient morbidity compared with a conventional approach for the same operation. Minimally invasive surgeries per se started with cystoscopy initially, and later the same Watanabe from Japan has started with the arthroscopy as well. The advantages are it has reduced soft tissue damage, decreased pain, decreased blood loss, faster recovery, lesser hospital stay, and finally a smaller cosmetic incision, which is not the prime purpose of minimally invasive surgery. Coming to minimally invasive surgery in orthopedics, we do use minimally invasive techniques in every subspecialty of orthopedics, might be in trauma, in joint surgeries, and also in spine surgeries. In trauma, it is all possible because of the advanced technology, like the imaging modalities of in the OR or outside the OR have been very, very good. Like the C-arm or O-arm, which is available in the operation room, will help us to give a minimally invasive surgery and do surgery with a closed method. And the better instrumentation which is compatible with these closed methods has also come into vogue. And the newer implants which are easy to fix through minimally invasive methods through a small incision and getting in is also possible. So earlier days, the concept was also different. The concept was mainly to give absolute anatomical stability. The absolute anatomical stability is that we have to address every fragment, hold it, denude it, clear it of all the muscle and periosteum, hold it, and then fix it with a rigid fixation. So that used to be the in vogue before, like with plates and all. But nowadays, the biological plating has come into picture, where the concept of minimally invasive plate osteosynthesis and minimally invasive percutaneous plate osteosynthesis are being done. Like, see, this is a distal tibia fracture which is being fixed from a small hole where we are elevating the periosteum and just sliding the plate underneath the skin and fixing the screws through these small holes. So this will help us to avoid the possible complications of denuding the bone and preserving the muscle attachments for blood supply. And also the fixation of the intramedullary nails have also come up. For example, this fracture, which is an intertrochanter fracture, earlier days we used to open it all almost the mid thigh up to mid thigh and fix with a DHS, which is an open fixation. Now, with the advent of the intramedullary nails and CM, with the small incisions like this, making an entry here, pushing the nail in, and we can lock it through the other small holes. And coming to the minimally invasive surgeries that are happening in joints, earlier days this used to be the fixation for the open ligaments. The joint was completely open, the patellar tendon was incised and removed, and then the tunnels were placed, and then the graft was passed to fix it. This is an ACL reconstruction surgery in earlier days when the ligament reconstruction was done openly. But now with the advent of arthroscopy, as you can see, these are the two portals, the anteromedial and anterolateral portals, and this is the area where we remove the graft and fix the graft through. So this is how it has changed from here to here. With this, we can put our tunnels in the right place. We don't have to open it. The rehab is very fast, and they can get back to their sports even. So this is how in arthroscopy it looks. This is the posterior cruciate ligament. This is the anterior cruciate ligament. This is a normal. This is from the tibia going and attaching to the lateral condyle of the femur and the inner side. And this is how, if it is torn, it looks like this is the tibial attachment is intact, but the femoral attachment is gone. It is torn. And this is how we reconstruct it with the help of a soft tissue graft. There are other grafts as well. The soft tissue graft is the most common one that we use, the hamstring graft. And even earlier days, it so used to happen that patient was complaining of knee pain, not amenable to anything. If you can see the X-ray, nothing is shown. And later the MRI has come, but still the MRI also says there is no problem, because we are not specifically looking for a cartilage issue by mapping the cartilage. In such a case, if we go inside, sometimes it can be an accidental finding that you find these kind of cartilage loss. And there the arthroscopy works well. We debride the unstable flaps of the cartilage, do this technique called microfracture, where we open the subchondral marrow, and this is how the stem cells pop up, and we try to regenerate the fibrocartilage. So this is the advantage of the minimally invasive surgery that has come up in orthopedics, knowing the exact problem. And many a times we get to see that MRI normal, X-ray normal, but still patient has pain. Then if we go from the posteromedial portal, we see a ramp lesion, and there are other kinds of lesions which are not visible or through normal investigations. And coming to the newer topic, that is joint preservation. Earlier days, as Dr. Verma sir was saying, earlier days it used to be different, where the patient was even in his late 40s or early 50s. It doesn't matter. There is only one option: either you have to suffer your knee pains, or you have to get your joint replaced. But later, the joint preservation, the concept of joint preservation has come up from the last 15 years abroad, and from the last 5 to 10 years in India also, where we are trying to preserve his own joint through all these minimally invasive techniques rather than replacing it with injections like hyaluronate injections, which is synthetic injection that we give for lubrication inside the joint. And the latest happening is PRP, that is platelet-rich plasma, which we take it from the patient blood itself and try to inject with the joint, which acts as an anti-inflammatory properties, and also with the as a nidus, and it attracts the growth factors into the joint and helps in regenerating the cartilage. So, and as you see, some are best when preserved. A native knee is always the best that if it can be preserved. So whenever possible, we try to preserve it. So for that, the most important thing is alignment. As you see, this is called a scanogram, where we get it done from the pelvis up to the ankle level. We see the axis, the weight bearing axis, which goes from the center of the head of the femur to the ankle. Normally, this goes into the center of the knee joint. But in case of varus knees, that is bow legs, we see that the weight bearing axis goes medial to the knee, or mainly on the medial side or onto the medial of the knee. And in case of valgus knees or knock knees, the weight bearing axis goes to the outside. So this gives us an idea of what is happening and where is the problem. And then depending on, see, if the patient comes to us at this stage where the lateral compartment looks normal, but the medial compartment is only gone, in such a case, if his age is less, if the other parameters are all fulfilled, then we do an arthroscopy simultaneously, see the lateral compartment whether it's intact or not. And if the lateral compartment is normal and only the middle compartment is involved with varus, then what we do, what is called a realignment osteotomy. So in this case, if you see, he has a bow legs with the varus, tibia is in varus, and this is how the joint used to be, with more compression on the medial side. So we do an open wedge osteotomy like this and make the knee straight. So changing the axis of weight bearing from the medial side to the center or onto the lateral compartment of the knee. So this is regional realignment surgery, and with this HTO or high tibial osteotomy, we can almost get 5 to 10 years of his lifetime to his native joint. And also the other minimally invasive thing that is being done for osteoarthritis in knee joint is unicompartmental knee replacement. As we know, the majority of the times it is the medial compartment which is involved. So what we do is we replace only the medial compartment with these unicondylar knees, and it works for another 10-15 years. If necessary, we might have at any point convert into a tricompartmental knee or bicompartmental knee too. This is about joint surgery. In spine surgeries, again, the wedge compression fractures or burst fractures in old age degenerative spine, as you see, is a very big problem. Patient is not relieved of pain. Earlier days, we used to put him on braces, give him on traction and all whatnot. But nowadays, with the advent of minimally invasive techniques, through injecting the bone cement through the pedicles into the fractured vertebra, this is called vertebroplasty. If we do this, the patient's pain is relieved mainly, and the patient is comfortable. And also, one more advance that is happening in the field of spines is the transforaminal nerve root blocks. What happens is in this, it used to be earlier days where we used to give an epidural steroid, which is diffuse, which is not going to the location per se. But with the advent of the imaging modalities and techniques like this, we see this, we locate the nerve root exactly where it is being compressed, and we put through our epidural needle and we give a transforaminal nerve root block, and this works like a magic. Patient who comes to us with that inability to walk just walks back from the OT. So that is a thing. And if necessary, if we can, and disc surgery is needed, then we have a microscopic discectomy or endoscopic discectomy also. Through a microscopic discectomy can be done with the help of a microscope that needs anesthesia, whereas endoscopic spine is done under local anesthesia, where we just introduce a endoscopic sheath, and we put a endoscope, and also instruments also go through the same sheath, and with a simple one incision we can clear it off at a single or even 2-level discs are also being done with endoscopic discs now. Percutaneous pedicle screw fixation. Percutaneous pedicle screw fixation is also being done for fixation. This is the advantage of having navigation techniques also inside the OT, where we can get our pedicle screws right into the place where it is. So these are all the advantages and newer techniques which are happening with minimally invasive techniques in orthopedics. And with the advent of all these things, the old saying of being an orthopedic patient, you need to lie in bed for days together, and for you to get back to your activity, it is taking months. It is no more true. With the latest minimally invasive techniques, we are getting the patients back to their feet on day 2 and getting to the activities by 3 weeks. So thank you for your patient listening, and any questions? Yeah.
I think no questions. So it's an excellent talk by Dr. Rajshekar. He is also EC member in Orthopedic Association. And olden days used to be not more. You are considered to be, you have done a very big surgery, and then moreover you are supposed to be a big doctor. And of course, nowadays things have changed, and Dr. Rajshekar said principles have changed a lot. And with this minimal invasive surgery, minimal anatomy is disturbed, and the recovery is also very fast. So anyway, excellent talk, Dr. Rajshekar, and I congratulate on behalf of IMA AMS for giving this excellent talk. Finally, I want to thank Ramani Madam, also congratulate her for conducting this excellent 2 days online webinar, Madam. Anyway, excellent job, Madam. Really good informative talk. Thank you, Madam.
Still, we have 428 people on board, sir, listening to the talk and your moderation. Thank you very much, sir. And tomorrow we shall meet by 8 a.m. again, the next day. I thank all the moderators, speakers, Dr. Rajshekar, who is my student, giving such wonderful talks. I'm very much.
Yes, Madam. Young, dynamic orthopedician, Madam, coming up. We can see him in future days at still more higher levels.
Thank you,
sir.
Ramesh, sir, tomorrow.
Thank you. Thank you all the moderators and speakers and the delegates for holding on. I should first congratulate Ramani for selection of the topics and the wonderful speakers who really made it lively till the last talk. Thank you all for this patient hearing, and I hope we'll have another feast tomorrow too.
Yes, sir.
Thank you. Thank you for the evening. Yeah.
Thank you, sir. Thank you.
Thank you, madam. Thank you, sir.
Thank you, sirs. Thank you, madam. Thank you, everybody. We have concluded our first day, and tomorrow we shall be starting by 8 o'clock with our first speaker as Dr. Narasimha. And thank you, everybody. Let's conclude here.